access to the brain from the tumor, the network. This type of a nodular wall, you never see access will have a regular wall. It will have a regular wall. It will never have a irregular wall. Next is CNS lymphomas. Primary lymphomas are there two types, primary and secondary. Most common primary diffuse large B-cell of the CNS. These are the second most common primary brain diseases after gliomas. So, what the most striking imaging finding to identify a CNS lymphoma is a hypertensive nature. In a CT, in a plain CT scan, it will be appearing brighter. That is hypertension. See, this is the non-contrast CT. That is, there is no contrast here, but still you can see it round, large lesion to the frontal lobe, which is brighter compared to the basal ganglia. So, hypertension intra-axial lesion in the left frontal lobe here is a classic case of lymphoma. See, only few intra-axial lesions are hypertension. One amount in the lymphomas. And you can see the vaccinating edema also surrounding which is appearing hypertension. Next is the MRI imaging findings. Whatever I have explained, the same thing with the here as previous slide. Again, here, this is a bifrontal lesion here, the round lesion. The lymphoma, under striking picture of the lymphoma is it is relatively T2 dark. This is the T1 sequence. So, here sequence. This is the T2 sequence. In the T2 sequence, you see a dark area here. Compared to the basal ganglia, it's dark. Why? Because of increased cellularity of the lymphoma, it appears to be hypointense. It is again a striking feature of the lymphoma. These are the post-contrast images showing the intense enhancement. That's a high-grade area. Next are oligodendroglioma. The most striking imaging finding of oligodendroglioma is predominance in the frontal region, doctor in the frontal region, and the presence of calcifications. A tumor in the frontal lobe with calcifications in an adult, in an elderly patient, almost covered in oligodendroglioma. It is one of the kind of low-grade tumors. And yeah, this is the plain CT image. It's a plain image. Second is the post-contrast image. In the plain image, you see there is a defined hypertension here. This hypertension is the calcification here. So the frontal region tumor with the calcification is oligodendroglioma. It's a very classical diagnosis. And next is the post-contrast image. You can see the two extent of the lesion here, which is enhancing lesion. So calcification is not seen here because of the entire tumor starts to enhance. The calcifying density and the tumor density becomes the same, so you are unable to see the calcification. So you can always see the calcification better only at the plain scans rather than the post-contrast scans. So it's the oligodendroglioma. This is the MRI image. First is the rear image. You see a right frontal tumor here in the right frontal parametric region. The second is the T2 image. Third is the post-contrast tumor image. Again, oligodendrogliomas are poorly enhanced lesions. That's why it's compared to the low-grade lesions. It is not enhanced much here. But the fourth image, that's the GRE sequence. I mentioned in my starting when I started this lecture that the GRE sequence will identify areas of calcification. You can see the dark foci here. Okay, those are chunks of calcification that's seen in the tumor. So oligodendroglioma will almost always have calcification. That's how radiology will identify and diagnose the oligodendroglioma. Next, posterior fossa tumor. In posterior fossa tumor, the most cellular hemangioblastoma is a benign tumor that occurs in the posterior fossa, especially to VHL patients. The one you will encounter it. Hemangioblastoma is actually a capillary hemangioma. It's intracranial. 95% in the posterior fossa, 85% cerebellar hemisphere. So, what is the classical appearance in a CT? The mural nodule is isodense to the brain on non-contrast scans with fluid density surrounding the cyst. Post-contrast, intense homogeneous enhancement of the mural nodule is seen. The cyst wall do not usually enhance. Calcification is not a feature. I'll show this in the images. So, this is the CT scan. It's a plain CT scan image, axial section. You see a round lesion in the posterior fossa. Again, posterior fossa means it's infratentorial, below the level of tentorium. And you see area here, which is brighter compared to the rest of the lesion. So, in a cerebellar hemangioblastoma, two components will be there. There is one cystic component and a mural nodule that is eccentrically located. I tell you what. Yeah. Okay. This is the post-contrast image. You see the mural nodule starts to enhance here, but this is what doesn't enhance. the tumor, only the neural node is enhanced, the cyst wall doesn't enhance. So this helps us to differentiate this cellular cholangiocarcinoma from pyelocytic astrocytoma, where the wall of the cyst will enhance, here the wall of the cyst doesn't enhance. So it is slightly differentiation. In a cellular cholangiocarcinoma, only the neural node is enhanced, the wall doesn't enhance. Contrast this with the pyelocytic astrocytoma, where the wall will also enhance along with the solid component. So I'll talk you straight to see that. So what are the MRI imaging appearance? On T1, the cystic component appears hypointense. The mural nodule can be hypointense to hypointense. And the post-contrast T1 sequence, the mural nodule shows vivid enhancement. Cyst wall does not enhance. On T2, the mural nodule appears hyperintense. Fluids are seen to be enlarged vessels next to it. Fluid filters similar to the seen in a T2 sequence. This is a set of images showing cellular cholangiocarcinoma. First is a T2 sequence. Why is the T2 sequence? You can see the fluid that is bright here. You the whole SST component and you have a mural nodule here. Next is the T1 sequence. Third is the post-contrast sequence. You can see the wall of the cyst is not enhancing. This is a saturated image. Only the mural nodule is showing very intense enhancement. So once the wall doesn't enhance, you see only a mural nodule. You have only one diagram, that is cellular cholangiocarcinoma. There is no custom. But the moment the wall is also starting to enhance, you have to think about pyelocytic astrocytoma, which will have very similar appearance. Both these tumors will have very similar appearance, except for the wall enhances in an astrocytoma, not here. Pyelocytic astrocytoma, also known as juvenile pyelocytic astrocytoma, typically occur in young patients. The majority of sporadic pyelocytic astrocytomas arise from the cerebral. Pyelocytic astrocytoma range in appearance in CT. Large cystic component with a brightly enhancing neural nodules. Enhancing wall seen, cyst wall seen 46%. However, non-enhancing cyst wall is also seen in 21%. So imagine a dilemma of a radiologist. You see a lesion and there is non-enhancing wall, you are the enhanced pyelocytic astrocytoma. But in 21%, sorry, enhanced cellular cholangiocarcinoma, the biopsy report will be pyelocytic astrocytoma. So in a minority of cases, the wall can be non-enhancing also, but you can easily differentiate it. Why? In a cellular cholangiocarcinoma, the wall will be thin regular wall. In a pyelocytic astrocytoma, even though the wall cannot enhance, the wall will be steep and not that can be picked up in a place can be. So that's having a differentiating feature. Heterogeneous mixed solid and multiple cysts and central network leads. Pyelocytic astrocytoma can also be completely solid in some 10% of cases. An MRI, the T1 sequence, solid component appears hydroto-hypointense compared to the adjacent brain parenchyma. The cystic component is the fluid signal, T2 hyperintense fluid signal will be T. And the post-contrast, again, there will be a contrast enhancement, the cyst wall enhancement. That's the important point. So this is the set of MRI sequences showing pyelocytic astrocytoma. This is the T1 saturated image. You see a round lesion here. What is it? Intra or extra lesion? PG? Intra-axial lesion. Which is it supratentorial here? No, it's infratentorial. Why? Because this is the tentorial that you see here. You see a round large lesion here. And this is the plate sequence. Again, you can see the northern solid component. This is the post-contrast image. You see the thin cyst wall here, which is enhancing wall. Okay, you see a thin cyst wall, it's an enhancing wall, and a large northern component, and the cystic component which is not enhancing. So, okay, for the tumor with an enhancing wall, irregular wall, northern wall, with big application, it's almost always zonal pyelocytic astrocytoma. Next comes the medulloblastoma. Again, it's the second most common malignant brain tumor of childhood in children. And on CT, medulloblastomas often appear as a mark arising from the vermin, resulting in effacement. Effacement means compression. In CT reports will always use the word effacement. Effacement means it is getting compressed. Effacement of the whole ventricle, basal system, and thereby it results in obstructive hypertension. They are usually hypertense and cyst formation and necrosis is formed. On MRI, the T1 post-contrast sequence, 90% of the T1 enhanced. And T2 sequence, you can observe the application necrosis and cyst formation. In DWA image, that's a diffusion image. This tumor to restricted diffusion. Again, this is the most important. Because the high cellularity in medulloblastoma is restricted diffusion. Just when I started the lecture, I told you, whenever there is a high cellularity tumor, it is also restricted diffusion. So a tumor showing a restricted diffusion in a childhood in a posterior forearm within the fourth ventricle is medulloblastoma. This is the CT image, sagittal reconstructed image. You see a round lesion here. This is for people who are not trained. This may not look very obvious, but see, same region as the post-contrast image. It's a brightly enhanced region within the fourth ventricle. This is the fourth ventricle here, this triangle that you see. So basically, the tumor is within the fourth ventricle. It is within the fourth ventricle. It is arising from the one. This lesion is an intraventricular lesion and it is causing compression of the fourth ventricle and this dilated triangle structure is the cerebral aqueduct of Pyrrhus. This is third ventricle, this is lateral ventricle. The entire upstream of the CSF flow is obstructed. It is called obstructive hydrocephalus. This is the MRI image of medulloblastoma. This is the T2 sequence. The large, round, well-defined infraventricular margination is here in the fourth ventricle. This is the T1 sagittal image. This is the T1 axial image. Enhancement is not intense here. It is showing tiny areas of enhancement, but it's a solid tumor. You can observe from the T2 sequence here. There is no stage here. Again, this is section that is taken above the level of endorin to see the hypocephalus that is started. These are the dilated lateral ventricles. You see here, two dilated lateral ventricles are there. Here, third ventricle is dilated. Tumor is fourth ventricle, within the fourth ventricle. So it is causing obstructive hydrocephalus. So in this condition, a neurosurgeon will immediately first leave the obstetric approach and drain tube into the lateral ventricle. Then only there goes for surgery. So ventricular stent will do. So this is medulloblastoma. Next is CP angle tumors. CP angle tumors is cerebellopontine angle tumors. Commonly, you will read a report CP angle lesion is seen. So where is the CP angle? You can see here. This will be cerebellum. This is the posterior fossa, second and posterior fossa. This is the pons. An angle is seen here. That is the CP angle. An angle between the cerebellum and this pons. That is the CP angle. Few set of tumors occur in the CP angle. Most common is acoustic schwannoma, next is epidermoids, next is meningioma. These are the commonest tumors that are seen in the CP angle region. On the left side, a well-defined region is seen in the left CP angle, which is protruding into the left internal acoustic meatus. What is the internal acoustic meatus? That is where the stomachache nerve complexes extend into the internal ear. See the other side, the normal internal acoustic meatus filled with CSF is seen. But the other side, the CSF is so it's an acoustic. Even in one, it's a straightforward diagnosis. Vesicular tumor cochlear nerve represents 80% of CP angle lesion. On imaging, it actually presents as a solid nodular mass with an intraventricular component results in widening of the porous acousticus. What is porous acousticus? It's right up opening of internal artery meatus. That's the porous acousticus. Because the tumor is going into the internal artery canal, the widening of that point. So that's actually imaging picture of acoustic structure. On CT, the region shows erosion and widening of the internal artery canal. Density of this tumor are non-contrast variable. For example, this can have a soft appearance. Necrosis will have a hypertensive appearance. So there is a variable. The important finding is the tumor entering into the internal artery canal. On MRI, the region is slightly hypointensity adjacent brain or hypointensity fluid. It may contain one specific area. And T2 sequence, the region is hyperintense. Fluid intensity in on this areas are better appreciated. And peritumoral fragments can also be used. And post contrast imaging, contrast enhancement is intense in this region. Neuropathomas have a homogeneous enhancement. Schwannomas have a heterogeneous enhancement. That is the important thing. Neuropathomas will have homogeneous enhancement. That is, the entire tumor will light up uniformly. But schwannomas will have heterogeneous enhancement because they have calcification, they can have necrosis, they can have hemorrhage. In a schwannoma, all these three things are seen. So it has a variable type of enhancement, not a uniform enhancement. This is the CT axial brain image. First is the plain non-contrast image. Second is the post-contrast image scan. First image, you can hardly see the tumor here. But the moment the contrast is given, a well-defined round lobulated mark, you can see in the right CME angle. So next time if you come across the report that says the CME angle, at least you will have an imagination okay, where it is between the angle between the pons and the cerebellum. That's the area that's called the CME angle. This is the MRI set of MRI images. First is the T1 sequence, second is the T2 sequence, third is the post-contrast sequence. In the first image, a large extraction tumor lead. The second image, there is a heterogeneity. It's not uniformly hyperintense. And compare this internal artery meatus with the left side internal artery meatus. There is widening of internal artery meatus here. Here is the normal width of internal artery meatus. Why is widened? The tumor is extending into the internal artery meatus. This is the clinching point. Same thing goes with the post-contrast scan. The normal internal artery meatus is seen here where there is no enhancement. Contrast to the other side. Enhancing tumors entering into the like a triangle is protruding into the internal artery meatus.
लाइव वर्क करता हूँ
So, this is the classification of atopic trauma. Next is intracranial epidermolysis. Like an epidermoid anyway, it's a cholesterol-containing lesion. Within the CNS also, you get to see epidermoid lesion because the cholesterol low density lesion it appears as hypodense on the CT scan. It's a 3D axial brain image. We show the hypodense lesion, the peripheral wall calcification. On post-contrast imaging, hardly there is any enhancement of this lesion. So it's a classic case of epidermoid. So how to diagnose this? We tend to measure the density of the lesion. We have a software for that. It will show the fat density of the cholesterol. So the moment a fat density lesion is seen intracranially, it qualifies as an epidermoid. On MRI, it shows the receptor diffusion. Again, T1 will be bright because of fat sequence. Next, these are the set of epidermoid images. The receptor diffusion is seen in the third image, which is very characteristic of epidermoid tumor. In stellar and supracellular tumor, I will go to craniopharyngioma directly. Craniopharyngioma is the term which two separate entities. There are two types of craniopharyngioma. One is adamantine papillary type. In children, pediatric age group to see adamantine type. Generally, in adults, it's the papillary type. It involves both the stellar and the supracellular region. On a CT, it has both cyclic component and a colic component. The most striking feature is the peripheral calcification. I will show the next image. This is the adamantine type of craniopharyngioma that is seen in the younger age group. A round lesion is seen in the supracellular region. The peripheral wall calcification, which is appearing as bright, you can observe here. This is the peripheral wall that is calcifying. A supracellular region with the calcifying wall is the craniopharyngioma. So that's the most important differentiating feature here. Why is bone window is a coronal reconstructed bone window? It's shown here this a faint peripheral wall is seen here, the calcifying wall. Can look at the cursor where I know. So that's the calcifying peripheral wall, which shows that it's a craniopharyngioma. Peripheral wall calcification, supracellular tumor is a craniopharyngioma. Pituitary adenoma. The difference between a pituitary adenoma and a craniopharyngioma, pituitary adenoma will not have calcification. Craniopharyngioma will have peripheral wall calcification. Pituitary adenoma, there are two types. One is microadenoma, next is macroadenoma. Microadenoma less than 10 millimeter. Macroadenoma is more than 10 millimeter. As this will get macroadenoma, in on a CT scan, the lesion has a variable appearance. Solid component can be hypodense, which hemorrhage will become hyperdense. Calcification is very rare. So that's the striking differentiating point. MRI images, I'll just explain it here. This is the coronal MRI tumor sequence. This is the post-contrast tumor sequence. This is the glider. This is supposed to be the stellar floor. The stellar floor is flattened here because the tumor is extending from the stellar to the supracellular region. These are the optic chiasmas here. And the two round dots that are seen as the intercapillary arteries. Intercranial, intercapillary arteries. So the tumor is extending from the stellar to the supracellular region, compressing the optic chiasma here and encasing both intercapillary arteries. This is a post-contrast lesion. It shows intense enhancement. Macroadenomas are known to have very good enhancement. So it's a classic case of pituitary macroadenoma, differentiating point from bradycardioma, absence of calcification. This is the diagonal image. This is the triangle. This is supposed to be the pituitary area. It's completely, the pituitary is completely filled with large tumor here. This is the post contrast image. The entire tumor shows bright enhancement. This is the nasal pharynx. This area, this is the top pharynx. For surgery, for a pituitary adenoma, they use this route to remove the translunar root. That's what it is called as taking access and remove this tumor from here. So this is the translunar root. This is also important for us to mention in the report. So the region is the region, the solid region, pituitary macroadenoma. Next, intravesicular tumors, ependymomas. Ventricles are lined with ependymal lining. So a tumor that rises from the ependymal lining is called ependymomas. So most striking feature of the ependymoma is the plasticity. What's plasticity? Like how the ventricular system allows the space up to flow. This tumor will also go along the foramens, where from which it will arise from one area, it will go to the other area through these foramens. For example, there is an ependymoma within the fourth ventricle. Fourth ventricle communicates to foramen of Brusca and meningitis. This tumor, instead of completing brainstem and all, it will easily move into other spaces using this foramen. So that's the most striking feature. Every tumor has a striking feature. The striking feature of the is called plasticity. Plastic means it can adjust sizes. Also the image. This is the TQ sequence. This is the tumor of the fourth ventricle. This is the sciatic section. This is the fourth ventricle. This is an triangle. It is filled by the tumor. This is the post contrast image. So enhancing tumor of the fourth ventricle is seen. Can you observe this region that is extending through the foramen of meningitis into the foramen magnum region and into the posterior dural thecal sac itself. This is the spinal cord. It's not compressing too much of the brainstem and all, but it's just trying to get outside the area from where it has started. It's going everywhere. This is the actual image to the foramen of Brusca. It is going into the CP angle. This is the CP angle region. The tumor that has started is exiting out. So whenever an intraventricular lesion that tends to follow the slope, the pathway of the CSF is an ependymoma. It's a very classical appearance. Next is forehead plexus papilloma. Forehead plexus being in the reticular system. There are two tumors that are seen there. One is papilloma, next is carcinoma. Forehead plexus papilloma is a cauliflower type brightly enhancing front-like region. This is a plain CT scan which shows the hyperdense region here, and this is the post-contrast image where there is a brightly enhancing region there. These are the MRI images. You can see typically the cauliflower nature of the lesion here, and it's a bright enhancing. How to differentiate between the forehead plexus papilloma and carcinoma? There is only one imaging finding: the invasive nature. Both will look same, both will enhance, both will be large in size. But the forehead plexus papilloma will never go outside the ventricular cord. But the forehead plexus papilloma will be moving outside the ventricular cord. So that's the most striking imaging feature. So this is an image of forehead plexus papilloma. There is associated hydrocephalus because of increased production of the CSF from the tumor. Next is forehead plexus carcinoma. Yeah, I showed the CT image here. This is the ventricular drain that they have inserted. See this tumor here, the huge tumor that has gone out of the ventricle into the brain parenchyma. So that's classical of forehead plexus carcinoma. Same with the MRI image, a large tumor which is involving going outside the ventricles into the brain parenchyma itself. So that's the forehead plexus image. Next is colitis. Is a benign tumor. It has a very striking appearance. It's a plain CT scan. It has a very dense appearance around in the third ventricle. These are the frontal ones. This is the third ventricle. It is seen in the tip of the third ventricle. It's a very classical diagnosis. Colitis, benign tumor. Usually, these patients have present with headache and sleep. That's how these patients have colitis. There is the absence of the normal CSF flow. The MRI. It's called the motor oil appearance. Why motor oil? Someone goes for car service without the after 1 year of driving the car, the oil, they change the engine oil. The engine oil is very dark. So that's how it appears on the cleaning treatment. So it's called the motor oil appearance. And T1 it appears bright because of the proteinaceous content within the T1. Last is CNS metastasis. The most metastasis is the most common tumor to see in CNS. That's the most common. Apart from glioma, not even glioma, nothing. Most common CNS tumor is metastasis. How to identify metastasis from a glioma? Only most important finding that you see is the disproportionate edema. The lesion will be very small, but but the reaction to the lesion will be too huge. See, this is a wrong lesion here. It's a completely a really small lesion, but the edema is almost involved the entire frontal lobe and it's going into the right temporal lobe also. So when you observe a disproportionate edema to the size of the lesion, that points towards being a metastatic lesion. In MRI, this is a small lesion here, post-contrast enhancing lesion. Look at the edema here. It's a huge edema that has started. For the size of the lesion, the edema is very huge. This is a edema around lesion here and a huge edema. So disproportionate edema when the points towards the metastatic lesion. So thank you. I hope I somewhat clarified most of the important terminology and basics of this numerator. Thank you. I thank Ramsamy sir for giving this opportunity.
That was an informative session. Thank you so much, sir, for unboxing the interpretation of radiology images and bridging the gaps between neuroradiology and neuropathology so that we can arrive at template diagnosis to help our neurosurgeons in treatment and management. I request Dr. Nagli, sir, Assistant Professor, JLC Kadapa, to give the comment as a token of appreciation. Dr. Nirmala ma'am, to give the token of gratitude to our morning trustee.
Thank you, ma'am. Thank you, sir. Taking over the inauguration ceremony. Hearty welcome all of you to the saga of neuropathology updates bridging the gaps in the diagnosis, which we are privileged to host under YSR University Health Science as part of Zonal CME, behalf of Department of Pathology, PS Institute of Medical Sciences, Kuppam. I would like to welcome our senior faculty and the resource persons on the dais. Firstly, I would like to welcome Dr. VSSR Subbarao Rayali, Vice Principal, PS IMSR Kuppam. Please welcome. Dr. Krishna Rao, Principal and Dean, PS IMSR Kuppam. Ramaswamy AS, Professor and HOD, Department of Pathology, PS. Dr. Jayashree G. Power, Professor, Department of Pathology, PS Institute. Dr. Nirmala MJ, Professor, Department of Pathology, PS Institute. Dr. Vidya K, Professor, Department of Pathology, PS Kuppam. Dr. Kumaraguru BN, Professor, Department of Pathology, PS Kuppam. I would welcome Miss. I'd like to invite our session moderator for the session, Dr. Chitra, ma'am. Ma'am, please, observer for a session. I would welcome Miss Geeta Shravya, first year MBBS student, to invoke the Lord's blessings.
Good morning to one and all. I'm Geeta Shravya from first year MABS. Vata Pigana Patim Bhaje Hum 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 Vatapi Ganapatim Bhaje Hum Varana Sivara Pradam Sri Varana Sivara Pradam Sri Varana Sivara Pradam Sri Vatapigana Patim Bhaje Hum Bhutadisam Sevita Charanam Bhutadisam Sevita Charanam Bhuta Bhaktika Prapancha Bharanam Bhuta Bhaktika Prapancha Bharanam Vitaraginam Vinutayoginam Vitaraginam Vinutayoginam Vishwakaranam Vignavaranam Vitaraginam Vinutayoginam Vishwakaranam Vignavaranam Vatapigana Patim Bhaje Hum Varana Srivara Pradam Srivatapi Patim Bhaje Hum Pura Kumbhasam Bhavamunivara Prapujitam Trikona Madhyagatam Murari Pramukadyupastitam Mooladhara Kshetrastitam Paradi Chetvari Vagatmakam Pranavasvarupa Vakratundam Nirantaram Nikhila Chandrakandam Nijavan Makaravi Drutexudandam Karambuje Pase Bijapuram Karambuje Pase Bijapuram Kalusha Viduram Bhutakaram Karambuje Pase Bijapuram Kalusha Viduram Bhutakaram Haradi Gunu Guhatoshita Bimbam Hamsatvani Bhukshita Herambam Haradi Guru Guhatoshita Bimbam Hamsatvani Bhukshita Herambam Vatapigana Patim Bhaje Hum Varana Srivara Pradam Srivatapigana Patim Bhaje Hum Thank you.
I would request Dr. Ramsamy sir to give a welcome speech.
A very good morning, one and all. Distinguished guests, esteemed faculty, fellow pathologists, and eager postgraduates, it is with immense excitement that I welcome you all to this one-day CME on neuropathology updates, bridging the gaps in diagnosis, hosted by the Department of Pathology at PES Institute of Medical Sciences and Research, Kuppam. I place on record my gratitude to our founder chairman, Dr. M.R. Doreswamy sir, CEO Dr. Jawar sir, COO Dr. Ajoy, MD Dr. Suresh Krishnamurthy sir, and AMD Dr. Rupa Suresh madam for their unflinching support in all our academic needs. With the generous support of our top management and the able guidance of our Dean and Principal, Dr. H.R. Krishnarao sir, we are able to host this academic event of the YSR UHS Zonal CME in Pathology. I welcome our dear Principal sir to this event. I welcome our beloved Vice Principal, Dr. Rayali Subbarao sir. I welcome the observer for today's event, Dr. Chitra Nagaraj madam, Professor of Community Medicine. I welcome the senior faculty of the department, Dr. Nirmala, Dr. Kumar Guru, Dr. Jayashree Pawar, and Dr. Vidya to this event. I welcome our beloved speakers for this event, Dr. Nandish BN and Dr. Kishan Prasad. I also welcome all the past students of the PSMSR who are gracing us today as faculties at various institutes. I also welcome the other senior faculty of the college, that is PSMSR, for this event. As the head of the department, I'm thrilled to witness our dedication to continuous learning converge with the critical need for advancement in diagnosing and managing brain tumors. The human brain, the very seat of our sentience, is tragically susceptible to insidious growth of tumors. As pathologists, we stand at the front line of this battle, armed with our microscopes and a relentless pursuit of knowledge. This CME is our collective response to the ever-shifting landscape of neuro-oncology, a landscape recently reshaped by the landmark revisions of the WHO CNS tumors classification. Today, we embark on a journey through the intricate world of brain tumors, focusing on key updates that will equip us to be sharper diagnosticians and more effective collaborators in patient care. We will delve into the WHO CNS tumors classification, the molecular diagnostics in neuro-oncology, neuromuscular pathology in today's event. Our esteemed faculty, recognized experts in their fields, will be our guides on this intellectual expedition. They will share their cutting-edge knowledge, challenge our assumptions, and inspire us to embrace the evolving nature of our field. To our postgraduates, I say this: let your curiosity be your compass. Ask questions, engage actively, and let the complexities of neuropathology ignite your passion. This is your opportunity to become the next generation of diagnosticians, armed with the latest knowledge to navigate the ever-changing landscape of brain tumors. To the organizing team, I extend my deep gratitude for their tireless efforts in bringing the CME to this fusion. I welcome each one of you present here and thanking you to come to PES Institute in this pursuit of excellence. May this CME be a springboard for us to bridge the gaps in diagnosis, refine our understanding of brain tumors, and ultimately improve the lives of patients. Thank you, one and all.
Thank you, sir. I would request our dignitaries on this dais to commence this special occasion by a light lamp ceremony.
I request Dr. Krishna Rao, sir, to speak a few words on this occasion. I request Dr. Rayali, sir, to speak few words on this occasion.
Dr. Krishna Rao, Dean and Principal, Dr. Ramaswamy, Professor and Head of the Department of Pathology, Chitra Nagaraj, Professor and Head of the Department of PSM, and the observer for AFC for this particular CME, senior faculty on the dais, off the dais, senior faculty from other medical colleges of the zone, guest speakers, Dr. Nandish, Dr. Krishna Prasad. Actually, I see 3 generations of pathologists here. Dr. Jayashree Pawar tells me that Dr. Nandish, Dr. Krishna Prasad, and Dr. Ramaswamy are all her students. So this is what is the essential part. I'm the vice principal here. I'm vice principal academics here. This CME is being held in a background of remarkable changes, both at the level of the NMC as well as the university. I thought I'll just take 2 minutes. Ramaswamy told me to speak only for 2 minutes. I think I'll speak for 5 minutes because I need to actually place this, orient all of you where we stand. I'm sure that you must have all seen the newspapers. 397 medical colleges or 700 medical colleges have been put on notice by the NMC. They've been told that probably they may not be able to take their MBBS batches next year. We had a virtual inspection for our continuation of recognition last year and a physical inspection to follow that. They were not happy with what they found here because of few things, but they pointed out 3 major areas. ABAS to see that our faculty is full, HMSS to see that our clinical material is adequate, and of course, our teaching program, they didn't mention it. These are the 3 areas of concern for NMC. Are the faculty present? My principal actually falls in the category of, must have heard the story of the 3 fishes. Fisherman comes and he says this pond is drying and I'll come to fish. There's a Durdarshi who takes away from the pond when the streams are going to the river. There's a fellow who waits for the last minute, acts dead and gets thrown away. Third fish who gets caught. My principal is a Durdarshi. He made sure, because we got a warning way back in March that ABAS is going to be tough. And we ensured that 75% of the faculty are punching ABAS. We are not in the 397 medical colleges. And let me tell you, out of 397 medical colleges on notice, 197 are government colleges, including my own alma mater, Andhra Medical College. Not because they have staff. They've got staff in every specialty much more than required, except they don't have tutors, because tutors is a word which is not used in government colleges. I think guest faculty is shaking his head. We have our own structural problems. Bottom line is, and my principal would not be happy. He addressed all of us last week. That left me very disturbed. That is the background of today's CME. Things are changing. It's not like life before. The MARB, I think Nandish comes from Nimhans. MARB is headed by Dr. B.N. Gangadhar, my specialist squad colleague, psychiatrist. He has issued a new set of guidelines. New set of guidelines are actually tightening up shortcomings. Staff, tightening is not good enough. Students' attendance, tightening is not enough. Competence-based medical education, are the lectures being held? Not enough. They want to supervise that. They want to see it is happening. The competency-based medical education is something which West and Europe have been doing for the last 20 years, 30 years. We are catching up late. What is this competency-based medical education? It actually sees the definition of the Indian medical graduate, tells you everything. Lifelong learner, researcher, this thing, that thing, and all that. And somehow we all filled up our undergraduates with knowledge. They were good for any country. They could go anywhere and settle down because their knowledge base is all right. The replication is the problem. They found it difficult when they're an intern. They found it difficult to become a part of the community. The competency-based medical education is all about that. And for that, we'll have to train them. Like it is a lot of Ramaswamy, Kumar Guru, all the senior faculty on the stage, make them competent. Just to cross those mental barriers. And I think in that respect, YSR University has stepped in. The CMEs is an old practice, but has been revived. Not only revived, but sustained. We had 2 CMEs in this college last week and 1 CME this week. And this space has been unheard of in the history of PS area. This is despite our having a management which encouraged the CMEs. Only 1 or 2 specialties took advantage of that. Most of the CMEs, specialties like mine, thought we don't have to do it. We go for an annual conference, that's good enough. Not the case. We see faculty coming from other zonal colleges. We don't realize they're so good in the zone itself. We want to see them talk here. My students go outside and their students come here. There's a cross-sectional learning. And I think it's all like when you talk about conferencing, postgraduate training needs to be taught how to arrange for conferencing. That's what Dr. Ramaswamy is probably saying. Like first you'll have to pick up a theme. Neuropathology updates, bridging the gaps to diagnosis. I think is a wonderful theme. I can talk about neuropathology of psychiatry. I've seen schizophrenia from the time a century or more back when Kraepelin called it demens precox or a precocious dementia. Things have changed. Dementia we've all thought that neurons are packed into the fetal head before birth and no neurons take birth after that. I said we were all wonder 10 billion, we were all counting the numbers. And after 15 years of age, neurons only die at a rate of 1 million every day. And in other words, dementia starts at 15 years of age. Things have changed so much. Our focus on neurons has gone from the focus on the neuronal cell to its connections. Each neuron on an average is supposed to have 1,000 connections. Those connections are perhaps more important. That's the reason why Dr. Chitra or Dr. Jayashree is still wise, because her connections are good. Dendritic connections are as important or more important than neuronal tissue. And I think Nandi should be smiling at me. He says, what is this basics he's talking about? But what we forgot as we saw schizophrenia is not even the number of neurons, the number of connections, it's the packing tissue. We all thought this glial tissue, these astrocytes, just God has put it for packing the neurons. We now realize it is not so. Whole secret of actually the neuronal tissue is how it actually develops, or what we call as the neurodevelopmental hypothesis of like the neurons keep on producing dendrites and keep on sharing them. There's a dendritic pruning which happens all the time, and this is done by the glial tissue, the astrocytes, and they're programmed by genetics. How well they prune. If the pruning does not happen, there's no neodendrites. Or in other words, schizophrenia is not just the death of the cells, or dementia is not just the death of the neurons. I'm sure you'll hear a lot of these things. Actually, very interested in seeing what goes on here. What I'm trying to say is much more than what is taught in the class in a pathology lecture. That is what perhaps we actually are sitting here for. And a lot of things go unnoticed. Only seen is who is on the stage, where the lamp is lit, what is the song sung. But what goes is, how do you pick up a theme? How do you actually step upon what are your advantages? What is Ramaswamy's advantage? Ramaswamy is close to Bangalore, trained in Karnataka, and he brings that particular roots, connections here, picks up a theme. He's actually training trainees, not just in conferencing, just making arrangements for the flowers and the meals and all that, actually making them think. Research is not really too much. Like we have a mental barrier. We don't really record. We don't research. What he is trying to make them do is actually push them to do this thing. I have a small announcement because before I'm speaking, I don't know, many of you know that Kumar Guru has got a patent last week. That's a very important thing. That's where we should be heading. We should be heading into doing some work beyond the class. And the work should be interested in what they call the finer principles. It should be interesting, it should be novel, and it should actually be self-sustaining. You got the marketing rights, you got the marketing patent, you got the, so this is where we go. I'm not saying that it should be money-minded, but money is important. It should be sustainable. And I'm sure no department actually stands for that better than pathology. I think all these senior professors there, Dr. Vidya, Dr. Jayashree, Dr. Nirmala, Chitra, Dr. Kumar Guru, all these are different speakers, and we got reputed faculty from elsewhere. All the best. Happy conferencing.
Thank you, sir, for your inspiring words. I request now Dr. Krishna Rao, sir, to speak few words on this occasion.
A very good morning. Respected Dr. Rear Admiral Retired PSSR Riley, Visit Seva Medal, Vice Principal, the College and Head of Department of Psychiatry, Dr. Ramaswamy, the Head of Department of Pathology, the Zonal CME Coordinator, Dr. Paleshwari from Nandyal, the observer for today's activity, Dr. Chitra Nagaraj Madam, the Professor HOD Committee Medicine here, the faculty of the Medical College, my respected Dr. Vishweshwar Reddy sir, Dr. Nagaraj sir, guest speakers who have taken time and come here on Sunday, Dr. Kishan Prasad, Professor K.S. Hegde, Medical College, Mangalore, Dr. Nandish, Additional Professor, NIMHANS, Bangalore. I welcome the guest speakers and speakers from our own college. I already heard morning Dr. Hamid, Dr. Kumar Guru, and Dr. Vidya. The delegates, Dr. Ramaswamy told me about the number 100. They come from the different regions of Rayalaseema. The faculty of our own college, the PGs and delegates from our own college. Last couple of weeks back, I was in Muscat spending time with my grandchildren. I got a grandson, 8-year-old, and 4-year-old granddaughter. As usual, the granddaughter, when I met her, she sat on my lap. She told me, "Tell me a story." I started telling a story. After 2 minutes, she said, "I heard all your stories. I don't want to hear any of your stories," she said. Then she went and picked up a book. Normally, she picks up a book which are easy, book of a Rapunzel or this one, Cinderella, the sort of book. But she picked up a book which was thick. She said, "Read this book." Started reading this book about a small girl who joined a mission school in France, lost her father. Her father was a painter, and she had that habit of painting. And the school also was such, we didn't allow her to paint anything other than gray. She was not getting any chalk pieces, colors, and all those things. So her friends, her other people, everyone started giving her small pieces of crayons and all that, and she started painting in vibrant colors. And ultimately, she became the painter for the uh, Queen of France. Her name is Artemisia Gentileschi, and became a great painter during those 1450 to 1550 period. And she brought color to France. Today we are on such a day where the whole everything looks gray outside. So it's the Department of Pathology, by their colors, vibrant colors, are adding life to our institute. And I thank the Department of Pathology for conducting this CME. And I welcome all the delegates from different places. They have come early morning or traveled yesterday night in bright colors. And welcome you all. The previous week we had two CMEs, surgery and OBG. And as Dr. Riley sir said, it is revival of CMEs what we're having here. We had around 2011 or 12, we started CMEs during IV Ross period when he was the VC, along with the internal assessment examination conducted for PGs. And with passage of time, the CME stopped. The internal assessment examination still continues, perhaps the only university which conducts for all the PGs at the same time. With the present VC, Dr. Babji and Dr. Radhika Reddy coming in as the registrar, again there has been revival of PG seminars, zonal seminars. Initially, people are reluctant because again it takes your Sunday private time. People need to travel and come. But then over a period of last couple of months, what we realized, it becomes a great area for the PGs to come and meet, share their thought, get into a platform, meet their teachers or peers, and express themselves, and that helps in developing a confidence, learning to know what's happening around, and also helps them in improving their communication activities, improves their attitude, and adds to their aptitude. Very happy today, Department of Pathology is conducting this CME of zonal YSR University activity at Rayalaseema. The topic is neuropathology updates, bridging the gaps in the diagnosis. I hope that all of you have a great time, and by the end of the day, it's always something we learn and add to our advantage. Thank you so much for inviting me, and have a great time.
Much, sir, for your encouraging words.
It's a great honor and privilege to propose vote of thanks on this memorable occasion. First and foremost, on behalf of Department of Pathology, I thank management for their continuous support and encouragement. I thank our Dean and Principal, Dr. Krishna Rao sir, for his remarkable presence and for his inspiring words. I express my heartfelt thanks to Vice Principal and HOD of Psychiatry, Dr. Rayali sir, for gracing this occasion. We are grateful to our beloved HOD sir, Dr. Ramsamy sir, whose guidance has always encouraged us. Thank you, sir, for your continued support. On behalf of Department of Pathology, I owe special gratitude to the distinguished speakers of the day, Dr. Nandi sir, Dr. Kishan Prasad sir, Dr. Kumar Guru sir, and Dr. Hamid Arfat sir for accepting and gracing the occasion by sharing their knowledge with us. I also thank our moderators and observer for the day, Dr. Chitra ma'am, Professor of Community Medicine, for investing their precious time. I thank our senior faculty members, Dr. Jayashree ma'am, Dr. Vidya ma'am, Nirmala ma'am, and Dr. Kumar Guru sir for their valuable contribution and encouragement in all our efforts. Special thanks to Dr. Reshma ma'am, Dr. Shobita ma'am, Dr. Sharanya, and Dr. Veena, and our dear postgraduate students who have worked as a team to organize and conduct the events in a smoother fashion. I would also thank the paramedical students. My sincere gratitude for the sponsors who have helped us to organize this program. Thank you one and all. I would like to thank Dr. Vishweshwar Reddy sir also on this occasion. Thank you, sir.
To moderate, I would request Dr. Jyoti Madam from GMC Kadapa. Madam. Dr. Rajshekhar sir, Associate Professor from Tirupati. We are esteemed for today to invite Dr. Nandish sir. Sir is an additional professor from the Department of Neuropathology at NIMANS. He's done his undergraduation from Mysore Medical College and post-graduation from JJM Medical College, Davangere. Sir's field of interest are neuromuscular disorders, neuro-oncology, and neuroinfections. He has around 100 publications and 60 guest lectures in his credit. Sir, over to you to give talk on muscle biopsy interpretation.
This is fine. Very good morning and namaste. I'm extremely thankful to Dr. Ram and his team for inviting me to be part of this great program, and very delightful to see all of you. In the next 45-50 minutes or so, we'll just have an overview of an approach to interpreting muscle biopsies. And this always goes with any learning. Of course, medical education is not an exception. That a lot of information comes to us from various sources. And especially in a CME like this, you'll have bombardment of a lot of information in a very short period of time. So it's very difficult to grasp. So as any learning, you can divide yourself the information into 3 zones. Very much important to know the basic concepts, fundamentals. Next, useful to know or good to know. Then the periphery will be additional information which is optional to know. So don't worry about what you are missing. So go with the message that each slide should carry with some message at the end of going to the next slide. Okay, so that is my message. Now going further, the uniqueness of any animal is the locomotion. Okay, of course, I'm not going to the other aspect of consciousness and other things, but locomotion is the one which determines the skill of an animal, whether it has to hunt or it has to have its habitat. It's all adaptation and other things is dependent on that. But if you carefully see, humans have got an extra locomotive capacity where it can dance and other things, okay, which is not possible with any other animal also. And this coordination, actually, if you carefully see, that coordination is the amazing thing. So I will come to that. But if you carefully look at it, though humans have got an extreme degree of coordination, but it may not match with some of the animal strengths, which could be a muscular strength, or of course coordination or balance, like balancing on a tree branch by a monkey, or if you take carefully see flying animals also. Though man or humans have not got that kind of capacity, but the uniqueness of humans is the fineness coordination. So which gives the extreme skill of highly sophisticated surgery, artistry, and other things. So all these things, if you carefully look at it, it's all because of neuromuscular system, which includes nervous connection also. Okay, so this nervous connection is connected to the central nervous system. So today we'll be dealing with various aspects of central nervous system. One of the talk would be on the peripheral nervous system. An extension of this peripheral nervous system will be the target organ, that is a muscle. Okay, now going to this, if you carefully look at all these things, neuromuscular disorders will have overlapping symptoms, whether it is due to neurological pathology or due to muscular pathology, or the junction of these things can have positive symptoms, negative symptoms. Negative symptoms are more common in the form of fatigue, weakness, okay, loss of sensation, like that. Positive symptoms would be altered sensation, cramps, pain, all those things, stiffness, contractures. They're all abnormal symptoms, various. But going with overall the complexity of this is what gives the uniqueness of the locomotion, coordination, other things. connection between the nerves, peripheral nerves, muscle, and the junction of it. Going further, this is how you divide the neuromuscular disorders: myopathic, where muscle is primarily involved; neurogenic, where nerve is primarily involved, or the junction of these two. But one thing you should remember, each can have secondary affection of the other one. If muscle is affected, the nerve endings can be secondarily affected and you can get neurogenic problems. If nerve is unhealthy, of course, it will not be able to maintain the integrity of the muscle. So muscle will have symptoms related to that. Going further, all these things can be not due to a primary pathology. It could be due to secondary systemic pathology. That also you should consider. But if you carefully look at muscle disorders primarily, can be broadly classified as acquired and genetic, inherited versus non-inherited. Under inherited will be a series of diseases, and the non-inherited, the most dominating one would be the autoimmune conditions or the inflammatory myopathies. Okay, so we'll deal some of these things after having an overview of the approach to that. Under genetic myopathies, the most important dominating would be the muscular dystrophy, which we'll have a few examples of that. Now, what happens is most of the times in all these clinical difficult situations, patient problems, ultimately you will have a lot of options of investigating. Most of the things whatever advances has happened, ultimately the gold standard would be pathology, histopathology. So you will be the savior and decision maker. So to understand the approach to any pathological diagnosis, we need to know some ways of approaching it, some background. That's what I will be dealing it with this now. So you know that muscle is a complex organ, though it looks complex organ because of two things. One is the metabolic active, the organization, structural organization, and the nervous connection, the extreme degree of activity which will be happening. So muscle is a bundle of muscle fibers, and these muscle fibers actually are bundle of myofibrils. I hope I am clear. Muscle is a bundle of muscle fascicles, and each fascicle has got multiple muscle fibers, and each muscle fiber has got multiple bundles of myofibrils. Okay, and myofibrils have got again units which we'll understand that net. So this is how what I told you as bundle. A muscle belly is a complexity of multiple muscle fascicles, and muscle fascicles are bundles of muscle fibers, and the muscle fibers are bundles of myofibrils. Okay, and myofibrils all these are like cylinders, like optical fibers. You can cut into multiple divisions, units, and myofibrils are nothing but multiple successive units of sarcomeres, which we'll understand. So this is a very complex organ. Well, it's like this. This is what one fascicle, if you take, it will have multiple muscle fibers, and one muscle fiber you take, one muscle fiber is a bundle of myofibrils. And myofibrils have got two important organs, two important protein complexes, which are longitudinal filamentous proteins. One is thinner actin, thicker myosin. They interdigitate whenever they are contracting. Okay, all those information may not be very important, but actually, if you see, this is what you have learnt in our histology, physiology classes. Then again later on it came. I'm just revising it. Why it is important? You will very soon understand this. Okay. Now this has got myosin and actin. These are the two important thin and thick filaments which helps in contracting it. This is like our axle of a wheel of a vehicle, the main axle which will pull the entire vehicle. Okay, contraction. So that's how the axle will pull the vehicle. Now these thick bands form the H zone, the A band, H zone, and then in the middle you have the I band. M line, and then you have the light zone, that is the actin filaments. Then you have the Z disc there. Okay, in between two Z discs you get the sarcomere, and sarcomere is that thing there, but a small unit length of a myofibril, and multiple myofibrils come together to form a myofiber, and myofibers come together to form a muscle fascicle. Muscle fascicles come together to form the muscle belly. This is what an ultrastructure you will see, the A band or the myosin rich area. Then the lighter zone is this actin area. Then you have the darker Z line and this M line in between that. Now, let's now divert ourselves. If all of us have vehicles, most of us drive, it could be a two-wheeler, three-wheeler, four-wheeler. Of course, nobody drives six-wheeler like trucks. Okay, we're not in that profession. But take simple vehicles to complex vehicles. The more complexity a vehicle becomes, till like this. So this also is to customize also, you need to make it more complex. To carry more heavy load, you need to make it much more complex. Why I'm talking all these things is because just look under the bottom of any of these vehicles. Okay, this long back when I was childhood, once what had happened in one of the taxi when we were going, the taxi all of a sudden it jammed where the chassis came and hit the tire wheel. Then we had an opportunity to go to the vehicle shop and look at the bottom of it, because you can walk through in some of the show what is service centers, is it not? You'll see this much complexity of it. Just when I came to this neuropathology, I was thinking all this. If you take the problem in that cab was basically one nut in one next to that wheel, okay, which is that nut had fallen off. So nowadays the vehicles which are coming are very sturdy, that accidents won't happen. But that time that nut had fallen off, so the entire chassis had fallen on the wheel. Just imagine it was just a problem with one nut. The problem had happened. But you see the organization, so many nuts, bolts, bars, everything is there. That forms a simple man-made machine. The more complex this machine becomes, then the more complexity in the connections. Now imagine our machine. This is, I'm talking purely from a locomotion point of view. Locomotion means movement point of view. A moving vehicle with our moving muscle. The complexity is whatever I told you as myosin actin itself are just two small proteins in a big vast mass of proteins. So there is, you have fibrils, actin, whatever Z line you said, it's an actinin fibril which binds it. So lot of membrane, submembrane, intramembrane, transmembrane proteins are there, cytoplasmic proteins are there, nuclear membrane proteins are there, intranuclear proteins are there. All of them are very important, okay, in connecting between the extracellular material to the intracellular material. Only where then the contraction will be effective in pushing the entire muscle, entire bone, entire joint, entire arm or the limb. So that is the complexity of this. And many of the pathologies are because of the disturbance in these proteins, disturbance in the function, disturbance in the quantity, quality and organization of it. Okay. So let's take simple, very most important proteins I have shown you. The most important one are transmembrane proteins, the most, and some are subsarcolemmal proteins. Sarcolemma is the membrane of that. The most one which is dominating the entire thing is this dystrophin you can see here. Okay. And this dystrophin is one of the heaviest protein, largest protein in the muscle. For this was the largest protein for a long time. Now there is one more protein which has come to compete with that, that is the titin. Okay. So there is that kind of discovery happens, and see the organization. This is how entire function happens. The problem with this is in a man-made machine, it has only function of either support or movement. But in our case, the proteins not only have structural function, they have functional function, physiology also. Like in a sense, they help in act as cofactors in some of the functions. Metabolically, they may act as catalyst. Some of them make a scaffold to facilitate other functions. Some of them they sequester ions, especially calcium, and some of them act as enzymes. Okay, so multiple functions, not only structural, but also functional organization of it. Like let's take for example, dystrophin we'll take. Dystrophin not only helps in transferring the contractile function from the actin myosin to the extracellular, but also helps in anchoring, also helps in sequestering the calcium. Let's take if this dystrophin molecule is broken down or insufficient. What happens? It will not be able to give a structural integrity. At the same time, it will not be able to keep the calcium within itself. Sequestered calcium is released. This calcium will activate proteases, then muscle gets destroyed. So that is the complexity. I will explain to you all this thing, but just to give an overview of it. So this is what I was telling you. This is the anchoring protein dystrophin, which connects the extracellular apparatus to the membrane to the nuclear, to the contractile apparatus, that is myosin actin. So what happens here is if this has got damage, you will see like this. If it is damaged, it cannot give structured integrity. At the same time, it cannot sequester the calcium. The calcium is released. Calcium activates many other proteases that will destroy the muscle integrity, integrity, and you will have degeneration, disintegration happening on that. So that is the main pathology. So now going to the primary muscle disorders, you can classify them as multiple. One is congenital myopathies where the onset is very early. These are all developmental problems where the man has not made the machine properly. In the same way, the child is not born with the proper organization of proteins, proper quantity of proteins, or dysfunctional proteins. Another one is toxic drug induced. This is of course acquired. Infectious myositis due to infections. Inflammatory myopathies are due to autoimmune conditions. And the another group is metabolic myopathies, either due to storage disorders, glycogen, lipid, all those things, or mitochondrial. Next is myofibrillar, where individual proteins, which is forming the main proteinar organization, that is problem. And next is dystrophy, where the degeneration happens, degeneration of these proteins of the muscle happens. So this is in as a holistic classification. But in a different way of understanding the pathology, you can classify them into pathology due to extrinsic factors, pathology due to intrinsic factors. Like in our many of the pathology diseases are due to an intrinsic problem. Cancer, it's an intrinsic problem. Infections due to an extrinsic problem. Drug-induced extrinsic problem, like that. So muscle pathology could be due to an extrinsic pathology like infectious agent, immunological like autoimmune disorders, or a drug, toxins, or it could be neurogenic. Neurogenic again could be intrinsic or extrinsic. Intrinsic is due to a protein problem where it may be aggregating, surplus or protein aggregative pathology, or metabolic myopathy, which is due to glycogenesis or lipid or mitochondrial. Then congenital myopathy, I told you, problem with the developmental organization, dystrophic process, the degenerative process. And all these things in short will explain, if you know, that you can think about the pathophysiology. Okay, extrinsic. In among these two, which one do you think is easy to handle, to manage? Extrinsic. So that is the thing. In the same way, many times if you go to philosophy, you can handle extrinsic problems. That is, you can handle outside problems, outside our body. Okay, if you think about philosophical, you can handle outside enemies more than the intrinsic internal enemies. You can handle outside people rather than the fight within ourselves. That is a philological one. So assessment. Okay. So histological assessment will be like this. Of course, all of us are comfortable with paraffin sections, right? The usual tissue coming in, formalin, then you process it, make paraffin blocks, take sections and this. But somehow that is not the ideal procedure for muscle, because you will not be able to pick up most of the information from that. So you don't, you can avoid paraffin section, but you can still carry out the same staining on cryo sections, which will come to that. Suppose if you get a fixed muscle tissue like any other tissue, you can do the routine staining, but very important that you do Masson's trichrome in this. Masson's trichrome is, sometimes if you want, you can skip HND, amatoxin, but no, none of the pathology will skip HND because that is our strength. So HND is very important. Along with that, we should do Masson's trichrome because connective tissue. Three colors due to Masson's trichrome is best appreciated on a muscle, because muscle will be red, connective tissue will be green or blue depending on the counter stain, or blue will be the nucleus. So best stain for that. Next is for myofibrillar, that striations, you can do PTH, congruate for amyloid. Cryosections is most important. The reason is, I told you so many diseases. Many of the diseases you can pick up. The organization of myofibrils you can pick up. The storage disorders you can pick up. Mitochondria you can keep up. Mitochondrial pathology you can pick up. Many of the degenerative conditions you can pick up based on cryosection only. Because once you fix and do paraffin sectioning, many of these features are lost or camouflaged. The only way to do is cryosectioning. I will tell you what is that cryosectioning very soon. If you do cryosectioning, you have two sets of stains. One is enzyme stains, another one is non-enzyme stains. So whatever you do for paraffin section will always be non-enzyme stains. Because for enzyme to be activated, you have to have cryosectioning. Once you fix it, enzymes will get inactivated. Even vapors of formalin can inactivate the enzymes. So cryosections, non-enzyme stains includes the same. HND you can do, but Masson's trichrome is difficult to do on cryosection. Instead of that, we do something trichrome only. It's called as modified Gomery's trichrome stain. Modified Gomery's trichrome stain. Pyridic acid shift you do for all glycogen storage disorders. Oil redo for Sudan 3,4 for lipid disorders. All these are, so you can pick up. See, you know that if you do paraffin staining, if a storage disorder comes in alcohol, all these glycogen disorders will be dissolved. You cannot pick up. Okay. Similarly, if you process it, lipid will be dissolved by the clearing agents. So all this will be avoided if you do cryosectioning. Enzyme stains are these one, which I will explain to you. The applications I will explain to you very soon. One is succeeding dehydrogenase. Next is NADH, nicotinamide adenine dinucleotide hydrogen, tetrahydroreductase, cytochrome oxidase. All these actually the SVH, NADH, COX are all mitochondrial complexes. So you can pick up mitochondrial pathologies by doing these enzyme tests. Mitochondrial pathologies you can do on this thing. Okay. Next is menadione alpha glycerophosphate. I will tell you what is this. Menadione alpha glycerophosphate. I will tell you. It is very important to muscle fibers are of main two types. Fetal fibers are type 3. Okay, which will not deal with that. Type 2C are regenerating fibers. Regenerating fibers are type 2C. But we will recognize the type fibers on ATPase typing of fibers. Acid phosphate, is a lysosomal enzyme. You can pick up them on whenever there is lysosomal storage. Myphosphorase, it's one of the glycogen storage or glycogen breaking enzyme. Myphosphorase. Next is phosphofructokinase. Now let's come to the application of these enzyme strains when you should do it. HNA, for any description, any picking up of pathology, organization, assessment, okay, everything HNA is must. Masson spectrum to pick up the fibrosis, most important. Next is PTH for cross-section and ring fibers. I will tell you what is that ring fiber later with example. Conglomerate for amylase. These are all revision, nothing new for you, I am sure. I told you about non-enzyme stain which can be done on cryosections. What is cryosection? I will tell you very soon. That is mainly for Nimmerlein rod, which is a type of congenital myopathy, where some of the Z discs are not properly organized. So Z discs accumulate, so you get rod-like structures. It's a developmental pathology. Nimmerlein rod, ragged red fiber again is a mitochondrial pathology which you can pick up on MGT. Ragged blue fibers is not in MGT. Ragged blue is on STH and ADH. Will not come to that. Rimmed vacuoles again a sign of degeneration. Accumulation of O-note degenerated proteins. That's what rimmed vacuoles. Vacuoles which are rimmed by granular material which is red stained on MGT. Tubular aggregate where sarcoplasmic tubules are there which is abnormally dilated accumulating, that you can pick up on MGT. Inclusions can be picked up. Allodo, all of you are familiar. Lipid storage, PS for glycogen storage disorders. That's very clear. These are all non-enzymes which you can do. All these things you can do, especially MGT, aldodo, PS, you have to do on cryosection only. Once it is fixed, you cannot do MGT and all those things. Next, muscle based. This is the clinical level. Very few centers now are done by pathologists muscle biopsies. Otherwise, 99% of the times it is clinicians who do. So they have to select the muscle which is moderately involved. Okay, for upper limb it is basically the biceps, deltoid, to some extent triceps. Low limb it is mainly the quadriceps muscle, or if you go to distal involvement, it will be tibialis anterior. Because these muscles are properly studied. Rarely, sometimes some of the ophthalmologists, because of ocular problems, they sent our orbicularis oculi to us. Initially, I was excited because that showed ragged red fiber like structures. I was excited and I showed it to my senior. They told that orbicularis oculi can occasionally show, or can show ragged red fiber like structures normally, physiologically. So these are all rare muscles, so they are not studied. These are traditional muscles which you should remember, and you have to avoid certain places. That is, biopsy should not be very close to the insertion site or origin, close to the aponeurosis, close to the bone. The reason is these are the places where fibrosis will be naturally be there, fibrous tissue. So you will be wrongly calling it as fibrosis, or nuclei will be centralized physiologically. That will be wrongly called. Avoid those places where some injection has been given, trauma has happened, because they will alter the pathology and all those things, right? So this is the overall. Why you have to choose moderate involved muscle? Because if you involve less involved muscle, the muscle fiber may not show much pathology or the actual pathology. If it is very severely involved, it may not show muscle fibers. Like in severe dystrophy, muscle fibers will be very minimal. You cannot pick up the changes. So these are the essential information. On message, I told you statement has to go. And next is what you should do after biopsy. See, earlier muscle biopsy used to be immediately fixed, put in formalin. So once any kind of intervention on the muscle will be stimulated and it contracts. So immediately if you place it in formalin, it will remain in the contracted state. You cannot pick up anything, because it will all look contracted, hyper contracted, dark pink. It will look, striations cannot be made out properly. But that was the formalin era. But now since we are expecting a non-fixed tissue, you don't have to tie anything. That time to cause that to relax, people used to tie and do all those things, but it used to cause a lot of artifacts. But now this is a non-formalin era. You don't have to fix it. So muscle will contract transiently and relax you have to send it fresh. How to send it fresh? You should not soak it in saline, like frozen tissue which comes up like for our margin analysis. Okay, frozen section intraoperative consultation. It comes in formula or sometimes it comes directly. It should not come like that, because there our tissue, our aim in a intraoperative consultation is recognizing malignant cells. We don't have to type the malignancy, at least recognizing the malignant cells and margin free. That is the two main conditions. But here it's not like that. We have to do a lot of study, lot of analysis. So you should avoid drying, you should avoid excess saline also. Both the things, extremes has to be avoided. So how to do that? Take a piece of gauze, just sprinkle a few drops of saline, just to keep it moist only, not to soak it and make it filled with saline. It should be very minimally moist, okay? And then place the muzzle biopsy there and cover it. Nowadays, you got very nice vaccine carriers. At least earlier, vaccine carriers used to come where 4 degrees is to be maintained. After that, you got highly sophisticated vaccines where you have to maintain -20. Then you got very super dry ice carrying or ice carrying vaccine containers. Nowadays, you are getting such containers where liquid nitrogen is there, which can maintain at a very high level. You have got much more better. Now they're all expensive. Everything comes at a cost. Now we got very good vaccine carriers where you can keep -20 degrees centigrade for 3 days. So a lot of things are advancing, but at a cost. So this is what I was telling you. Don't soak it in excess saline. Don't do these things. But this is why you should be aware is though you don't do the biopsy, but you have to educate the person who is doing the biopsy. Fixative, no fixative. This is what. Don't put excess saline. If you put excess saline, what will happen? I will tell you. Now this is what. If you put excess saline, this is what happens. You get a lot of ice crystal formation, saline. Otherwise, in an ideally sent specimen, this is how muscle fibers are there. Okay, we'll understand what is normal, abnormal very soon. Now, what is the transport? How it should be transported? There should not be any delay, obviously, and it should be very, very fast. Ideally, in many of the abroad centers, what happens? The biopsy is done in one room and the evaluation is done in the next room. That means you have one institute of neuromuscular disorder. Everything is done there. Neurology is on one floor, neuropathology is one floor, the consultation is below, procedure is done below. Very fast happens. But in our situation, it's not. So within the campus, not a problem. But if you have to transport from other ways, you have got very good ways of transporting it. Very, very important criteria is to maintain the cold temperature, cold chain. How to maintain the cold chain is that the gauze piece which is moist, muscle tissue is there in the center, cover it up, keep it moist, then place it in airtight sealant or whatever cover. Then you place it in the actual cold box. Okay, it could be a thermoflask or anything or any of the vaccine containers. Then you pack it from an outside actual box with the carrying all the address, everything. So these are the things. It's called as triple packing. Okay, never ever this muscle tissue should come in contact with the ice. This ice, you got now high quality of liquid materials which will remain solid, cool in a very cold state. You got many coolants also. You got many upgradation has happened. You can consider that. Now, what you should do once you receive in the muscle, once you receive at the lab, take out the muscle tissue, orient it properly. Then you have to do what is known as sap freezing. So why you should get this sap freezing? So though the purpose is same. In an intraoperative consultation also you do freezing. Here also you do freezing. That is you do cryomicrotomy. That is you cool the tissue to -25 degrees centigrade and then you take section. In an intraoperative consultation, frozen section, after doing sectioning, you take it for staining and interpret. But once it comes in the lab, what you do is you take the representative tissue, take it in the cryo section. After keeping it in the chuck, OCT media you place, then you place the tissue, freeze it in the cryo section, wait for some time and then cut. All these things 20 minutes approximate, right? 20 to 30 minutes. But here in the muscle tissue, you have one more step called as instant freezing, flash freezing, snap freezing. All the same names, don't worry about it. What it means is that now just take muscle phase. Muscle is one of a large cell with lot of cytoplasm, lot of metabolic active substances are there. Fluid is there, tissue fluid is there, both intra muscle fiber and extra muscle fiber. If you do it in that procedure where room temperature is there or body temperature, from body temperature, room temperature, from there if you go to -25, It won't go suddenly to minus 25. It goes to 0 and then minus 25. During that process, what happens? The fluid becomes crystallized. You have seen in our fridge only in minus 20 degrees, so hard it will be the crystals. You can, if you throw that on somebody, it will hurt like any stone. That way of crystals is dangerous to the muscle, because when you do tire sectioning, let's say see how comfortable are you in staining and interpreting a muscle, intraoperative frozen section versus a regular paraffin section. Nobody will be comfortable in interpreting intraoperative frozen section slides, right? In the same way, in muscle, what happens? Those crystals will actually pierce through the muscle fibers, pierce through the nucleus, pierce through the muscle, to the sarcoplasm. You know, most of the stainings, what you do later is to pick up fine findings in the sarcoplasm, fine findings in the nucleus. If there are a lot of crystals, you will be wrongly interpreting. You will be losing out the interpretation. So you have to maintain the same integrity. How you can maintain is from room temperature. If you can directly take it into a vitreous stage. What is that vitreous stage? That is a stage where you will have very cold temperature. Everything is preserved in the natural state. From plus 25 or plus 30 degrees centigrade, you have to jump into minus 150. Minus 150. Only then you can preserve this kind of appearance. I showed you the photograph here. If you do the usual way of freezing, this is how it happens. Have you come across any slide, frozen section slide without vacuoles? Impossible. Vacuoles is obvious. Okay, it's inevitable because of the fluid there, and it will go to that normal moist ice temperature, cold temperature, and then it becomes crystals. But this is called as vitreous state. Minus 25 to minus 150. How to bring it is you have to subject the tissue to a fluid or something which is at minus 160 degrees centigrade. That is liquid nitrogen. But if you place, have you ever touched any object of minus 50 and below? A simple example I give. This was told by one of the army officer. In Siachen, the temperature is minus 50 and below. That is minus 50 and below. If by chance somebody removes the glove and touches a rod or something, if you take out your hand, your entire hand will be not only frozen, full of blood, because the skin epidermis will be with the iron rod. Okay, what I'm telling you is, if you subject liquid nitrogen, if it falls on our skin, you will have similar burns like oil burns, hot oil burns, blebs and other things. That is the danger. So you cannot subject the tissue to what? Liquid nitrogen. But you need liquid nitrogen to reach the temperature. So what you should do is, you use a liquid which is protective, cryoprotective also, but which will not damage the tissue, but it will reach the same temperature. And that fluid is isopentane. So what you should do, you pre-cool the isopentane, like take the isopentane, put it in the liquid nitrogen like this in the third image. Isopentane you take, cool it with liquid nitrogen, then take it out. That liquid nitrogen now, isopentane will be minus 150 or minus 160 degrees centigrade. Now you place the tissue in that. The tissue is not damaged, but it is exposed to minus 160 degrees centigrade. So from plus 25, it reaches minus 160 centigrade, becomes pale white. From red, it becomes pale white. Then you can start doing cryosectioning. That's the way you do frozen sectioning, right? Okay, that is the purpose of it. You do that, the sectioning, then this is a what. And cryosectioning, what you do, you subject it to various strains, which I told you. Then you can do immunohistochemistry on this. You can do Western blotting with the same tissue. Whatever tissue we have frozen it, we can use it for that. You can do enzyme assays. I will tell you the importance of it. And some portion of tissue you can even subject it to electron microscopy also. But electron microscopy, what happens? Vacuoles may be there. So you can still do it with freezing or without freezing also, because once you know that you want to do electron microscopy, you don't have to freeze it. You can take it into glutaraldehyde, which is a better fixative for electron microscopy. Now, going to that, why you should do enzyme histochemistry? You know, many of the pathologies in the muscle is due to enzyme problem, protein problem, and to identify the mitochondrial abnormalities or metabolic abnormalities, and also to fiber type it, or type 1, type 2 fiber typing is also, but because you can pick up the pathology based on the distribution of the fiber types. Okay, I'm not going to the normal fiber types, everything. If okay, because those are all physiological aspects, but you know that in muscle you have two types of fibers, type 1 and type 2. Type 2 is further, type 2A, B. Type 2C is regional fibers. Type 3 is fetal, like that. Type 1 and type 2 is a mixture of depending on the motor unit. Both are important. Type 1 is something which is slow rich in fat and other things, helps in slow twitching, okay, slow movement other things, but very sustaining one. Type 2 fibers are fast twitching, they fatigue, glycogen rich. So all of our muscles has got a combination of both. Depending on the muscle function, one of them may be dominant. Okay, most of the muscle fibers which we are biopsying are more or less 50 or 60, 55 like that. Okay, more or less. And that's why they are best to analyze it. Now, what are the applications of enzyme strains? Non-enzyme strains we discussed, right? MGT, all those things. Enzyme strain application, STH, succinic dehydrogenase, very important in picking up mitochondrial disorders. Very important in picking up central core is an area, is a type of congenital myopathy where the activity, oxidative activity is lost in the central area. Again, it's a developmental problem, congenital myopathy, type of congenital myopathy. Target fibers are neurogenic problem, which I will explain to you. Lobulated fibers or moth-eaten fibers are an indirect evidence of myofibrillar disorganization. If myofibrils are not organized properly, if they are degenerating, you will see them as moth-eaten fibers, which I will show you the photograph later. Okay. Same thing with NADH, but NADH has got one additional advantage that you can pick up tubular pathologies, tubular aggregates, or the sarcoplasmic tubular pathologies very well. Let's take now. SDH staining will be like this, or NADH staining will be like this, blue. Okay. Because the end result is a dye, nitro-blue tetrosome reductase will be converted into a deposit dye, blue dye like this. Now you see that this is a normal fiber, but what has happened here? You have got lobulations of something has eaten away, like that kind of picture, right? So it's called as moth-eaten fibers. Moth-eaten fibers are when the fibers have got small areas of unstaining. If these unstaining areas are little larger, you call it as lobulated. It indirectly indicates that the myofibrils are not properly organized. Normally, myofibrils are longitudinally arranged. They run long lengthwise. If they're here and there, if they are showing not circularity, it shows lobularity or moth-eaten. It indicates that myofibrils are disorganized. It's a primary myopathic problem. Now, this is what is called as target. This happens in neurogenic problem. See the difference between this and this. Target because you have a central area of unstaining, dark rim, and then normal staining area, 3 zones. Okay, target area, which is a problem when there is denervation. Next, this is core. Core is where there is no oxidative activity. This is a developmental problem of the proteins there. It's a type of congenital myopathy. All this you can pick up on special stains. If you do HND, it will look normal in all the 3. Okay, and this is a ragged blue fiber. Ragged is where the fiber is broken, cracked. Over that there will be blue deposits, oxidative deposits. This is a ragged blue fiber which you will see in mitochondrial pathology. Okay, ragged blue. Tubular aggregates you can see as something like blue aggregates or accumulation or inclusions, which you will see in only NADH. SDH will not stain the tubular aggregates. Let's come to cytochrome oxidase. Cytochrome oxidase is nothing but type 4 complex 4. You know, you have 5 complexes in mitochondria which help in electron transport. The complex 4 is cytochrome oxidase. So in mitochondrial pathology, this cytochrome oxidase will be maybe deficient, and that's what you see. Normal staining is like this, cytochrome oxidase. In a mitochondrial pathology, there will be cytochrome oxidase deficiency. Now, can you tell me, is cytochrome oxidase deficient in any of this? Normally, type 1 fibers are cytochrome oxidase, I mean, they are oxidative rich. So, COX staining will be very strong in type 1 fibers like this. These are all type 1 fibers. Type 2 fibers are light staining. Do you think this is deficient or type 2 fiber? That confusion is there, right? So whenever light staining is there, you have confusion. So you use a background staining of SDH combination. So when it is truly deficient, SDH stains. When it is not deficient, if it is type 2 fiber, it will be pale brown like this. Okay, so this helps in picking up mitochondrial disorders, very useful stain. Then ATPase, as I told you, 2 type fibers you can pick up. You do it on 2 pH. One is acidic pH 4.6, another one is basic pH 9.4. Acidic pH type 1 fiber will be dark. Basic pH type 2 fibers will be dark. In that I told you 2 types of fibers are type 2 and B. In ATPase 9.4, type 2 will be dark. In ATPase 4.6, there are 2 further subtypes. Type 2A is absolutely pale. Type 2B is intermediate staining in 4.6. If you can remember this, fine. If you cannot remember, you can refresh afterwards later on. So this is what ATPase helps in. Remember, acidic pH 4.6, type 1 fibers are dark, basic pH. And acid phosphatase, you know, it's a lysosomal enzyme. All lysosomal storage disorders, you will have acid phosphatase being accumulating. Okay. This is how acid phosphatase you can pick up staining. Next is median alpha glycerophosphate. I told you about protein surplus, right? There are certain abnormal proteins which can accumulate. There are certain myofibrillar proteins which can accumulate. They have reducing property instead of oxidative property. How to pick up them? You can do this reducing stains, median alpha glycerophosphate like this, it will be there. They will accumulate like this. Okay. Next is myophosphatase, you know, type 5 glycogen storage disorders is due to diffusion of myophosphorylase, Macquarie's disease. This is a normal control. You can do all these things only on cryosection only. Okay. Now, there are certain protein pathologies I told you which you can pick up on proteomic study, that is immunohistochemistry. For this, you have so many proteins available now, the list is expanding. Now, for a long time, these proteins are extremely sensitive. So if you fix it, it was very difficult to retrieve it and do it. So you know we are all comfortable now of tumor IHC, right? Tumor oncology we do on fixed tissues. But for muscle, somehow these proteins are extremely sensitive. When little exposure will cause cross binding, which is very difficult to release. So it was very difficult. Now we are standardizing some of the IHCs on paraffin sections because we are getting fixed tissues from faraway places. We have been successful in some of them. We are not successful in some in others, which we are still going with cryosections only. Okay, cryosection, that is important. Now for some of the proteins, they are deficient. Like dystrophies, you have deficiency of dystrophin proteins. For sarcoglycans, you have deficiency in sarcoglycans, like that. For protein aggregate disorders, you can have desminopathies where desmin accumulates, myosinopathies, myosin heavy chain disease, myosin are accumulating. Myofibrillar myopathies, I mentioned that name, myofibrillar myopathies, myofibrillar proteins are accumulating. Now, for some protein disorders, you don't have immunohistochemistry available because it's not a valid testing. For that, we do Western blotting. For some of the proteins which is very popular, you have to depend on Western blotting only, immunoblotting. Just be aware of it. You don't have to remember all this theoretical information. Now let's come to the actual pathological interpretation. The most important first step in understanding the approach is the architecture. That is where a muscle fiber, whether it is properly oriented in its distribution. That is, you know, muscle is a mass of fascicles, and fascicle is again a cluster of individual muscle fibers. And muscle fibers are again a collection of myofibrils. And these have got coverings, right? What is a muscle covered by? Muscle is supported by aponeurosis and fascia. But once you come inside, you have fascicle. And fascicle is separated by a perimysium. And individual muscle fibers are surrounded by endomysium. And you have one more thing called as epimysium, which is an extension of fascia which covers the entire muscle belly. Okay, or at least a muscle subcompartment of it. Now, this is how cryosection will look. This cryosection, you have a typical polygonal cell. A muscle fiber is a physiological giant cell where the muscle fiber periphery is a polygonal. Nicely, multiple muscle fibers are aligned nicely like a tile like this, mosaic. Okay, and the nucleus is pycnotic, or it could be elongated but dark staining, but it will be subsarcolemmal. Subsarcolemmal nuclei, multiple nuclei. Since it's a longitudinal muscle fiber, long running cell, the nucleus is placed at multiple distance, regular intervals like this. This is how all cryosection will look. Now, can you tell me, this is how normal, just recognize the boundary here. Can you make out a fascicle here? This is the fascicle, and you have got a boundary here. You don't have a proper thick wall or compartment, or thick wall or fence there, but you can still make out the boundary of the perimysium. The quantity of perimysium is important, appreciate that. Endomysium is very minimal, almost like two muscle fibers are touching each other. Now, what is the difference between this and the previous one? What has happened here? Well, yes, exactly. You don't know where the fascicle is starting. You don't know how much. One is the muscle fibers are not touching each other. Okay, so that means there is both perimysial and endomysial fibrosis, and that is causing disturbance in the architecture. When you cannot make out the normal orientation of a parenchyma or tissue, you call it as effacement, right? You cannot make out the cortex of the lymph node, medulla of the lymph node. You say lymph node architecture is effaced. You cannot make out renal glomeruli properly, all those things. You say glomerular architecture is effaced. Same thing here, muscle fascicular architecture is effaced. This effacement of architecture is the sign of degenerative disease of muscle, is the sign of dystrophic process, okay, is the sign of a genetic condition. But there are many other mimickers that we'll take later, but I'm telling you the sign, okay. Now, apart from fibrosis, there are other things which has happened to that. Can you appreciate that? That is, muscle fibers are no more polygonal. They become rounded. They're showing variation fiber size, unlike the previous one where they were all uniform. Next, they are rounded. They're also showing some of them are showing internalized nuclei, right? Which are not supposed to be there. They are actually should have been periphery. So up to 2% of muscle fibers can show internalization of nuclei, up to 2%. But if you see a newborn or up to 6 months, you may be able to see up to 3%, 4%, 5% like that. But at any level, it should not cross 5%. If it crosses 5%, it is pathological part of myopathic process. But if it crosses 30%, then it is one of the criteria for central core disease, congenital centronuclear myopathy, which is a type of congenital myopathy, centronuclear myopathy, which we'll discuss for the time. I'm just telling the context here. Okay, next. Now, what you can appreciate in the left one. Suppose you get a fixed tissue or you want to see the degree of fibrosis, distribution of fibrosis, you can do connective tissue stains. Mass spectrometry is one of the best one. That's a mass spectrometry is very important to do along with HND stain. And you can see on the left side very clearly the fascicular architecture. You can see fascicular architecture is here. The fascicular boundary is very clear. Where is the fascicular boundary here? The fascicular boundary is not at all clear here. So fibrosis has come up and disturbing the fascicular architecture. Can you appreciate here? You think here fascicular architecture is maintained? It is relatively maintained, but it is showing early signs of effacement. How? See, fascicular, the boundary of fascicle is not here. It is proper, but here it is not proper. And you can see fibrosis starting here, creeping. We call it as creeping fibrosis. Internalization of nuclei is there here, right? These are early signs of effacement. So next is appreciate the size and shape. They should be uniform in size, shape, and both it should be uniform, polygonal in shape. Any disturbance in this is again abnormal. It's a sign of myopathy. Primary myopathic disorder will show this one, especially rounding like this. Now, there is one problem. Here I will use pen here. Now, if let's take this is a muscle fiber. If there is a problem in the muscle fibris, what happens? The muscle will become rounded. Suppose if a muscle fiber, which is like this, is deprived of oxygen, deprived of blood supply or nerve supply, this muscle fiber will shrink, is it not? The shrinkage will become like this. The shrinkage will become like this, right? That means the muscle fiber collapses. Then the edges will become more narrow. You get what is known as angulated atrophic fiber. So angular atrophic fiber is a sign of neurogenic change, and rounded atrophic fibers like this are all sign of myopathic change. Both have got difference. Okay. So, but sometimes you can get pan-fascicular collapse. The entire fascicle has become shrunken because of a larger nerve involvement or an anterior cell involvement or spinal muscular atrophy, pan-fascicular atrophy. Okay. This is when a larger nerve fiber is involved, nerve trunk is involved. So whenever you talk about atrophy, you should talk whether the atrophic fiber is angulated, that is neurogenic, or rounded, that is myopathic, or hypertrophic as a compensation for both. Hypertrophy can happen as a compensation for both. Nevertheless, you have to pick up whether there is variation fiber size or not. Okay. Now you can appreciate two types: rounded atrophic left side, below is angular atrophic. Okay, angular atrophic, that image it is overlapping. Basically, angular atrophic is there on the behind. Can you make out your angular atrophic here? Yes or no? Yeah, that's it. Okay. Now, position of nuclei, I already told you, peripheral, normally it is peripheral, up to 2% it's fine, more than 2% is abnormal. As a safer side, 5% you can take as a cutoff. Now, another one is internalization. I've already told you internalization of nuclei. Now, this is a type of congenital myopathy called as centronuclear myopathy, where there are no dystrophic changes. Please understand this. Any dystrophy can also show internalization, but internalization will not be more than 30% generally. In the absence of dystrophy, but if you're seeing centronuclear more than 30%, it's a type of myopathy, centronuclear myopathy, congenital myopathy, belonging to the group of congenital myopathy. Next is overall, these are the things which you recognize. Let's come to the next feature. What is this? This is a regenerating fiber. You know, stable cells, labile cells, stable cells, permanent cells. Labile cells are all which are continuous in cell cycle like our epithelial cells. Stable cells are those when stimulated, they come into cell cycle like liver and all those things, connective tissue, bone. Muscle is also skeletal muscle. Muscle belongs to three categories. Like uterus, smooth muscle can be like labile cells or typical stable cell actually. When stimulus is there, cardiac muscle is permanent cell. You cannot regen, that's why infarct is there. Next is is skeletal muscle is neither permanent nor completely stable. It's in between. So there is some regeneration. These are the regenerative fibers. How to pick up regenerative fibers? They are smaller, they're blue, and they've got a nuclei inside. Okay, blue because of ribosomes, nucleus will be central, larger with nucleoli. That is a regenerative fiber. So this is, and most important here is, okay. Yeah. See, now you can pick up an hypertrophic fiber. Whenever a muscle fiber hypertrophies, it cannot what you call maintain the health of it. So it tends to break, it tends to show splitting and give rise to 2 or 3 fibers, and that's what you are seeing here, splitting, which can happen with any hypertrophic fiber. And this is very important. A myofiber, when it becomes necrotic, this what you will get. Okay, necrotic fiber, but here it's almost becoming myophagocytosed. This is how it will look. See the difference between this healthy fiber and myonecrotic fiber. Then you have regenerative fibers like this. These are regenerative fibers. So what this is necrotic fibers here, granular it is, paler, then myophagocytosis, then after myophagocytosis you have regeneration, right? So this is the sequence. Now these are the findings. Now summarizing all these things. Variation fiber size, rounded atrophic, hypertrophic fiber, myonecrosis, myophagocytosis, regeneration, whorled fiber is a type of appearance which you will see on STH and ADH only. Like this it will be. The myofibrils will be whorled like this, which you can pick up only on enzyme stains. That's the importance, because sometimes everything will be looking normal, but you will see whorled fibers, which is a sign of myofibrillar pathology. That is the one. This is how whorled fiber will look. See, can you make out whorled fiber? And another important thing is lobulated fiber, which I told you, that is again a sign of myofibrillar organization pathology. So all these are all signs of myopathy. Please understand, these are all signs of myopathy. Now sometimes on HND it may look normal, but on STH NAD strain you will see these lobulated fibers, which is again a sign of myofibrillar or disorganization, which indicates myopathic problem. So myopathy like this, right? I will just take 5 minutes because I don't want to compromise and come in the way of the next session. So this is the importance of special stains, where normal stains, the routine stains may look normal. Now these are the findings overall. These are all the findings of myopathy. Now one word is, the 2 examples I will take, 2 broad categories I will take. Suppose you see myopathic changes with inflammation is inflammatory, very simple. Okay. And in this, it's again a subcategory. You have subtypes within that. Like for example, these are the subtypes of inflammatory myopathies. That is when inflammatory myopathy has a dermal involvement, dermatomyositis, when it has got showing degenerative changes. Apart from inflammatory changes, if you see degeneration in the form of inclusions, it's an inclusion body myositis. When there is too much of necrosis, you call it as necrotizing myopathy. Polymyositis is, which doesn't belong to any of these categories, but now it is controversial, which I will explain to you if time permits. Okay. Now, dermatomyositis, all of you have learned right from our MBBS, right? Skin changes, heliotropic rash, periorbital, okay, malar rash, everything, Gottron's patches on over this knuckles, V-shaped thing, rashes, shawl sign over the shoulders, all these things are dermal changes. Pathogenesis is actually an antibody-mediated immune complex deposited microangiopathy it is. Okay, so you will see that the vessels are damaged. So what happens? The peripheral part of the fascicle undergoes ischemia. So because of this, you get peripheral atrophy like this. Can you see peripheral atrophy? You will see myopathic changes, but not a degenerative myopathy. Okay, degenerative myopathy is only in genetic and dystrophic process. But here you see myopathy without degeneration, that is without fibrosis, inflammation, perivascular or interstitial with peripheral atrophy. Inflammatory myopathy with skin changes with peripheral atrophy is dermatomyopathy. Skin will show non-specific changes or typical SLE changes because it's a kind of dermal interface dermatitis or anything in between. Okay, so this is a type like DLE changes or non-specific or in between any of those things you can see. Polymyositis is a type of myositis where you will not see dermatomyopathy type changes, but you will see inflammation around individual muscle fibers like this endomysium. That is polymyositis. This is actually mediated not by B cell, but it is T cell cytotoxic mediated. Now what is like this? This criteria is very important. It should be around intact muscle fiber, inflammation around intact muscle fibers. Now when you see polymyositis with inclusion bodies, That is inclusion body myositis. And the inclusions are in the form of rimmed vacuoles. Vacuoles which are rimmed, and that you can pick up only on MGT stains. Okay, I'll show you. And in addition, there may be secondary mitochondrial pathologies, fibrosis, everything. See, this is polymyositis change. But in addition, you are seeing inclusion bodies, right? This is inclusion bodies. There is an inclusion body myopathy. This is how you will get. And if you go for what are these proteins involved here, they're all degenerative proteins which are malfolded, misfolded. That's why they will have amyloid kind of staining, amyloid features. And on ultrastructure, you will see these kind of membranous worn out proteins like this, myelin figures. So inclusion body myositis is a combination of inflammatory myopathy with degenerative changes in the form of inclusions, in the form of vacuoles, in the form of rimmed vacuoles and fibrosis and abnormal proteins which will have amyloidogenic properties. Necrotic myopathy, where necrosis is too much with minimal inflammation, is necrotic myopathy, which you can pick up again. Next is when you see myopathic features with lot of fibrosis, with abnormal protein organization, that is in the form of lobulated fibers, moth-eaten fibers, then you call it as dystrophy. You call it as dystrophy, right? Inflammation may or may not be there, but what is important here is a degeneration in the form of fibrosis, in the form of hyalinization or myofibrillar disorganization like moth-eaten or lobulated fibers. Then you will see, then you will call it as dystrophy. The one which is prototypical of dystrophy is muscular dystrophy due to dystrophinopathy. Okay, dystrophy means basically degradation, degeneration. It is coming down, regressing it. So muscle fibers are lost. See, when you say neurodegeneration, that means the neurons are degenerating. They are losing out. In the same way, muscle fibers are losing out because the proteins are not able to sustain the life of the muscle fiber. So these are many varieties of classification is there. The one which is popular is a combination of genetic and pathological and clinical distribution like this. Here, one is based on genetic X-linked, the notorious being, the commonest being Duchenne muscular dystrophy, which is a very severe loss of dystrophin is a partial loss is Becker muscular dystrophy. Emery is another X-linked. Autosomal recessive is limb-girdle and some congenital muscular dystrophy. Autosomal dominant, limb-girdle can be again autosomal dominant also, both recessive and dominant. Then special types of dystrophy called as spatioscapulohumeral, depending on the distribution of the dystrophy, oculopharyngeal. One example, this is a very good from photograph from their textbook only. The distribution of all these things. Limb girdle is purely upper limb, shoulder girdle and pelvic girdle. So what you see in this, I told you already the pathogenesis, right? In all dystrophies, what happens? The proteins are deficient. They cannot sustain structural integrity and functional integrity, like cannot retain the calcium. Calcium is released, so they break open like this. Here, normal dystrophin, they break. Actin is it cannot keep the structural integrity. At the same time, calcium is released. These calcium activate proteinases and starts degenerating, disintegrating the proteins, and the muscle fiber shrinks. Muscle fiber degenerates. But the dystrophin is very heavy molecule. You have 3 compartments, single protein antibodies cannot demonstrate it. You need to span across the entire length of the dystrophin. So you need to have 2 antibodies across each span of the length of the dystrophin. So you have 3 proteins, antibodies you have to do. Dystrophin 1, 2, 3. That is to recognize the rod domain, C terminal towards the cysteine rich area, N terminal the amino area. All these 3 you have to do antibodies. So this is the most common. So one has to remember this very large protein. But there are many dystrophin associated proteins called as sarcoglycans. They also may be pathological. You get dystrophies. When dystrophin is deficient, you get dystrophinopathy. That is Becker's or Duchenne's, depending on the severity of loss. If sarcoglycans are lost or deficient, they are sarcoglycanopathy, which typically causes limb girdle muscular dystrophy, upper limb and the pelvic girdle lower limb. Similarly, you have dysferlinopathy, you have calpainopathy like that. How to pick up all these things? The classification of all these dystrophies is based on which protein is deficient, which gene is involved like that. How to pick up the same myopathic features you will see on HND. So on HND, even if it is in a fixed muscle, you can pick up dystrophy. But you cannot go further, tell which type of dystrophy it is. For that, you have to do enzyme histochemistry, but that also will not type to, it may give clue, but you have to go further for immunohistochemistry. So this is a typical dystrophy you will see, and a well-established dystrophy on the right side with a lot of fibrosis which has happened. And as I told you, to subtype a particular of dystrophy, you have to go for proteomics, that is immunohistochemistry. Like in this first case, you can see all the dystrophins are deficient, typical Duchenne muscular dystrophy. If it is Becker, one of the dystrophins may be deficient. That is a Becker dystrophin. Suppose if it is sarcoglycanopathy, dystrophins are normal, one of the sarcoglycans are deficient. Okay, that is a sarcoglycanopathy. Similarly, you have for dysferlin, you have. But some proteins, what has happened, you don't have immunostimulation available for that because the technique will not be suitable. For that, we do Western blotting. Okay, Western blotting. This is a case of dysferlinopathy. So that is about this. Now, one word about congenital myopathy is how you classify congenital myopathy. The difference between congenital myopathy and other genetic myopathies, this is also genetic myopathy. But it's a purely developmental problem because in other dystrophies, what happens, the patient, the muscle reaches normal level, then it disintegrates. Here, from the beginning, there is many developmental defect. There is no sign of degeneration here, no fibrosis. But in an adult, in a typical dystrophy, what happens? It reaches normal stage, then degenerates, fibrosis happens. But here, no fibrosis, no normal. They will be from the beginning abnormal, like in the form of Nemaline myopathy, where actin disc or sorry, Z-actinin will be accumulated. Central core, where oxidative activity is not proper because of the developmental problem. Then myotubular myopathy, the nucleus will be remaining there in the central. Congenital fiber type disproportion, where type 1 and type 2 has to be admixed, but here it is not getting properly admixed. Only one fiber is dominating, one fiber is hypertrophic, one fiber is hypoplastic, like that. So that's here, this is a myotubular myopathy on the left side, X-linked, centronuclear myopathy on the right side. See the centronuclear, so many, no dystrophic changes at all. Central nucleus is there, more than 30% of the fibers. Central core, you can see this, you can pick up only on STH and ADH if you do any of those things. Multi-mini cores, they say a type of core where small cores are there, multiple. Congenital fiber type, I told you, they're not admixed. One fiber becomes hypoplastic or hyperplastic, like this it is. All these things, they manifest in the child as weakness, hypotonia, respiratory difficulty, okay, and like that. So metabolic myopathy, one word, you know, I don't talk about PS because you learn better in liver and in that construct. Fat also, this is a typical glycogen storage disorders with typical PS positive deposits. Then this typical macrocytosis is more common because of myophosphorylase, typical muscle specific phosphorylase. That is 7 pompous, can again involve lipid storage, you do oil redo. Most important is mitochondrial. One word about mitochondrial, because mitochondrial, you know, mitochondria is another organelle which has DNA material. Okay, so there are many myopathies where mitochondrial DNA is problem. So that you can pick up only on mitochondrial analysis. For that you have to do this battery of stains. The most important being MGT, which picks up ragged red fiber, COX deficiency. Then on STH innate you will get ragged blue fiber like this, ragged blue fiber. MGT you get ragged red fiber, COX deficient fibers. But if you actually do special stains like this, you will be able to pick up only in 10% of the case. Just imagine 10% only it will pick up. Normal HND will be absolutely normal, no difference. If you do fMRI microscopy, another 2-3% increase. This is our study. You can get abnormal mitochondria, either in size, shape, crystal abnormality, or phonographic. So to avoid this, many of the mitochondria may look normal, but they are functionally abnormal. The complexes may be abnormal. For that, we have to do mitochondrial respiratory chain assay, which is a biochemical analysis which we do from tissues. So though this is a biochemical domain, but we do because we correlate better. That has increased the diagnostic yield from 10% to 55% to 60%. Just imagine. So what about remaining 30-40%? It will depend on the clinical scenario and genetic, but now it's sophisticated more and more better. We have reached up to 65%, but other 30% we are still struggling with that, which we do genetic. Neurogenic, you know, angular typical, just I'm ending now. Genetic angulated atrophy fiber you can pick up like, see, typical angulated atrophy fiber, hypertrophy fiber as compensation. Sometimes everything will look like normal like this, but only when you do 80% you can pick up grouping. Now this is abnormal. I told you type 1 and type 2 should be admixed like a mosaic, but here it is grouping, which is an indication there is a neurogenic process happening, and that's an indication of that. Target fibers can come in that. So this is that sometimes you get occasional atrophic fiber, but grouping is there, you can pick up very well. That's it. About this, I think this is the last fiber. Yeah, last one. So what I would like to tell you is, now the situation scenario is changing now. Earlier, it used to be clinical, then directly they used to do biopsies, but now they are going for radiology. Okay, then genetic, all these genetic conditions. Now we are coming later only, we are coming. Okay, that is this part. Histopathology is coming later. But ultimately, the final answer is given by histopathologists only. They may avoid us for a great extent. Same thing holds good for any aspect of it. We are coming at the end, but the gold standard still remains. But definitely, if you see, sometimes when they try to correlate genetic also, you can add genetic. Many times if you combine all the results, it may be many times it will be confusing. The most confusing will be genetic results. It will be out of the box. So what will solve the problem in that situation will be histopathology. Okay, many times genetic results will be all variation of unknown significance. All those things will come, but ultimately histopathology comes to the rescue. So that's why still we have a role. May not be a major role, but still we have our place. But only thing is we have to equip with more and more advancements what is happening that. And that is the purpose of whole CME like this, which we have to regularly attend, interact and learn from this. Okay, thank you so much.
Thank you so much, sir, for enlightening session on muscle biopsy interpretation, especially the practical aspects mentioned were highly illuminating. I would request Dr. Ramaswamy, sir, to hand over token of gratitude to our moderator, Dr. Rajshekhar, sir. Yes, Dr. Kalam, sir, to moderate next session, and Dr. Jyoti, madam. From GMC Kadapa. I'm privileged and humbled to take the opportunity to invite Dr. Kumar Guru BN, sir. Sir has completed his MBBS from KIMS Bangalore, PCP from KIMS Hubli, MD from JSS Mysore, and he's completed his DNB in the year 2014. Sir has 40 publications in his credit, and he has a total 10 years of experience past his MD. Sir is a field of interest is in cytopathology and neuropathology, renal pathology. He's an active member in IAPM AP chapter, IAPM and KCIAPM IAC. Sir has received awards in outstanding research in the pathology in the year 2021. And Sir has received Dr. Monisha, Dr. Panna Chowdhury Memorial Award in the 2023 and won prizes to add his glory. He has won third prize in Senior Faculty Award category at IAPM AP Annual Conference 2018 and second prize in Senior Faculty Award category at IAPM AP Annual Conference in the year 2019. We would request Sir to share his knowledge about squamous cytology in CNS lesion. Over to you, sir.
Good morning. Good morning, everybody. I'll be covering, thank you for the introduction. I'll be covering role of squamous cytology in CNS lesions. I had posted pre-test. Good number of candidates, students have attempted the same, around 60 plus. Yeah, I am happy that you attempted. But scores you can definitely improve. Please be attentive. I want 100%, 10 out of 10. After hearing the class, I will post the post test. I want that result. Please try to listen carefully. This is my lesson plan. Introduction, I will cover the basic points, procedure, what is the exact procedure, then algorithmic approach, that is pattern-based approach. Under each of the pattern, what are all the entities that will come, differential diagnosis that I will enlist. Then we will have some case-based learning or approach. That is the application of previously what you have learned. That is the pattern-based approach. Then discussion, I will just tell few noteworthy points. Then I will wrap up with take-home message. Coming to the introduction, the central nervous system lesions are known to the mankind since 1774. Few decades ago, it was stated that brain tumors were uncommon in Indians. Is it true? No, it is not true. It was there, but we didn't have the facility. We didn't have that infrastructure. We didn't have the investigative modality. The reason why the incidence was low. Recent investigative technique, with the advent of recent investigative techniques, the brain tumors have emerged quite common in India as elsewhere in the world. The advancement in neurosurgical imaging has enabled us, that is our colleagues, to readily characterize many of these CNS lesions. Sir had spoken about that basics of neuroradiology in the morning. If you are attentive, you can pick up many of the lesions which I discussed in the case-based approach. A rapid intraoperative diagnosis of space-occupying lesions of CNS helps the neurosurgeon, firstly, to confirm whether the tumor is present or not. Why? It could be normal brain tissue also. Presence of tumor, number one. Number two, based on my diagnosis, I may give low-grade glioma, high-grade glioma, etc. Sir will plan, neurosurgeon will plan or modify his surgery accordingly. How I will explain. Neuroimaging guided techniques permit precise localization and frequently necessitate pathological assessment of minute tissue specimens. How minute it is? 2 millimeters. I just get 2 millimeters. 1 millimeter I will take for squash. Another millimeter I will subject it for the histopathology, routine histopathology. I will put it into formulae. We need very good rapport with our clinical colleagues. Who are they? Radiologist and neurosurgeon. I have to build good rapport with them. Then only I can give justice to the patient. I can reach the accurate diagnosis. What is the basic purpose? Once I receive what is the surgeon expecting from me? The specimen comes, he is interested to know whether it is lesional tissue or whether it is normal tissue, no lesion. Why? If there is no lesion, he might have taken out a small bit of normal brain tissue. That is what he is worried. Next, if it is lesional tissue, whether it is neoplastic or whether it is non-neoplastic. If it is neoplastic, is it primary or is it metastatic or secondary? Next, if it is non-neoplastic only, is it cystic lesion? Is it inflammatory lesion? Is it vascular lesion? Or is it just necrotic lesion? If it is primary, he is worried whether it is glial or non-glial. It matters. Line of treatment is different, line of management is different. Now, non-glials can be sometimes more, it will have different prognosis, worse prognosis. Glial, if it is low grade or whether it is high grade. This is what matters. And finally, I will be concerned about this more because most of the time it will be glial, whether it is low grade and high grade or high grade. What does it? Again, the non-glial will be again low grade or high grade. How does the grade matter? Imagine the surgeon, they have got different schools of thought. What school of thought I am presenting here appears more logical to me. Low grade, he will go for complete resection. High grade, he will take care to avoid resection of the normal tissue. Why? Low grade means grade 1 and 2. High grade means we can take 3 and 4. If it is high grade, what is the characteristics of high grade? It will infiltrate into the normal tissue. Now, he cannot manipulate or play around more with the normal tissue. What if he's playing around more with the normal tissue? Normal function of the brain, normal area is gone, normal function of the patient is gone. That is it. So, low grade, he will not worry. He will go for aggressive resection. High grade, he will stop. Then, sight matters. How does it matter? Surgery is avoided if the tumor involves critical area. Tumor involves the critical area. What does it mean? What if the tumor is located in the brainstem area? What is there in the brainstem? Respiratory center. Even if it is benign, he will not touch. He will not touch. He prefers not to touch. Why? There are instances patient may die on the table. Does he take risk? No. This is 2021 WHO classification. I will not go into the details of the classification. I will just skip through, but just try to know what are the main categories. Gliomas, glioneuronal tumors and neuronal tumors. Again, it has got 6 subcategories: the adult type, diffuse, pediatric type, diffuse, low grade and high grade. Then circumscribed astrocytoma. Then we have got glioneuronal and neuronal tumors, and finally ependymal tumors. These are 6 categories. Next, choroid plexus tumor, embryonal tumor. Under this, medulloblastoma is important. Pineal tumors, cranial and paraspinal nerve tumors. Under that, schwannoma is important. Meningioma, then non-meningothelial mesenchymal tumors, chondroosseous tumors, then melanocytic tumors, hematolymphoid malignancy, among which the lymphomas are important. Germ cell tumors, then tumors of cellular region, finally metastatic tumors. This is the recent WHO grading. Irrespective of whatever is the grading, I am just in the squashmere. What I can state is low grade or high grade. Now coming on to the procedure, intraoperative cytological preparation was first introduced by Eisenhardt and Cushing in 1930s. The technique was further championed by Russell et al. The present technique was introduced by Russell et al. And Sir Hugh Cranes. How is the procedure done? Smears are prepared from tissue samples sent in isotonic saline. Yeah, we do encounter problem. Neurosurgeon has to coordinate with the interns, PGs. If he is coordinating with the interns, then becomes a problem. Intern may and also nurse, they may put in formalin. No, I have to have given clear instructions. You also should give clear instruction. It should be normal saline. Next, viable tissue is dissected. How to dissect? You will get a small piece of tissue. How much small? 2 millimeters. How to dissect? Gray white areas only dissect, because areas, hemorrhagic areas can be there. I don't want. Necrotic areas may be there. Necrotic areas, I will come to that later. Necrotic areas, people tell it is not important, but I feel it is important. What you do, take necrotic area, put it onto some different slide. What to do with that slide, I will tell. Slides are then stained with rapid hematoxylin and eosin. Please remember rapid, because I want result within 30 minutes. Then gray May-Grunwald Jimsa, you know, it itself will take 30 minutes. I do not want to waste so much time. I will do it only for research purpose. Then Papanicolaou method can be done, yeah, and examine for cytomorphological details. Entire staining procedure, make sure it is within 10 minutes. Okay, plus or minus 2. Okay, special stains are done in selected cases. Once what happened? It was middle of the night. Sir had sent me. I smeared. I saw only necrosis, and here and there some scattered macrophages were there. Diagnosis was clinical diagnosis was metastasis. Now I got it because I saw some epithelioid cells. I got a strong suspicion. Let me try. I asked the neurosurgeon, please extend the anesthesia. I am not able to report within 30 minutes, plus 10 minutes I may take. Then I asked the I did AFB staining, came positive. I had a strong suspicion, am I missing tuberculosis? What did the neurosurgeon told? Sir, you have saved my day. That is the relief he gets when we give the accurate diagnosis. The rest of the tissue is transferred to the to 10% formalin. Ideally, the report should be communicated within 30 minutes. How do you communicate? Next question. Please call neurosurgeon or their assistant. Repeat the diagnosis 3 times if possible, or one time also is enough, but according to the protocol 3 times. Low grade glioma, low grade glioma, low grade glioma, etc. Then don't remain silent. Ask them to repeat back to you. Have they followed what I have told? That is the protocol that you should follow for communication. Communication should be very clear. Now coming on to the preparation, this is how I do. Take a small bit of tissue that is about 1 millimeter, deposit onto the slide, place it on the slide, crush it between your index finger and the thumb, crush it properly, then pull it apart. You will have smear. Then go immediately fix it in H&D. Most of the time I prefer H&D, though I do other types of stain only for research purpose. I will not play around with the diagnosis. Coming to the approach to the diagnosis, you have got almost 11 parameter you need to use, that too within 30 minutes. You have to be really very fast, very quick. Age, gender, site, clinical details, including the imaging studies, then pattern, smearing pattern or smear pattern. Then you have to assess the cell population, cellular arrangement, then nuclear features, cytoplasmic features, and background. These 4 I will cover in detail. Then relationship to the vasculature. Totally 11 entities you have to keep in mind, because each of these have got significance. Let us see. Age, less than 3 years. These are the common tumors that can happen. Medulloblastoma, pilocytic astrocytoma, ependymoma, choroid plexus tumor, and germ cell tumor or teratoma. Next, 3 to 15 years, pilocytic astrocytoma, medulloblastoma, ependymoma, astrocytoma, and choroid plexus tumor. 15 to 65 years, glioblastoma. Don't worry about the anaplastic and all. Anaplastic, the terminology is gone. Just we will tell astrocytoma. I will restrict to that. Then meningioma and pituitary tumors or neoplasm. Then metastatic cause, more than 60 years or elderly, 65 years or elderly, metastatic carcinoma, glioblastoma, astrocytoma, meningioma, and acoustic schwannoma. Now, distribution, anatomical location. Our anatomy knowledge is very important. Intraparenchymal, it can be either supratentorial or infratentorial. What are the tumors? Supratentorial, astrocytoma, glioblastoma, oligodendroglioma, and ependymoma. In the intraparenchymal, infratentorial, you will have cerebellar astrocytoma, medulloblastoma, ependymoma, and hemangioblastoma. These things are common for both metastatic neoplasms, lymphoma, inflammatory lesions, and vascular disorders can happen in both the areas. Now, coming on to the intracranial lesion, extraparenchymal, that could be meninges, etc. So, supratentorial meningioma, it could be metastatic neoplasms or epidermoid or dermoid cyst, rarely. Then can have in the infratentorial part, schwannoma, meningioma, metastatic neoplasms, and glomus jugular tumor, rarely. This is a very important topographic diagram. Please try to remember. In the cerebral white matter, astrocytoma and glioblastoma, more common. At the junction of gray matter, white matter, metastasis, usually metastasis. Next, deep-seated in the young, astrocytoma, and older individuals, glioblastoma. Cystic cortical, here it could be especially in the temporal area. Ganglioglioma is common temporal area. Patient also can present because it involves temporal area. What you can expect? Even DNET can also happen. patient may present with seizures, temporal area. Then pleomorphic xanthoastrocytoma and pilocytic astrocytoma. Here, then we will go to the oligodendroglioma is usually cortical based. Then periventricular areas, lymphomas you can get, then choroid plexus papilloma, cystic cerebellar lesion in the young pilocytic astrocytoma, and older individuals hemangioblastoma. Solid. What if it is solid? It could be medulloblastoma. Now come to the cerebellar part, that is brainstem part. Okay, in the here you have got pons, glioblastoma, then choroid plexus papilloma, and fourth ventricle ependymoma. In the cerebellum, you have got metastasis. Then the solid cerebellar, central cerebellar, here I have already covered. In the spinal cord, ependymoma and glioblastoma. What if it is spinal terminal? Most common diagnosis what we encounter is myxopapillary ependymoma and paraganglioma. Paraganglioma I have not seen much. Now coming on to the smear pattern. When will my thought process start? The moment I smear, I will have something in my mind. How? See this smear pattern. It has got large clumping here. Then there is decreasing gradient. Okay, and this gives rise to varying shades. You can have cotton wool pattern or steel wool pattern. What is this? It is because of the tumor cells attaching to the vascular structures. Why these patterns, what is especially steel wool pattern, cotton wool pattern indicates high grade gliomas. So this different shades and steel wool and cotton wool pattern has got you have to think of glial tumors. I am trying to many things are given in textbook, but I am trying to make it very simple so that even you can diagnose. Next, come to meningioma. Here you are seeing very large clump at one end, spicules that radiate out from the clumps. What about schwannoma? Though I have written bar schwannoma, sometimes you can get similar pattern, but in the schwannoma, more common pattern is you will see large clumps at the edge. At the edge means here. It can be here at the edge of the smear. There you will get that schwannoma pattern. Then, so there is minor difference. What if it is single, large, smooth, and even gradient like this? Pituitary tumor or some round cell tumors you have to think. Not only that, sometimes even normal brain, if we get that can also show this pattern. So when I will come to know only if I put it under microscope. Coming on to the cellularity, highly cellular, high grade lesions, low cellularity, low grade lesions, and also neurofibroma. By any tumor which has got lot of collagen, it will not yield properly. That is the reason. Then cell population, either it can be monomorphic or heterogeneous population, uniform population or heterogeneous population. Monomorphic population, usually it signifies tumor because of the clonal proliferation. Heterogeneous population, there are differentials. It could be normal smear we should not forget. Then it could be reactive process, it can be inflammatory process, and lastly it can be even the tumors. What type of tumors? Mixed type of tumor. Then I will come to these four important things: cellular arrangement or cell arrangement, then cytoplasmic feature, nuclear feature, and background. Very important algorithm. Please try to register. It can be either cohesive cellular arrangement or it could be discohesive. What are the conditions you have to think? Under cohesive, glioma, then meningiomas, then germ cell tumor, craniopharyngioma, metastatic tumor, nerve sheath tumor, and choroid plexus tumor, and ATRT, that is atypical rhabdoterata tumor. Discohesive, this terminology is gone. You can replace this terminology with embryonal tumors. Then lymphomas and pituitary neoplasm. What if it is fibrillary cells and well spaced out? Reactive gliosis. But if it is fibrillary and well aggregated, you have to think of astrocytoma and glial component of the ganglioglioma. Glial component of ganglioglioma. Then you got tissue fragments which are adherent to the vessels, ependymoma. What not only that, I will show the ependymoma part. You should understand the relationship between the blood vessel and the tumor cells. It will be further away from the tumor cells, and it will be bridged by the glial processes. That is the diagnostic. Floating neurons, DNET, that is disembryoplastic neuroepithelial tumor. What do you mean by floating neurons? Neuron cells will be there. Any cell has got cytoplasm and the nucleus. The cytoplasm is stripped off. Only the nucleus is there in the background, that is floating. Okay. Meningothelial holes, meningioma. Then ample amount of cytoplasm you will see in the ganglion cells of ganglioglioma. Small irregular rosettes with neuropil islands, it is seen in neurocytoma. Then hair-like processes and with elongated, and Rosenthal fibers, very characteristic feature of pilocytic astrocytoma. Next, come to nuclear cytoplasmic features. No, it is not working. Okay. Cytoplasmic features, processes, it is astrocytoma. If it shows processes, then it's a glial processes. Astrocytoma means it is glial tumor. Astrocytoma, ependymoma, meningioma, nerve sheath tumor. What if it shows cytoplasm shows clearing, germ cell tumor and chordoma? What if it is vacuolated, hemangioblastoma, chordoma, most important? Then you can also expect adenocarcinoma metastasis and pleomorphic xanthoastrocytoma. Now come to the what if it is granular, pituitary neoplasm and melanoma? What if it is very scanty, lymphoma? Please think of lymphoma, then embryonal tumor and oligodendroglioma. The name why it is called oligodendroglioma is the processes will be few, few. Now this I have already covered. I will not touch that. Glassy cytoplasm, sega, subependymal giant cell astrocytoma. Now come to the nuclear features. What if it is round cell tumors, that is oligodendroglioma, neurocytoma, pituitary adenoma and lymphoma? Then how do you, most important point, how do you differentiate between oligodendroglioma and lymphoma? Lymphoma will show lymphoglandular bodies, oligodendroglioma will show fibrillary cytoplasm. Fibrillary cytoplasm will not be there in lymphoma. Fibrillary background will not be there in lymphoma. Then oval or elongated, astrocytoma, then ependymal tumor, meningioma, nerve sheath tumor and choroid plexus tumor. What if it is hyperchromatic? Again astrocytoma, pituitary neoplasm, nerve sheath tumor, lymphoma, germ cell tumor and embryonal tumor. Increased pleomorphism and mitosis, it could be signifying high-grade glioma, metastasis and germ cell tumor. What if there is nuclear indentation? Again high-grade glioma, lymphoma and chordoma. Prominent nucleoli, where and all you will see, ependymal tumor, ganglioglioma, you cannot forget, lymphoma, oligodendroglioma, germ cell tumor and metastatic tumor. Pseudo inclusion, please don't forget meningioma, we can see pseudo inclusions, melanoma also, then glioblastoma. Salt and pepper chromatin, there are only two, neurocytoma, pituitary neoplasm and sometimes medulloblastoma. Background, fibrillary background, glial tumors like astrocytoma, ependymoma, then reactive gliosis and oligodendroglioma. Necrosis, high-grade glioma, we should not forget treatment. The reason why I need prior history of the patient is the patient treated with radiotherapy. Then also you can expect necrosis, embryonal tumor, lymphoma, metastasis and germ cell tumor. Rosenthal fibers are seen in pilocytic astrocytoma, craniopharyngioma, hemangioblastoma, not only within the tumor, even adjacent to the tumor. Some bodies seen in meningioma. Keratin material can be seen in craniopharyngioma and dermoid cyst. What type of keratin? Here it is wet type of keratin. And dermoid, it could be epidermoid also. Lymphocytes are classical or characteristic features for ganglioglioma, pleomorphic xanthoastrocytoma, and also germ cell tumor. Neuropil characteristically you will be seeing in neurocytoma and also medulloblastoma. Myxoid matrix in neurofibroma and other myxoid tumors. This list is not limited. You can construct your own algorithm when you are practicing. I am just giving you the example. Now, relationship to the blood vessels. See the first diagram. There are three pattern: perivascular gradient pattern, angiocentric and diffuse pattern, and the randomized clusters with or without vascular affinity. Come to the first one, perivascular gradient pattern. What you are seeing here, cells are more concentrated toward in the blood vessel, towards the blood vessel. As you go away from the blood vessel, there is a gradient. Cells appear to be more spaced out. Where do you see? Astrocytoma. Next, see this diagram. Cells are definitely concentrated like the previous one, but it is more concentrated in the blood vessel. And see, surrounding the blood vessel, what is happening? There is no gradient. Even if the gradient is there, it is equally spaced tumor cells. So it is angiocentric and diffuse pattern lymphomas, large cell high-grade lymphomas. Next, here randomized clusters are there. It may or may not be in relation to the blood vessel. Metastatic carcinoma. The most common we can see colon. Now coming on to the type of blood vessel, either thin walled blood vessel or endothelial cell proliferation. Where do you see thin walled blood vessels? Oligodendroglioma. Then grade 2 and 3 astrocytomas. Metastatic carcinoma, lymphoma is common. Then gliosis. Endothelial cell proliferation you can see in, please remember, glioblastoma. This one is common. Metastatic carcinoma and lymphomas are common. Now we will go to the cases. We will have some interaction. If you want, please, I want you to participate. 14-year-old male, temporal region, what are you seeing? I will explain, you just tell me the diagnosis. That's all. You are seeing one large cell with showing prominent nucleoli, and small cells are also seen, fibrillary background, fibrillary matrix. What do you feel? And also some indented nuclei. Okay, I will just change. Pen I will use. Can you see this particular cell? It has got small indentation, very tough to make out when compared to the other cells. Okay. These are the features. It is a normal smear. Why? You are seeing heterogeneous population of the cells, neuronal cells and glial cells. There is astrocytes, there are oligodendrocytes, neuronal cells. What it could be? Normal smear I already told. From where? Gray matter. Why? You are seeing neuronal cells. Okay. Next, 5-year-old male, occipital region. Some dark blue cells you are seeing. Yeah, uniform population. Then very large cell you are seeing, which is got again prominent nuclei, not so much, not as small as this one, but very large. What it could be? Normal smear, heterogeneous population, Purkinje neurons. These are all Purkinje neurons, internal granular cells. These are all internal granular cells. So it is from the cerebellar cortex. Okay. Go to first case. 10-year-old male, right frontal lobe, well circumscribed mural nodule with cyst. I think some of you have already diagnosed. You are seeing some elongated cells. Concentrate on this cell, elongated cells. There are some elongated cells. Then classically you are seeing some thin hair-like cytoplasmic processes. Okay, there is, what is this? Clustering is also there. It is spread out also. these are the elongated cells. When you see the elongated cells, definitely it is a neoplastic process. If it is non-neoplastic process, reactive and all, you may not find so elongated cells. It can be still round. What about the cytoplasm? Cytoplasm will be more condensed, somewhat like this. If it is neoplastic process, it is not condensed, it is reactive. Cellular smear, these are the other features of the condition. Cellular smears, diffusely scattered cells or cluster cells may be in cluster. Monomorphic bipolar cells, fine hair-like processes, elongated nucleus, coarse chromatin. It has got cells have got coarse chromatin, that is nucleus, fibrillary background. Then Rosenthal fibers, it is not there. I will show. Then eosinophilic granular bodies also you can see. What is the diagnosis? Very good. Great. This is from my personal collection. Why I focus this is you are seeing some fibers, no? Here, Rosenthal fibers. This is the histopathology of the same case, Rosenthal fibers. Very beautifully made out, pilocytic astrocytoma. 60-year-old male bilateral frontal lobe lesion. It is also involving corpus callosum, subcortical in location, butterfly-shaped contrast enhancing lesion. Very classical history. See here, you are seeing some cells, glial cells, fibrillary background is there, but what is the nature of the cells? It is showing some pleomorphism, and also there is a increased cellularity. Clumped nuclei, nuclear chromatin is there, and you are also seeing, if you closely observe, some giant cell formation is there. Giant cell formation is there. Some vascular endothelial proliferation, it is corresponding to something called as glomerular body. Here, highly cellular smears, pleomorphic cells, fibrillary cytoplasm. These are multinucleated giant cells. Tumor cells which are adherent to the blood vessels like this. Then endothelial cell proliferation with glomerular bodies, and there can be necrosis. I have not focused on the necrosis. What is your diagnosis? Great. Histopathology of the same. Highly bizarre cells, multinucleated giant cells, then glomerular body you are seeing. Case number 3 of middle-aged male for right frontal lobe, hypodense, well demarcated cortical lesion with areas of calcification. Monomorphic cells you are seeing, small blue round cells, fibrillary side background, fibrillary background. That's all you can appreciate. Now you go to the high power. In the high power, some open type of chromatin with clumped chromatin you are seeing. So if you see carefully, some cytoplasm is also there. It does not correspond. This is droplet, I can say, I feel. This may not be droplet, okay. But still we can see those things. Cellular smear, diffusely scattered clusters, scanned cytoplasm, eosinophilic cytoplasmic droplets, rounded, yeah, please remember, oligodendrocytes can have rounded or lobulated nucleus. Coarse chromatin, small nucleoli, fibrillary background. Mini gematocytes also you can see in this particular condition. Calcification also can be seen. What is the diagnosis? Oligodendroglioma. Yeah, this is my personal collection. Thin walled blood vessel you are seeing, and monomorphic population of the cells and fibrillary cytoplasm. This is the histopathology. What appearance is it showing? It is pre-egg, post-egg appearance. Okay. Why? Because it is artifactual halo. 10 years old male, right lateral ventricle, large circumscribed, cauliflower shaped, irregularly contrast enhancing lesion. Cauliflower. Remember cauliflower. You are seeing some papillary formation, monomorphic population of the cells. Some polarity is also there. Okay. This is high power, some clumped chromatin and monomorphic population. That's all I can make out. Inconspicuous nucleoli. Okay. Papillary pattern, classical. This is called as honeycomb pattern. What is the nature of the cells? Cuboidal or low columnar, polarized epithelial cells, distinct cytoplasmic border. Yeah, I think it is difficult for you. I think, yeah, you can still observe. Screen is good. Distinct cytoplasmic border, and some of bodies also you can find. What is your diagnosis? Choroid plexus papilloma. This is the histopathology. papillary structure lined by the tumor cells. 14-year-old male, epileptic. Right location is right temporal lobe, circumscribed solid lesion with areas of calcification. I am seeing some varied cellularity. Some it is clustered here, more cellular here. Here it is not much. And also, if I closely observe, I am seeing dual population of the cells, and this is calcification. This is calcification. And there are glial cells, and also there is some larger cells. Very large cell, prominent nucleoli, and this is the cytoplasm of the particular cell. Ganglion cells, they are dysplastic. What is dysplasia here? It can show variation in size, and also it can show sometimes multinucleation. It can show bizarre. It can be glial cells are also there. Fibrillary background, calcification. What is your diagnosis? Very good. Temporal lobe ganglioglioma. This is the histopathology of the same. 30-year-old male, right lateral ventricle, heterogeneous hypointense lesion with areas of calcification. Again, calcification. Some round cells are there. This is a vasculature, thin blood vessel. Then it is showing classically salt and pepper chromatin, uniform population of the cells, monomorphic, and also you are seeing salt and pepper chromatin. Cellular smear, monomorphic population, monotonous population, little cohesion is there. Then small round cell, neuropil matrix is there. This is very important. Neuropil matrix, salt and pepper chromatin. What is your diagnosis? Pardon? Yeah, central neurocytoma. These are the thin walled blood vessels. What you are seeing here, it corresponds to. It is almost a mirror image. Cytology or squash smear is nothing but the mirror image of histopath. Please, that is what I feel. Next, 7-year-old male, right cerebellar hemisphere, intensely contrast enhancing nodular grape-like lesion. Quite, yeah, intermediate size or large intermediate size cells, somewhat monomorphic also. Here also it can have salt and pepper pattern and clump, but it is showing some clumped chromatin. See the arrangement, rosetoid arrangement. Not only that, the arrow mark is pointing towards nuclear molding. Here also nuclear molding. It is arranged in circles and chains. This is chain. This is circle. Cellular smears diffusely scattered, pleomorphism can vary. Then scanned cytoplasm, it has got nuclear molding with characteristic feature. Salt and pepper chromatin can be there, just like neurocytoma. So it is also arranged in circles and chains. Streaking can be seen. Apoptotic bodies also can be seen. Mitotic figures are characteristic feature, and also neuropil matrix. What is your diagnosis? Medulloblastoma. Okay, important. The author of the one particular book is there. He has described dog in groups. It is in groups. It is not discrete. Dogs in groups. This is the photo of microscope photograph of personal collection, where similar kind of picture was there. Small blue round cells. You can also see some what is that? Apoptotic bodies. Histopathology of the same, it was showing some septations, that is fibrous tissue in between, and these are the tumor cells. Next case, 70-year-old male, right frontal lobe, supratentorial location, densely enhancing lesion, ring enhancing lesion. Now, you are seeing some small blue round cells, a scant amount of cytoplasm. These are the apoptotic bodies. They are discretely arranged. They are not much cohesion, but discretely arranged characteristically. So cellular smear, monomorphic, monotonous population, then lymphoglandular. These are lymphoglandular bodies, non-coherent cells, discretely arranged, scant cytoplasm, single or few nucleoli, mitotic figure, and also you are seeing apoptotic bodies. Author describes this as leopards. This is a lymphoma, histopathology of the same, mitotic figure. Usually what type of lymphomas you can see? Usually it will be B cell lymphomas are common. Diffuse this one. 36-year-old male, location is phylum terminal, sharply circumscribed intramedullary lesion with cystic change. You are seeing endothelial cell proliferation, endothelial cells, and tumor cells are here. It is cuboidal type of cells, and it is spaced out. These are the glial processes. Then you are seeing some lakes, myxoid lake encased by the tumor cells. Description: papillary or rosetoid pattern, perivascular radiating cells, myxoid spheres or lakes encased by the tumor cells, cuboidal cells, epithelial, it has got epithelial appearance, and it is bland and monotonous. What is your diagnosis? Very good. It is myxopapillary ependymoma, myxoid lakes. I have already given the clue. This is a histopath. It is showing the same thing, mirror reflection. 60-year-old female, thoracic region of the spinal cord, intradural extramedullary, contrast enhancing lobulated lesion with areas of calcification. Now only I think you can make the diagnosis. The monotonous population of the cells with cytoplasmic processes are there, but see what is important. There are two things important in this particular condition: pale nucleus, peripheral margination of the chromatin. Chromatin appears peripheral margin, shows peripheral margination. Cytoplasm of the one cell and the other cell you cannot make out properly. Indistinct cell borders, very classical feature. Some of our bodies, very great. Cellularity can vary, clusters or whorls or fascicles, indistinct cytoplasmic borders, thick cytoplasmic bridges you can see, monotonous nuclear morphology, pale center and peripheral margination of the chromatin. You can also see inclusions. Some of our bodies classical feature. If it is straightforward, then meningioma is the diagnosis. Histopathology of the same. This is whorl. This is what you see whorls in the histopath. 50-year-old male cerebellopontine angle tumor, well circumscribed, heterogeneously enhancing lesion with cystic change. Here you are seeing very characteristic feature. This is called as frayed cytoplasm. What is the word? Whenever we come across new terminology, we should be curious enough to know what is that new terminology. We are better to open the dictionary of our very good friends. According to the dictionary, it is what is the word meaning of frayed is when you see a carpet, you will see some fibers coming out. That is called as fraying. This frayed cytoplasm. That is how it is called as frayed cytoplasm. Now you are seeing two more important features. This is called as right-angled crisscrossing of bundles, interlacing bundles, spindle-shaped cells. So it is a spindle lesion, spindle neoplasm, shaped neoplasm. Then you are seeing some nuclear streaking here. The arrow mark is pointing towards nuclear streaking. Cellularity can vary again. It can be arranged in fascicle or cluster. Yeah, you may ask me doubt. Fascicle is a histopath terminology. Why are you using here? I am not using. Book has given. Why? See, Kashmir cytology is one where it also not only shows cytology, it also shows architecture. The reason why the term Kashmir cytology is slightly different from the routine cytology. You can use some terms. Then spindle cells, then frayed cytoplasm, frayed ends, which has got the cluster has got frayed ends. Then collagen bundles. You can see interlacing bundles shows crisscrossing at right angles, streaked nuclei. All these are characteristic feature of cerebellopontine angle tumor, schwannoma. In this particular slide, why I have put is this is what I saw. There were features. What I showed in the previous slide. In addition, I saw some bizarre cells, very bizarre cells. This was a histopath of the same. Again, I am seeing bizarre cells. What it could be? Very good. Please do not jump into conclusion that it is MPNST. No, it cannot be MPNST. It has to be ancient schwannoma. It can, because it is long-standing. It can show bizarre cells. 30-year-old male cellular region, homogeneously enhancing lesion. Monomorphic population of the cells. You are seeing some cytoplasm around the cell. That is what is important. This is the high power view. It can also show some granularity. So diffusely scattered cells, or it can be sometimes in clusters like this. Round to oval cells, scant cytoplasm. This also has got salt and pepper chromatin. What it could be? Pituitary neoplasm or pituitary neoplasm. This is the histopath of the same granular cytoplasm. The cell population can vary depending upon the subtype. Anyhow, it will be monomorphic. Then 10-year-old male supracellular lesion, solid cystic lesion with areas of calcification. Squash smear, this is the actual case what I encountered. Squash smear showed some hyperchromatic cells in tight clusters. Some proteinaceous material was also there. Then concentrate here, some cells has got abundant cytoplasm, slightly abundant cytoplasm. Here you are seeing palisading arrangement of the basiloid cells, and in the center you are seeing, what is this cell called? What type of cell is it? Reticular cells, reticulum cells. Then this is stroma you are seeing. What is the diagnosis? You know the diagnosis. Cellular tumor. Very good. Adamantinomatous craniopharyngioma. Then 35-year-old male basis sphenoid large lobulated heterogeneous enhancing lesion. You are seeing some cells which has got vacuolated cytoplasm. That is what arrow mark is pointing towards. They may be in clusters or singles. See, this is from the personal collection. Similar kind of cells. This is the vacuolated cytoplasm. Why I have focused? Can you make out the difference in the stain? What stain it could be? Above one is HND, below one is MGG. It is. Why I have done MGG? Usually I will not do. I would have diagnosed in this one HND only, but MGG is better. You to appreciate the background. So clusters or singles, physalliferous cells, myxoid matrix. What is the diagnosis? Histopathology of the same. It was arranged in nodules or lobules divided by stroma of varying thickness. 60-year-old male frontal lobe circumscribed contrast enhancing lesion. Some cells you are seeing which has got hyperchromatic nuclei, and if you closely observe, it is arranged in acinar pattern. It is in clusters and they are also scattered. This is the histopath of the same. You are seeing glandular structures. Some pleomorphism is also there, which is not appreciated in this power. What do you suspect? Metastatic tumor. Now what you should know something about non-neoplastic lesions also. Infections like tuberculoma, toxoplasmosis can happen in CNS. Then cystic lesions are epidermoid cyst, arachnoid cyst, Rathke's cleft cyst. There can be infarction also, liquefactive necrosis. Then reactive gliosis, vascular malformations also we do encounter. Only one case, 30-year-old male immunocompromised patient. Lesion is located in caudate nucleus and the putamen. Classical location, ring enhancing lesion. What is this? Something you are seeing, and within that something you are seeing something which is much more tiny. Bradyrhizoids, uniform sized. These are the uniform sized parasites, inflammatory cells. What is it? Toxoplasmosis. This is the histopath. Same thing you are finding. Bradyrhizoids. Now coming on to the just points. Few important points I will tell. Brain is described as sea of water wrapped in tube of fat with a bit of protein thrown in to hold it all together. Crust preparation, it shows both cytological and architectural details of CNS lesions. Please remember this point. Majority of the gliomas Then pituitary neoplasms, medulloblastoma, metastatic carcinomas yield good cellularity and force few diagnostic problems majority of the times. Whereas cell yield will be poor in schwannoma, meningioma, and neurofibroma. This is what is given in the textbooks, but my personal experience is I have seen good cellularity in schwannomas. Yeah, neurofibroma, definitely I have suffered. Meningiomas also good cellularity. Mixed gliomas are responsible for difficulties in smear interpretation. Why? Because they exhibit more than one histological cell type. Improper grading of astrocytoma can occur in cytological preparation. Why? The astrocytomas are known to vary significantly in grade from one area to the other area. In the same lesion, you can find low grade areas, high grade areas also, different area. Grade 1 area also you can see, grade 4 areas also you can see. Next, how to solve this problem? Give the highest grade, do multiple biopsy, ask the neurosurgeon to send multiple biopsy, not one. Then whichever is showing the highest grade, give that. So multiple biopsy from different area might reduce the false positivity and false negativity. The discrepancy observed between the smears and histopathology is basically due to sampling error, undergrading or overgrading of gliomas, error in the recognition of histological cell type. Now, what are the causes of misdiagnosis? It is not that I have not misdiagnosed at all. Yes, I have faced difficulties. It could be reactive cells or non-representative sample or poor cellularity, or it could be morphological similarity of the cells. Very simple example I will tell you, you can encounter with that, which is not common. Phyceliferous cells shows vacuolated cytoplasm, even metaplastic cells show vacuolated cytoplasm. Not only cytology, you will find difficulty even in histopath. Presence of necrosis and inflammation obscures the underlying pathology. Then non-diagnostic causes are basically non-representative sample or because of poor cellularity or presence of necrosis and inflammation. Metastatic workup is always challenging. Why? Once the surgeon removes that metastatic part and sends it to us, sir is not bothered. Sir may not be bothered. Only I will be scratching my head because it is, and patient is also happy because something is removed from his body. We have to find out what is the cause. Where is the primary tumor? That is a challenging part. Diagnostic accuracy also depends upon the interest, that is your interest, enthusiasm, and experience of the neuropathologist in the field of CNS cytology. The lack of development of CNS cytology when compared to the general cytology is because very few pathologists are experienced and exposed to this neurosurgical specimen and its interpretation. What are the pitfalls? Failure to consider that a biopsy may not be representative. He may have removed from the adjacent area, tissue from the adjacent area and sent to us. Failure to consider non-neoplastic process. Is it always neoplastic? That you should have thought. Then overgrading we should avoid. Can you guess? It is a famous monument. Can you guess? Golden Temple, Amritsar. Why did you put this? Non-representative sample. Even if I find difficulty, if I have non-representative sample or inadequate samples, sometimes I have seen only 1 millimeter tissue. What I can do with 1 millimeter tissue? Because I have to divide into two. 1 millimeter sample, I can just make squash smear and I have given the diagnosis. What did the neurosurgeon tell? Sir, it is enough. I cannot remove more. So I did get the histopathology specimen. Now, finally coming to the take-home message, squash smear cytology is reliable, rapid, inexpensive, intraoperative diagnostic tool. It provides complementary information to the histopathological diagnosis. And squash smear can be considered as a mirror image of histopathology. Inadequate and improper sampling are important contributory factors for the misdiagnosis. And squash smear cytology has emerged as preferred diagnostic tool over the traditional frozen section technique. Why? What is the disadvantage of frozen section? Ice artifacts, basically. It is therefore necessary for the pathologist to train ourselves in the interpretation of cytomorphological features of various CNS lesions. You try to have whatever I have taught you with you and try to put it into practice, and also while writing in the examination, this is how it should be your answer papers. It should have stuff. If you don't apply, it will be like this. Can you please, I have put some photos. There is reason behind this. It is, I will tell you what is it. Yeah, you can also tell, but I want the diagnosis. Steel wool, gliomas, smear, it refers to the smearing pattern. Butterfly is the radiological, this one, it involves the corpus callosum and on either side it can spread. What is it? Yeah, glioblastoma. Salt and pepper chromatin. Yeah, there are many conditions, few conditions, central neurocytoma and also medulloblastoma, pituitary neoplasm. Grape, medulloblastoma, nodular. Group of dogs, again medulloblastoma. Leopard, lymphoma, good. Honeycomb, choroid plexus papilloma. Cauliflower, choroid plexus papilloma. These are the references. Reference number 5, sorry. Reference number 6 is the one which is the one which has given that diagnostic approach. Please read that in detail when you go for examination. It may be helpful. Thank you.
Thank you, sir, for your valuable knowledge sharing session. I would request our moderators, Dr. Jyoti ma'am and Dr. Kalam sir, to hand over the memento as a token of appreciation to Kumar sir. I would request Dr. Vidya ma'am to hand over token of gratitude to our moderators of the session. Dr. Jyoti ma'am and to Dr. Kalam sir from GMC Kadapa. Thank you, ma'am. Welcome back, sir, for the Brown interpretation and detection of specific biomarkers, genes, proteins in tumor tissues. Yes, it is application of IHC and molecular studies in the CNS tumor. Over to you, Nandis, sir. Moderate this session, I would call Dr. Jyoti ma'am from Apollo Chittur. Nirmala ma'am, Professor, PS Kupam.
Yeah. Now it's past 12, so good afternoon. And the next 30 minutes, I will not take much time because some things are overlapping with Dr. Kishan's talk. This is more of an application type. So we'll just have an overview. The most difficult time is pre-lunch, I would say, pre-lunch and post-lunch. So let's see how much I will be able to keep your attention. Okay, but you don't have to stress yourself. Just relaxingly, just keep listening. Few points. It's just more of applications. So you can just kind of awareness you can take. You can whenever you have time, you can just revise on that. So now this particular topic, if you see, there are three elements involved in that. That is, we are talking about CNS neoplasms and application of IHC and molecular workup both together into this neoplasm. Though I'm talking about why I'm mentioning about these three entities is, yeah, just remove this. Otherwise, for any oncology workup in the present WHO scenario, these three things are running together. In the present WHO classification, you have molecular terminologies coming in, and you have various new names. Some are coming into the classification, some have gone out from the previous classification, some have stayed. All those things are happening. So about the classification, Dr. Kishan will be telling. Now, in relation to that, how we can use or apply IHC and molecular, we'll study. Now, CNS neoplasms, I would say that this is in whatever when I'm talking about, you can just remove this word. Whenever I'm talking about the IHC and molecular, specific IHC and molecular workup, only then you can bring CNS perspective there. Otherwise, neoplasms in general, you can apply it to everything in common. Okay. So though this particular session is on neuropathology, keep laterally thinking about other systems also. Now, I would initially, I would say in general, histopathology is more fascinating because of the challenges involved. But hematology is also equally good cytology, as Dr. Kumar Guru mentioned. But if you carefully look at it, somehow most of our discussion, amount of time we spend in studying and evaluating is going more towards oncology. That's the reason why most of the sessions are also on oncology. I was initially thinking, is it because of awareness that we are seeing so much prevalence, all those things? That is also there. Awareness is good, but more than that, actual prevalence is increasing across the entire globe. And in India also, the prevalence or incidence of neuro-oncology, CNS neoplasms is increasing. But one thing about CNS neoplasm is that elsewhere, the mortality may be very significant. When it comes to morbidity, even a benign tumor, post-surgery or by itself, can be significantly damaging in the CNS. So it becomes very accurate, very important that you accurately diagnose and properly diagnose without any kind of error, very minimal error. That's what makes the situation very challenging in a CNS perspective. Okay, that's the reason why I wanted to stress the importance of evaluating CNS neoplasms. Okay, now I just want to mention how advances have happened. Initially, just taking IHC as an example, initially with a simple antigen antibody reaction, single step, it became double step, then multiple step, then it became polymer based, where multiple the reactions of the secondary antibody, the signal changes could be picked up much more easily, much more intensively, and much more elaborately and objectively. So now it has come to a stage where things have become automated, digitalized, all those things have gone up. In the same way, molecular also is increasing. Now the present scenario, what I would say, not only about neuropathology in general, earlier we used to think that we will diagnose and then go to the next case, but now it's not ending there. Once you diagnose, you may have to interact with the clinicians because they will come out what is the implication of it, what is the present WHO situation, patients will come, all those things. Referral, second opinion, they may come, or you have to handle your own friends, relatives, questions. So it's going beyond. Overall, in every aspect of whether it's oncology or non-oncology, now every department, at least in some of the, it's a good practice. They are forming a team, multidisciplinary team, and this in that team, actually speaking, though the clinician is acting as an actor or the actual main stage actor or actress, the main director or the script writer is pathologist only, because they are based on that only. So pathologist role has become very centric, so you may have to be more aware of it. That's what this particular table shows, that our role earlier was more or less ending at diagnostic level, and we used to go to the next case. But it's not anymore like this. You have to go with not only diagnosis, they will come out with questions. How sure are you? All those things. What is the prognosis of it? What is the treatment? How will the particular case or a pathological entity or diagnosis tumor respond to a particular treatment? What will be the prognosis? How will be the recurrence rate? All those things. You may have to be ready with that. Because of that reason, our WHO classification is not limited only to classification. Some of them are included prognostic elements also. So indirectly it will grade, indirectly it will indicate what prediction, how the patient is going to do, what treatment is going to be working in that patient, all those things. So our role, responsibility has become more and more demanding and increased. And that's what I'm going to discuss about that. So indirectly, this particular table you can extend into what is known as biomarkers. What is biomarker? Biomarker is nothing but a biological molecule which will indicate or provide useful clinical information that will guide in the diagnosis, management, prognosis, and prediction. So this biomarker, you can make it clinical biomarker also, where MRI imaging, all those comes, but pathological level, you have diagnostic biomarkers which will help in diagnosis, confirming the diagnosis, ruling out the mimickers or differentials, and helping in proper classifying it. Second thing is that is not enough. You may have to go with prognostic biomarkers, like how the patient is going to do, survival, all those things. IDH is one of the best example. All IDH mutant tumors are better than IDH wild type. Of course, it is in relation to diffuse gliomas. Predictive biomarkers, like which treatment will work out good. In the same way, if you take up the same IDH, they are almost always MGMT methylated, which we will, if time permits, I will tell you. Basically, if MGMT is methylated, it's an alkylating enzyme. So you can easily use alkylating agents for that. Okay, it's a dealkylating agent. You can use alkylating agents as a chemotherapeutic drug because they are going to respond very well. Similarly, if 1p19q is correlated for, let's take oligodendrogloma, that is the defining molecular marker, they'll be responding to this PCV regime like that. Okay, so those are some of the examples for it, how biomarker is going to be useful. Okay, and in the present scenario, if you have to label, just a curiosity for lateral thinking, one marker which can help in all these things would be 1p19q. That is, it will help in diagnosing oligodendrogloma. It will help in indicating that they will behave well. Predictive markers, the particular chemotherapy will respond well. 1p19q will fulfill all these three. It's a diagnostic marker also, plus these two information. Now, to put it in a very short form, tabular form, I'll come to the same table at the end also. Why we need all these tests, that is IHC, molecular workup, all those things. First is, you would have done some morphological assessment and come to some clinical differential or some pathological differential. You want to be 100% sure, pick up a single diagnosis. That is not possible only with morphology, right? So you go for that. Next is, as Dr. Kumar Guru mentioned, our brain is a very unique organ. Any insult on the brain, it overreacts as compared to any other tissue, because the organization is like that. Lot of cells in a particular unit area. So reactive conditions can mimic neoplasm. Grading is challenging. Line of differentiation, there are, from the same primitive neuroectodermal cell, you get glial cells also, you get neuronal cells also. So many times it will confuse, and some other cell would have come mimicking. And next is, you have so many subtypes, subtypes, variants, all those things. Additional component is a variant. Then not everyone can go for molecular testing. Okay, in the sense, you need to depend on genetic tests, but how comfortable are you with genetic interpretation? We are not, as pathologists, we are not. And so it will be happening in a dark room like fish, or in another room. But whenever it's in relation to to morphology, like IHC you do, it's in relation to morphology, you are very comfortable. But if you do sequencing, you don't know what things happening. So you will always be comfortable if you have surrogate markers which can correlate with histology, like IHC, which will indicate. Next, of course, prognosis prediction I told. Next, some genetic tests. Nowadays, tumor NGS has come. It gives all peculiar results. But you have to be very sure. Again, you have to come back to this pathology only. Of course, research, it depends on IHC and this thing. Then, if you purely depend on morphology, there will be a lot of variation. Not only inter-observer, intra-observer also. Morning, evening, it will be depend. You will have differential analysis more in the morning. Evening, evening it will be more because of mental fatigue. Morning, you will be fresh. Like that. And there are a lot of new things which WHO has proposed, that to recognize you need additional evidences. So, and as Dr. Kumar Guru mentioned, there will be a lot of procedural wrong sampling or very little sample, artifactual sample, procedure induced, streaking, streaming, all those things. For that, you may have to depend on additional stains to be very sure. Small biopsy is one challenge these days. Everything is become scope based. So you have thoracoscopy, endoscopy, colonoscopy, all those things is coming up. Because of that, tissue is becoming smaller and smaller, but the information expected is becoming more and more. Okay, so that is the challenge. Now let's take examples for each of these, and that will end my session so that you can go have a good lunch. Okay, afternoon you can concentrate for Kishan's talk, because morning you have been listening continuously. It's very hard to sit there and listen. Okay, and difficult to that is challenging. Okay, let's start. So this is straightforward, no doubt about it, is it not? Whenever you assess morphologically, or obviously you will have differential diagnosis. There is very few tumors which are these days, very few tumors which do not require IHC and they are purely morphological. But though those tumors do not require IHC, but you may have to do IHC to rule out the mimickers. Is it not? You agree with that? So that is what I want to tell you. So next is reactive neoplastic. A simple, as Dr. Kumar Guru mentioned, the glial cells can overreact. Let's take gametocytic astrocytes. You know, gametocytic astrocyte, earlier they used to call gametocytic astrocytoma also. And the same gametocytes can come because of extreme reaction. How to differentiate? Morphologically, there are some clues like tumor gametocytes will be uniform, they will be what do you call INC ratio will be there, short stout processes. But reactive astrocytes, gametocytic astrocytes will be very heterogeneous. They'll be long, the thick and long process will be there. INC ratio will not be there. Variation, they accompany other reactive cells like that. But one good method of recognizing reactive versus tumor is simple GFAP. See here, these are all tumor cells, tumor glial cells. See, these are all starry type glial cells, astrocytes. This is one example how we can do. Sorry, MIBN, I'm given a wrong name. GFAP comes here. Of course, reactive neoplasty you can use MIBN. That's what I want to convey. MIBN also you can use. That is proliferative marker, but GFAP is good. Okay, like this. These are all reactive. The right two images are reactive. Left one is a typical neoplastic glial cell. Now, grading, of course, mitosis is most important. But how comfortable are you in mitosis, picking up mitosis, especially in CNS scenario? Some of these CNS cells, because of more lipid or what, I don't know, they shrink and give problem, especially meningiomas. So you depend on proliferative markers. That is MIBN, that is K6 and MIBN, the same category, and also PHH3, phosphohistone protein. Now this grading, you know, although WHO has gone ahead in using molecular markers, still in most of the scenarios, grading still depend on mitosis. Okay, but mitosis again challenge is there where they're truly mitosis or something mimicking a mitosis because of the nuclear shrinkage. To pick up the hot spots, you depend on MIBN and K67, and it's directly related to prognosis. Grading is directly related to prognosis. And one thing you should, at this level, I want to mention, there are few molecularly high-grade tumors. For example, know about diffuse midline glioma. Once you to diagnose diffuse midline glioma, if you use HCA, you will understand the classification later when Dr. Kishan mentions. Once a pediatric tumor which is in the thalamus or brainstem or spinal cord, if it is H3K27, that is a kind of type of histone mutation if you see, though the morphologically it is grade 2 or grade 3, it would directly jump to grade 4 just because of the molecular aberration. Similarly, a tumor which is high grade astrocytic in morphology, let's take, we are not seeing necrosis microvascular proliferation. High grade astrocytoma like grade 3 without necrosis MVP, you cannot call grade 4 morphologically. However, if it shows an EGFR amplification mutation, +7, that is addition of chromosome 7, loss of chromosome 10, P10 mutation, third promoter mutation, all those things, that will jump into molecular glioblastoma, irrespective of whether it has microvascular proliferation or necrosis like that. Similarly, you have hemispheric gliomas with another histone mutation called as H3G34 or H3G34V. Then also it will jump into molecular grade 4. So that is all the things. If you don't have all these things, but you are suspecting morphologically, clinically, all those scenarios, you can suggest that this is what morphologically it is grade, but you have to do this testing to rule out grade 4 like that. You can always be in communication, some kind of communication. Then to pick up the line of differentiation, more or less the classification is linked to lineage or line of differentiation. Okay, so most of the markers what you do is actually to classify it, pick up the lineage. Simple is this GFAP. To pick up gliomas, you do GFAP2. To pick up metastasis, you do cytokeratin. Like that, I'm just giving you. But just to give you example, why you need lineage to pick up lineage of differentiation when it is morphologically clear. But many times morphologically it is confusing and challenging. Let's take simple example of clear cell tumors. All these tumors can show clear cells or oligodendroglio-like cells. So somebody may ask, like these days, short notes, if you go for DNB exam theory, they all ask peculiar lateral thinking questions. Okay, short notes. So let's take simple, they will ask this. Similarly, small round cell tumor, again, Dr. Kumar was mentioning about so many cells will show small round uniform monotonous cells. The different analysis will range from that primitive neuroendocrine tumors to all those things, embryonal, lymphoma, all those are small round cell. Again, you depend on immunohistochemistry because they all look alike. So best is this, this is a soft tissue panel, which you can do that, right? So I'm not spending much time on that. But in general, lineage markers are all these things pertaining to CNS. Like for a choroid plexus, we do. Like choroid plexus is one challenging, especially when it is carcinomatous. You don't know whether you're dealing with a metastasis or primary choroid plexus tumor. Of course, luckily, luckily one way, unfortunately for the patient, unfortunately that choroid plexus carcinomas are more common in children where metastasis is less common. But by chance, if it is choroid plexus carcinoma, you can use this skill 7.1. Otherwise, many tumors, CK7 will be positive metastasis. This is also positive. That is a reversible potassium channel. That is the one. For neuronal markers, you have neuronal tumors. You have neuronal markers. The prominent being synaptophysin, chromogranin, nu, and all the NSC. For nerve sheath, you have dominant S100. You have STM3 also for MP and STs. Meningiomas, SSTR2 has come. That is somatostatin receptor. See, all these markers, when it comes, it will be very popular. Initially, when it came, they told it's very specific to meningioma, but these days we are seeing in many others. But of course, it is not very strongly staining in other tumors. Variable, and you may have to go with that one also. Very strong, diffuse pattern of staining. All those things are important. Mesenchymal, the most common mesenchymal tumor other than meningioma is the SFT, solitary fibrous tumor. So STAT6, pituitary. Of course, I will come to that. Hemopoietic lymphoma, I'm not dealing with a germ cell. Whatever you do for systemic, same thing applies here. Brachyury for chordoma. So these are lineage markers. So next, going to the classification. In these two lineage markers are there. ATRX and 1P90Q. I spend little time for that because these are very important to diagnose them. Okay. ATRX, okay. Oh, one slide is missing. Sorry for that. No problem. Now, central nervous system, I'm not going into the classification which Dr. Kishan will do, but these are based on this lineage only. You have classified this. So it becomes important that you keep in mind the lineage markers and the mimickers. I'm going to spend little time on the molecular surrogates because sometimes these markers which you use to classify, you will also be classifying molecularly also because some of the molecular entities, classification includes molecular entities. So to classify, you may need some molecular markers also. So for example, let's take this. Let's take example of gliomas. Okay, it's the most commonest primary adult tumor, adult CNS tumor. Okay, of course, Dr. Mentioned that the most common tumor in brain would be metastasis. But in practice, metastatic tumors, once they recognize, they will try to handle in much other way. But the primary adult tumor will be glioma. Pediatric will be comparison between pilocytic versus medullo. But in India, it's pilocytic common. So let's take up this one, most important. Since it's more common, we'll spend little time on that. As I told you, for subclassification, molecular classification, you have to depend on this. So this is a classification. Simple 3 types. Adult diffuse glioma is the main classification. Under this, you have 3 types of it. Under this, you have subtype. I will come to that later. Under this, you have grading actually. But no grading for this. Is directly jumps into grade 4. But IDH mutation is one which you have to recognize to clearly mention that it has astrocytoma. For oligodenoma, you need not only morphology but IDH mutation and 1P90Q. So you have to do that. So morphological challenges is that many times morphologically, just simple oligo and astro will confuse us, is it not? Sometimes earlier you used to call oligoastrocytoma for these mixed tumors. Now it is discouraged. Sometimes a simple epiderma can confuse us with astro-oligo. Glioneuronal, where neuronal is not very clear. I told you about grade 4 astrocytoma GBM. What is common between these two? Any idea? Dr. Kishan will tell why this grade 4 astrocytoma. Now astrocytoma earlier was ending at grade 3, anaplastic. Okay. Now it can still go with grade 4 when you have IDH mutation and microvascular proliferation or necrosis or necrosis. Okay. But GBM can look like grade 4 astrocytoma with microvascular proliferation and necrosis, but IDH should not be mutated, should be wild. That's the only difference. But morphologically, if both are there, you cannot pick up. Of course, for grading, again, you depend on those things. Because of all these challenges, you have to depend on IHC and other molecular profile. Now, simple example, this gives the full spectrum of tumors. Grade 2 tumor where the astrocytoma is one level more than the normal. This is grade 3, this is an oligo, and this is a grade 4. Okay. All these 4, if it is IDH mutant, it's very clear. Is it not? Suppose this is basically astrocytoma grade 2, astrocytoma grade 3. If IDH is mutated, you can be very classified. But can you do IDH mutation, go on doing sequencing all the time? Difficult, is it not? So the simple example would be to do IDH mutation, IDH staining. But this IDH staining, what you do is only for R132H, that is that can be picked up in 90% of the cases. Okay, that is where in this particular locus, okay, this particular allele where arginine is changed to histidine. But remaining 10% you cannot pick up. Picking up will not only help in diagnosing astrocytomas and oligodendrogliomas, but also indicates that they are all favorable prognosis, right? Not only that, it can also help in differentiating from other conditions which can mimic, like reactive gliosis, which will be negative, glioblastoma, which will be always IDH wild type. Other gliomas like ependymoma pilocytic will not be IDH mutant. So that has again another implication. Okay, so not characterized. Next is this ATRX. Names are all complex, like alpha thalassemia mental syndrome X. Okay, linked. Don't worry about that. But this is again a lineage marker which helps in picking up astrocytoma. So suppose if you don't do IDH, let's take if you don't do IDH, or if it comes IDH negative, let's take IDH ISC is negative. Can you call it as IDH wild type? You cannot call, because the remaining 10% of the cases which can show rare IDH mutation, you have not picked up. That can be picked up only on sequencing of the DNA. So when you have done IDH mutation on IHC, IDH staining on IHC, or you have not done IDH staining at all because of various reasons, either you don't have the molecule or that molecule is not working. And in the case where morphologically it is not looking like oligo, but looking like astro, and if ATRX is mutated, you can still go and call it as astrocytoma. Is it not? Did you understand my statement? What I mean is, suppose you don't have IDH marker with you, but you have ATRX, okay, or IDH marker is there with you, but it is not working, or it is the stock is over, whatever reason. Morphologically, it is looking like oligo, and it is not looking like oligo, it is looking like astrocytoma, and you do ATRX. If this is mutated, that means you are dealing with an astrocytoma clearly, because it's in a lineage marker, astrocytic lineage marker. That's what I want to tell you. But in those cases, can you give it as astrocytoma IDH mutant? You cannot give, because you have not done IDH yet. Though it will be IDH probably, but you can write NOS, not otherwise specified, because you are not completely worked up yet. So this is how you can do at least some justice, some requirement you can fulfill. So this is one marker where the mutation will make it loss of the protein. So there will be loss like this, similar to our what is that, INI1 and all those things, H3ME3 like that. Okay. So, and this is always mutually exclusive with 1p92 codeletion, because this is astrocytic. 1p92 is typically oligo. If it is ATRX mutated, 1p92 will never be codeleted. If 1p92 is codeleted, ATRX will never be mutated. That is there. But IDH mutation will be common to both. Understood? That you should remember. Okay. Now, one thing you should remember, in some of the midline gliomas, some of the hemispheric gliomas which are H2 mutated, they can show loss. Even some of the midline gliomas, just to keep as in a lateral thinking. These are all optional to know for you. I told you three levels of learning. Okay, don't break your head now. You can read later. Similar, P53 is something which accompanies ATRX. So it helps in complementing your interpretation. So it helps in picking up astrocytic lesions. Okay, and some of the glioblastoma, especially giant cell glioblastoma. But oligos will not show. But remember, generally P53, to call it as positive, strong positive will be diffuse and strong, which is seen to be true mutation will be diffuse and strong. But nowadays they are telling that even overexpression can be supportive. So anything more than 10% can be considered as significant. Okay. Now 1p92, there is no molecular IHC marker which is surrogate to that. You have to depend totally on FISH or any other methods. So, but this is again lineage indicative tumor. That is, it always coexists with IDH mutation and always indicates oligodendroglioma. Now what happens is, suppose you have an oligo like we don't have a genetic setup in our lab. Let's take a situation like that. And you have typical oligo tumor on morphology with round cells, all those things, everything. And it is IDH mutated, ATRX not mutated. Clear? IDH mutant, ATRX not mutated, molecularly very clear. Sorry, morphologically very clear. Then you don't have to depend on 1p19q. It's already clear. It's morphologically it is fulfilling. IDH is mutated. ATRX is not mutated, means it is not astrocytoma. There is no other tumor in the brain which is IDH mutant other than astrocytomas and oligo. Okay, you don't have to depend on 1p19q in those situations. I'm just telling you, these are the ways where you can fulfill a resource poor setting. That's like that. Okay, as I told you, this is one which will help in picking up not only the tumor that is classifying, but also prognosis and prediction. Okay, so now this is how you can go for classification, subclassification, subtyping, and all those things. Now let's take this particular situation is very clear. I've already told you. Now, one word about glioblastoma. I told you about molecular glioblastoma, right? But in an elderly, what happens? You have typical morphological glioblastoma. You saw the examples, both radiological examples you saw, squash smear examples you saw. It's morphologically, it's not a problem for you. But in a young patient, 40 years or something, if you see something like glioblastoma, you have to recognize that it could be astrocytoma grade 4, which is IDH mutant. So that here it's very important. But if in a young patient, 45, middle-aged patient, 45 or so, if IDH sequencing is negative, that means it is IDH wild type. And if you're seeing morphology of glioblastoma, IDH is not mutated, then only you can call it as IDH wild type glioblastoma. But you should remember that above 55 years, 98% of the times, it is above 55, 90% of the times, the mutation what you will see is IDH, sorry, I'm telling you the opposite. Above 55 years, please understand this word, just for to make it things simplified. Above 55%, 55 years of the age, you will not see IDH mutation generally. Okay, you will not see IDH. The percentage of IDH mutation in above 55 years astrocytomas is just 1 to 2%. So they say that above 55 years, the IDH mutation is very less. And even though you see IDH mutation, that will be most of the times, the common mutation what you see, that is R132H. So in short, what I want to tell you is, erring at a level of 1% or maximum 2% errors, above 55 years, if something is on IHC, IDH negative, you can go ahead and call it as IDH wild type above 55 years, because as such IDH mutation is rare. Even if it is mutated, that is most of the times it is the common mutation what you will see, that is R132H. So based on that, you can still manage without genetic workup with just IHC. So you have to pick up sarcomatous element. You can depend on Y-maintain or other heterologous differentiation like S100 for all those things, rhabdomyoblastic difference that you can pick. Epithelial GBM, you know, it occurs at much younger level. There will be BRAF V600E positive that you can pick up. If wherever you cannot do IHC, you can always go for NOS, not otherwise specified. BRAF V600, I told you. So this is what. Now going further about pediatric type is a challenge. There are a lot of markers have come, but if you actually carefully see, some of these are purely molecular, which we depend on DNA methylation of this. We cannot help it. But just if you say that it is a diffuse pediatric type low-grade glioma, that should be enough, because this has not it has not completely translated to clinical practice. So they are quite okay. Radiologists are, neuro-oncologists are quite okay. Surgeons especially are okay with your broad diagnosis. Only when it comes to oncologists, especially radiation, all those things, they want to calculate they want to calculate the cycles, all those things. Then it becomes problem. In a recurrent situation, it becomes a problem. But whatever it is, always a multidisciplinary team. You can always discuss together and take it. All these are all individual case-based case. Okay, you cannot generalize so much. Now coming to the diffuse high grade, low grade is fine, is challenging. High grade, you have markers which can help. One is midline glioma, where you do histone H3K27M, and for hemispheric glioma, another histone which is H3G34, and that is one that you can do. And we'll take up this one. I told you already. We'll take up the higher grade ones. Let's take simple example. Any suspicion on this? First, you tell this is definitely neoplasm. Yeah, this is the brainstem pons. Is it low grade or high grade? High grade because of heterogeneous nature, variegation, and see the high grade nature of it, and astrocytic morphology. High grade astrocytic morphological tumor in the midline child in the midline brainstem. In a child, you suspect diffuse midline glioma, and this is how it will look. In the absence of necrosis MVP, if you see a glioma of this type with histone mutation, it will directly jump into grade 4. Okay, molecular grade 4. Similarly, you have, see, this is what we took an example. Similarly, if it is the same type of tumor is occurring in the hemisphere with the same situation, oh, this is still I'm talking about midline glioma, just to tell these, some of them can show ATX mutation. Okay, so keep in mind, little be careful about the location, age, everything. We're talking about periodic diffuse high grade gliomas. Okay, and problem is why it becomes important that these tumors are aggressive. It's a typical curse to the patient, like a death statement to that patient, because they don't respond properly to the chemotherapy. Very bad prognosis. They can disseminate through the CSF. Now, diffuse high grade glioma, another one is hemispheric, where it instead of showing H3K27 in the locus H27, it is showing in the 34 location nucleotide, and same histone mutation will be there, same high grade, and this will also may not show necrosis MVP, may or may not show necrosis MVP. Irrespective of it, if it shows this mutation, it will directly jump into grade 4, molecular grade 4. So that if you know that message, that's more than enough. Next is when both are wild type. To tell that wild type, you cannot depend on IHC, because IHC are all surrogate markers. You have to go for sequencing, and in the sequencing, if you don't see any mutation, only then you can call it as wild type. Okay, just because something is negative on IHC, don't call it as wild type. That is one thing. If then you can call it wild. Okay, fine. Now let's come to this. Okay, I wanted to ask you, but before that only it came. This is a typical attractive tumor, glial tumor with nice perivascular rosette, or a true ependymal rosette. Yes, ependymoma. Ependymoma morphologically is very attractive and straightforward, but there are few challenges I will tell you. Let's take this. In this, perivascular rosette is not very clear, right? Perivascular rosette is not clear. Any glioma can show some degree of perivascular rosette. Why? Because the glial fibrils, when it comes very close to the blood vessels, you invariably get a kind of a nuclear zone area. Okay. Now this tumor, okay, to diagnose you where this perivascular rosetting is not very clear, you can depend on GFAP to pick up the perivascular accentuation, and most important is EMA, right? EMA is one stain which can help in picking up, because EMA actually generally you use it for staining epithelial tumors or meningiomas, but here you get a paranuclear dot staining. In this one, many times we used to call papillary clear cell. These are all old terminologies. Now they are removed because they are all only growth patterns, morphological patterns, no relationship with prognosis. But now the diagnosis classification is based on, Dr. Kishan will tell, two things. One is location, either supratemporal, posterior fossa, or spinal, or it is depending on the molecular. To recognize molecular, you have these types. Why you have to recognize molecular is because some have got bad prognosis. Even if you don't remember a molecular terminology which has good prognosis, at least you should know those molecular terminologies or tumors which are having bad prognosis. Like for example, I told you about supratemporal this ZFTA fusion. These are supposed to be having very bad prognosis, and that you can pick up by a surrogate marker called as L1 cap, because it will show a ZFTA fusion. Okay, so that is one, and they are having bad prognosis. Supratemporal ZFTA fusion positive. The specialty about this tumor is this can have clear cells, and this can mimic oligodendroglioma. You know, oligodendroglioma comes under which category of tumor in the classification? Adult diffuse. Okay, adult diffuse glioma. But we are talking ependymoma is a unique tumor which doesn't fill with this, but this can occur in childhood. You know, ependymoma is more common in childhood, especially supratentorial region is more common in childhood. Now, this oligodendroglioma-like tumor occurring in a child, supratentorial, earlier older days they used to call periodic oligodendroglomas, and they used to be aggressive. But now it is very clear that these oligodendral-like tumors occurring in childhood are not true oligodendrogliomas. They are these supratentorial ependymomas which are mimicking them, and they are the one which can show typical oligo-like appearance by this branching vessels, sometimes calcification, clear cells, all those things. But basically they are supratentorial ependymomas with ZFTA fusion or RELA fusion. And the marker for this is L1 cam. Similarly, posterior fossa type A is very aggressive. Okay, and you have a surrogate marker for that, which is basically the trimethylated histone is lost. That is the mutation you'll see. So that is it. At least you should remember those which are having bad prognosis. Okay, and one ependymoma is spinal ependymoma, which will show NMIC mutation, which you cannot pick up on IHC is not robust, so you still depend on on genetic studies only. Okay, that is fish. And if this is amplified, those tumors are also very bad, spinal ependymas. And IHC is needed. Now, this set of tumors, which are circumscribed astrocyte tumors, especially pilocytic, SEGA, they are all morphological tumors. You don't need IHC for it. However, sometimes you may need IHC not to confirm the diagnosis, but to rule out other mimickers. Is it clear? Okay, that is what you should remember. So I'm not stressing on this classification. Okay, in that one tumor I have to do, there's PXA tumor that can show BRAF mutation, BRAF E6 and CD34 expression. See, can you recognize this tumor? Dr. Kumar Guru mentioned one nice intraventricular tumor, nice circumscribed, large cells, okay, glassy cytoplasm he used, giant cell mimicking, gametocyte mimicking, ganglioid mimicking, everything mimicking but forming in the ventricle, nodule, associated with tuberous sclerosis. All are close. Yes, the weaponogenesis, giant cell astrocytoma. Okay. So these are all typically, whenever you have difficulty, by chance you have difficulty, because sometimes we get second opinion, third opinion, where the tissue will not be processed properly. Something would have happened, where by the time it comes, it will be exhausted. Small tissue will be. You want to confirm it, you can do TTF1, which will be positive in SEGA. Okay, SEGA will be positive for thyroid transcription factor. Okay. Now next IHC application next is to recognize new entities. You know, WHO every time brings up new classification, new entities. Like for example, this has been brought plenty. That is polymorphous low-grade neuroendocrine tumor of young. Though you are morphologically it is convincing for you, but you need more evidence. Is it a new entity? So you depend on this BRAF, CD34. Okay. So to pick up new entities, again you depend on IHCs for that. Neuronal elements, I already told you to pick up neuronal elements, especially neurocytoma. You know, neurocytoma can mimic because of the salt, pepper. You know, extraventricular neurocytomas can occur. Extraventricular neurocytomas will mimic oligodendrogliomas very much. Okay, and they can mimic supratentorial ependymas. Then you have to depend on synaptophysin neuronal markers, gangliomas to pick up the neuronal elements, DNETs, all those things. Again, the next is most important here is, these are all the neuronal markers which you can use. We are comfortable with neurofilament, synaptophysin, and NSC we use, chromogranin use. NSC is nowadays giving a lot of problem. We have stopped that using. Chromogranin, yes. Of course, correct plexus, not to forget, Dr. Kumar Guru has showed a lot of examples. Just to indicate, I told you already about the usage of this KIR 7.1. A lot of times we have come across tumors which have been wrongly called as metastatic, but they are correct plexus because of this one. Just to indicate that is the one. Next is, any diagnosis on this. Straightforward diagnosis, don't think too much rare. Posterior fossa, child, midline, medulloblastoma, very good, excellent. Medulloblastoma, immunotumors, basically in that medulloblastoma, you know, earlier the diagnosis was purely histological, right? But now it has gone further, genetically defined, because they have seen that there is a lot of variation in the prognosis among these patients. What was classical in one patient of diagnosed as classic was behaving well, another patient of classic was not behaving well. In one, so they recognize that they were actually molecularly driven. Wnt activation, Wnt pathway, sonic hedgehog with p53. In this, p53 is not 10%. Please remember, in this it should be diffuse and strong. Only then you can call as typical T53 mutation. And another one is non-Wnt non-SH, which is further classified as group 3 and 4. Why? Because a classic ependymoma, classic medulloblastoma can be Wnt activated or non-Wnt activated. A classic medulloblastoma which is Wnt activated will behave extremely well, where you can de-escalate, means reduce the chemotherapy, reduce the number of cycles. Patient will do well, because I have come across few of the patients, children so cute, very good, who were doing very well, who were extremely good in studies before surgery and treatment, post surgery and treatment, radiation. Their scholastic performances come down like anything. Very sad to see. Okay, small children, girl children, Ellie, they're all so cute and good. They are told that I want to become doctor, everything. After that, they have just passing marks. So much very difficult. The reason why this happens in our setup is we get lot of referral. So patient themselves will come. We have to interact. We may have to counsel. The counseling not officially, but patient come to discuss. They have to go back to their hometown. Then it's very heart touching actually. So that's what happens. Now this is what I'm telling you, the same thing. How prognosis differs depending on the pathways. Okay, classic and anything. So how to do that? You can do molecular workup also, but fortunately we have molecular surrogates, IHC surrogates to pick up Wnt pathway. you depend on beta catenin and YAP S-associated protein. Okay. For SHH, you have GAB1, which is positive, and here F1. When both are, all of them are negative, we are not doing filament. That's why I'm not talking much about that. When all are negative, you can call it as non-Wnt non-SH, but this belongs to further two subtypes, group 3 and 4. For that, it purely depends on recognizing CME. CME you may have to do. Okay. That is purely molecular fish actually. That you can do that. Now this tumor, again very young child, posterior fossa. See this tumor, you have to pick up again embryonal tumor. I will not, for want of time, I will not explain more. You can see something more here. Can you pick up anything more about these unique cells? Young child, embryonal, posterior fossa, rhabdoid cells in short. Okay, and you have this. So once you see rhabdoid cells and glandular-like areas, all those things, atypical teratoid rhabdoid tumor, that you can confirm only by doing which stain? That is this marker INI1, where it will be lost. Okay. So that is purely dependent on that INI1. And this is again a rare tumor, embryonal tumor, called as embryonal tumor with multi-layered rosette, that you have to do molecular workup on chromosome 19. But you have fortunately one unique surrogate marker called as LIN28A that we do. Again, these markers I tell you, from different companies you get. One company will be working, in the next lot it will not work. Again, you have to change the company. A lot of experimentation has to do, which quality control itself is a totally different division. So now lastly is this part, cellular mass, very clear. What do you suspect is typical organoid arrangement, papillary, sinusoidal, neuroendocrine, pituitary. Now pituitary, classification, entire classification is based on hormonal thing. Okay. So pituitary adenoma classification is purely based, morphologically it is different, staining wise it is different. Molecularly, histologically you classify based on hormones, whether they are secreting prolactin. They may not be secreting, but they may be expressing one. But remember, some are getting arrested at transcription level. They may not be expressing them completely. So for that you have to depend on transcription factors based on this. Okay, like TPIT for ACTH. PIT1 is for growth hormone prolactin. So steroid factor for gonadotrophin, like that. So all these things are important. Transcription factors, we have started that, very useful marker. Many of them were going as pituitary adenoma, hormone negative it was going, but nowadays we are able to pick up many based on transcription factors only. But why you need all these things, to pick up high risk adenomas which can recur, which can invade, all those things. Which are the high grade tumors? Just to mention, sparsely granted growth hormone secreting adenomas, lactotroph adenomas in males, PIT1 positive plurihormonal adenomas, silent corticoadenomas. Silent corticoadenomas are one where ACTH may be expressed but hormonally negative, or ACTH may not be expressed, only TPIT may be expressed. That is also possible. So all these are important Cook cell adenomas. And granular posterior pituitary tumors can mimic many conditions. A simple TTF1 can help. Simple TTF1 can help. That will help in picking up posterior pituitary tumors. And lastly, there are a big group of systemic tumors which can primarily occur in brain, like plasmacytomas of skull base can occur. Metastasis obviously is the lymphoma, primary CNS lymphomas I'm not dealing with that because it's an entirely separate category. Germ cell tumors, primary germ cell tumors. Now what are the things? We've almost covered everything, all these things. These are all self-explanatory, is it not? Research, I'm not going to the research aspect. Genetic result, it's all self-explanatory, I'm not going. Reduce inter-observer variation. And finally, yes, that's it. Now one case I will explain to this because when I was preparing this, one case came, so I thought I will illustrate. This tumor came from one of the patients. This was the morphology. Can you pick up anything in this? Sorry? Necrotic tumor, right? It's a necrotic lesion, but round cells are there. Okay. Based on these round cells, but see a few surviving cells were there, but they were not they were all pycnotic, dark staining. But they were telling glioma or metastasis, all those big differential diagnoses were there. One thing what happens now, problem what happens is clinician including radiologists are allowed to give a big list of differential diagnoses. Okay, the longer the differential diagnosis they give, that means they have evaluated the patient more. If a pathologist gives, means he is not confident. Okay, you have to reduce the differential diagnosis. So this what happens in this case, they had given metastasis, tuberculosis, lymphoma, all those things. But this was bothering me. But one thing was clear that it is a coagulative necrosis, looking like tumor necrosis, round cell were there. So we did CK, we did LCA. LCA came positive. and B cell, oh, I have not given. Then we did B cell. Fortunately, some of the proteins were intact. Many times necrotic tumor will not show any staining. We have diagnosed many times metastasis based on CK, all those things, especially in CSF. We have done CSF will come. Based on few cells we have shown. This came as primary B cell lymphoma. The radiologists then he correlated. He agreed with that. They were very happy. I don't know how patient. This why this happens because they're extremely sensitive to steroids. If a patient is subjected to steroids, they will have lymphocytolysis, and that's what happens. So finally, we have to all these higher techniques will not replace us. But if we are not ready for it, then there will be a risk of our job. So we have to be equipped with that. Of course, for that, not one person cannot do it. It's all the team. We have to go everyone together with the management's help only. Okay, with the management is not supporting, you cannot do anything. But I told you some simple mechanisms, is it not? Where with minimum IHC, how we can plan. But whatever it is, you have to build a team within the department and inter-department also. So use judiciously. At every level, we have challenges. In our country, challenges is bound at every step, and we have to go ahead with that. Okay. Thank you so much, and all the very best.
Thank you, sir, for giving us a greater knowledge and understanding about the application of IHC and molecular studies in CNS tumor. I would request Dr. Nirmala ma'am and Dr. Jyoti ma'am to hand over a token of memento to Nandish sir. Ma'am.
One question. Do you? Yeah. Any questions from the audience? No. Do you routinely do IHC for all the CNS tumors? What about What about molecular genetics?
But if a case comes as glioma, it will go with IHC. Without IHC, it won't go.
Will be the cost?
Cost actually, it was very nominal till last year. What happened post-COVID, during COVID, there was a lot of fund which has been exhausted. We went towards negative balance. So then government put across so many things. So what happened?
Kishan Prasad Sir, Professor in Pathology, KS Hegde Medical Academy, Nitte. Sir has 16 years of experience in the field of pathology. He has 149 publications, 101 international and 48 national publications. Sir is also a MEU coordinator. He is a secretary of KCIAPM SK unit. Sir is an active member in KCIAPM state chapter. He is a chairman of ethics committee KIMS and one of the members of board of studies RGHS. He has won the best teacher award in the year 2021. Welcome you, sir.
Good afternoon. It is a very difficult situation, as Nandish said. It is a pre-lunch and post-lunch session is very difficult. And also I'm seeing very few audience, even though I'm talking, but very few audience. Okay, so let us see. I will, depends on the situation, I can cut short my initial talk so that I can make interactive in my slide seminar. Allotted time for me is 1.5 hours. So I will try to finish within that, I will assure you. And it is always it is my pleasure. Jayashree madam, she was my teacher. And you know, as a PGs will be learning many of the times through adult learning. Always pleasure to have Dr. Nandish. He was my UG batchmate and also PG. Along with that, we studied. And Dr. Nandish and Dr. Ramaswamy. He was also as a part of adult learning. So many of the times, even in biopsy reviews, we forcibly used to say wrong answer, so that teachers should say why it is wrong. So that is also learning habit for you. I'm giving you a hint. Okay. So it is also I'm identifying the Kumar Guru. He's also a good friend. It is almost like a JJMMC. It is a mini JJMMC. PS Kuppam is called as a mini JJMMC. Many of the faculties or PGs after completion, they'll be coming here and they'll be settling. So my job is very easy. Always any topic without disclaimer, I will not start. Disclaimer in the sense, this topic is quite new to me. Even the topic is WHO 2020-21, what's new? It is new to me also. Because of this, I have learned many aspects. And also, I may not be working with just a institute with Nandish caliber, NIMANS, where they'll be exclusively looking at the neurology, muscle, and central nervous system. My institute, probably I'll be having around 100 to 150 cases per year. And recently we have started the ISC for CNS with Dr. Nandish guidance. Okay. So with this disclaimer, I'll be starting with this what's new in the 2021 classification. Of course, it's the right time to start with what's new because it is we are end of 2023. After 3 years, we are learning what's new in 2021 classification. So the methodology I'll be going with, like already it is almost a recap of many of the things what has been taught in the morning session. It is a WHO CNS classification overview 2021, changes in tumor taxonomy, nomenclature, grading, changes in tumor introduction of new tumor types, use of not otherwise specified, not elsewhere classified. This is a new terminology. Gene nomenclature, DNA methylation profiling of tumor, layered reporting, and specific changes in different tumors, and what is called a C impact updates if time permits. Okay. So this blue book, which we WHO blue book, it is look like it is there is some change in the color also. Now it is looks like a cyanosed. The color is changing to it is a cyanosed blue. So it is a latest update. There was a series of update within the it's a WHO classification of the CNS tumor. So this is the overall classification. Overall classification, there will be 12 categories. There will be 12 categories. How many? 12 categories. So remember this point. And what is the commonest tumor is, again, I'm going with Dr. Nandish, glioma, glioneuronal tumor, and neuronal tumor. First and foremost, whenever we dealing with majority of the cases, around 60-70% of the biopsies what we receive, it's a glioma, glioneuronal tumor, neuronal tumor. And also, we are having choroid plexus tumor, embryonal tumor, pineal tumor, cranial nerve or paraspinal tumor, meningioma, mesenchymal non-meningothelial tumors, and melanocytic tumor, hematolymphoid tumor, germ cell tumor, tumors of cellular origin, and metastasis to the SCNS. So we'll think always common tumor or the common thing. So we're looking at the first and foremost tumor is a glioma and glioneuronal tumor and neuronal tumor. So again, it is divided into 4 types. Each 4 type has some subheading. Again, it is a revise of today morning talk. Adult type of diffuse glioma, where again molecular things are taking up. So it is important. So maybe when we were studying, so I think Dr. Ramswamy, Dr. Nandish, when we were studying, so whenever we used to read the molecular pathology related chapters, we used to just close the chapter and come back. Human pathology, especially the human pathology journal, we never read, but it is not so. We have to update ourselves with the molecular changing. And there is one similarity between this molecular pathology and CBME. Remember this CBME. So we are looking at the CBME curriculum for the UGs and for the PGs. So this CBME and for the UGs and postgraduate, it is also something called as outcome-based it's a curriculum. So similarly, this molecular pathogenesis, it is bringing up, it is a molecular nomenclature, it is brought up basically because we are looking at outcome-based treatment or outcome-based management of these tumors. Okay. So adult type, even recently when I was looking at, so I was interacting with the famous Dr. Pradeep Vaidishwar. I think you may be aware, many of, he is from Bombay. So he was talking about this, even many cases of sudden death. Many of the cases, you including me, including you, many of the time, you may not get obvious reasons, obvious pathology in the autopsy. So he was telling, so now there is molecular pathology to detect what is the specific lesion in negative autopsies. So it is changing everywhere. Molecular pathology is a future of pathology. Those are it's a postgraduates. If you want to pursue some higher education, go ahead with the molecular pathology. It is a future of pathology, molecular pathology. So this adult type of diffuse glioma, it is further classified into, there are various subheading: IDH mutant, 1P, 19Q, co-deleted, or IDH wild type, or pediatric diffuse high-grade glioma like histone mutation, particular histone mutation, H3K27, H3K34, or H3T IDH wild type, infant hemispheric glioma. So like that. So pediatric low-grade glioma, so there will be MIB altered, angiocentric, or polymorphous low-grade neuroepithelial tumor of young, diffuse low-grade glioma with specific genetic alterations. And there will be circumscribed gliomas like pilocytic astrocytoma, high-grade astrocytoma with the pyloid features, pleomorphic xanthoastrocytoma, subependymal giant cell astrocytoma, choroid glioma, and astroblastoma MN1 altered. So why this it is a classification changes? It is, who is giving the suggestion? It is given by one consortium to inform molecular and practical approaches to CNS tumor taxonomy. It is called a C-impact. Okay, C-impact. So they'll be continuously meeting and they'll be giving suggestion how to alter the CNS classification. So they'll be periodically meeting for this updation within the WHO classification of the various tumor. So what are the major changes compared to the 2016? So there are major changes are the revision in the CNS tumor taxonomy or the nomenclature, revision in CNS tumor grading, restructuring of tumor groups, or introduction of new tumor types, or use of not otherwise specified or not elsewhere classified, and integrated diagnosis or layered reporting, and usage of DNA methylation profiling for diagnosis of some tumor, and changes within the nomenclature for certain genes. Okay, we'll skip this. what are the diagnostic tool is required for ultimate WHO classification is, of course, light microscopy we can't forget, where it is a daily bread and butter. Apart from that, do some histochemical stain. Also utilize electron microscopy, it is immunohistochemistry and molecular genetics. Okay, molecular genetics in the form of maybe DNA sequencing, RNA sequencing, or fish, or any profiling, or methylome profiling, or copy number profiling, any of this. Use all this and come with the new classification. So what are the changes? What are the changes within the taxonomy? So there will be certain changes is genetic changes required to make complete diagnosis. Genetic change. That means one example I'm giving you, astrocytoma IDH mutant. Okay, astrocytoma IDH mutant, or diffuse midline glioma with particular histone mutant or histone mutant, or genetic alteration are not essential but supporting diagnosis. Is good example is a pediatric type low grade glioma, which I'll elaborate little more, and the glioneuronal tumor, and molecular feature which will help to define new types, like as Nandish said, medulloblastoma WNT activated, or medulloblastoma SHH activated. Okay, and a certain tumor where molecular alteration is not required at all, like meningioma. It is not option. It is not mandatory. Okay. It is a also. It is a. They have tried to make it very simple. This classification make it very simple, but there are some ambiguities. Always there is a chance for improvement. Okay. So there will be tumors with highly characteristic features, choroid glioma occurring in third ventricles. Okay, and some tumors names reflect the morphological features like myxopapillary ependymoma, pleomorphic xanthoastrocytomas. Some tumor names had anatomic site modifiers like choroid glioma of the third ventricle, particularly occurring at the third ventricle. Some tumor names did not have modifiers despite occurring in specific location. Medulloblastoma, where it is occurring? Posterior fossa, infratentorial. Okay. Some new tumor names have genetic modifiable. As I said, glioblastoma, IDH wild type. Some tumors name did not having specific genotypes, like names did not, despite having the specific atypical teratoid or rhabdoid tumor. Okay. This is one change. One is called as CNS tumor grading. Tumor grading. What are the change? So initially it was used in Roman numerals. Now it is changed to Arabic numeral. Why it is so? So when we insist for UGs, we'll be saying blood grouping, mention, plus or minus. We'll insist for right positive or negative. So why? There is always chance for negative become positive. So like that, to overcome this ambiguity, so probably they want to change to uniformly make it just like any other non-CNS tumor. So how we are using 1, 2, 3 for this. So they want to make it uniform. So they are using an Arabic number. And they'll be insisting for you is to use CNS WHO grade 1, 2, 3. So particularly asking you to say CNS WHO grade 1, 2, 3. Okay. And again, this point also, it is so many times we said anaplastic term is eliminated. Anaplastic astrocytoma, we used to say, now the term is eliminated. And grading within the tumor, So like what is this grading within the tumors? So like one a good example is patient is having astrocytoma IDH mutant. Okay, IDH mutant can have 2, 3, 4. The grade can 2, 3, 4. Okay, suppose astrocytoma IDH wild type. What is the grade? IDH wild type. What is the grade? 4. Always 4. Okay, always 4. So it is what we say, it's a glioblastoma. We used to say IDH wild type. So it is grade 4. So ependymoma. Now it is a further graded 2, 3. So like that. Next is this is the classification. So what I said is astrocytoma, IDH mutant, CNSO grade 2, IDH mutant 3, IDH mutant 4, and wild type CNS grade 4. And as Nandish was insisting for oligodendroglioma, IDH mutant, and with particular translocation. 1P 19Q. What 1P stand for? P stand for short term. Okay, P. What is the full form of P? It is a petit. Okay, it is a petit. So it is a P 19Q co-deleted. Okay, so it is a grade 2. So grade 2 oligodendroglioma. Next is usage of the word type and subtype. So initially we used to say entity and variant. Now it is replaced with type and subtype. No more we are supposed to use entity or the variant. One good example I'm saying, so it is a meningioma. So meningioma is a single type of the classification, single type. Okay, all other subtypes. Okay, so there initially it was typed as a, so it is a variants of the meningioma. Now it is called as subtypes. Okay, they are called as subtypes. Next is clinico-pathological grading. Clinico-pathological grading. So what do you mean by clinical pathological grading? So it is whenever IDH mutant astrocytoma, it will grade from 2 to 4. Okay, and meningiomas, it will grade from CNS 1 to 3. Okay, in other word, there will be no CNS tumor with IDH mutant astrocytoma. There will be nothing like a grade 1 IDH mutant astrocytoma. There is nothing word. Okay, or CNH WHO grade 4 meningioma. There is no term. There is no term at all. It is something to do with the outcome. They have tried to classify. Next is as somebody was discussing this morning. Somebody was discussing about this morning. Suppose it is even though the histology wise or certain IHC wise there is looks like a grade low, but there will be certain genetic alteration is there. Automatically it will go for higher the grade. It will go for the higher the grade. One good example is astrocytoma IDH mutant. It can be 2 to 3 or 2, 3, 4, anything. But if it is this particular gene is mutated or this homologous deletion, like a CDK N2A 2B homozygous deletion, if it is there, okay, or similarly, it is a this automatically it will jump to it is a wild type or it is a grade 4. It will go for the grade 4. So this genetic alteration, if you prove, even though histology wise it is looks like low grade, it is automatically grow for higher the grade, aggressive course. Like certain tumors, there is no grades are allotted. One example is diffuse leptomeningeal glioneuronal tumor. It is need not be always graded. Sometimes certain tumors are not grades. Grades are not assigned. Like astroblastoma, MN1 altered, no grading is possible. So this all the change what we are seeing in this. Okay. So this EGFR mutation and one more mutation. What is the one more mutation? What is the one more mutation? Generally seen in the astrocytoma, EGFR and TERT mutation. Okay, TERT promoter mutation. Okay, TERT promoter mutation. So this also it is one of the essential criteria to classify further according to the WHO classification. They are using one more term is called as utilizing the essential diagnostic criteria. It need not be for only WHO. It is useful also for other tumor. If you go back all the WHO non-CNS tumors also, they are almost in the end, they are telling this tumor has some essential criteria and desirable criteria. Okay, desirable criteria. Essential and desirable. Desirable is essentially is out of 4 must have, like Jones criteria, what we used to say. Okay, so these are minimum criteria. So minimum 1 or 2. Okay, desirable maybe have, may not be have. So like this. So they have used what is called as essential diagnostic criteria. Essential diagnostic criteria. One example. And also usage of not otherwise specified and not elsewhere classified. What do you mean by this? Not otherwise specified means. So you have it's understood there is some necessity for IHC or you identified there is some necessity for the genetic alteration to be documented. But in many of the center, you may not be having the facility. Okay, you're not done. Can we able to say IDH wild type based on the morphology? No. So what you're supposed to say in such cases, IDH NVOS or it is a high grade glioma NVOS. It is a fairly enough. It is a fairly enough because you are not done. You are not done the studies. Certain tumors where you have done all the genetic studies, still not able to classify, exactly categorize. Well, what you're supposed to do? So you are supposed to use what is called as not elsewhere classified. So understood the difference between these two. So one, you are not done the molecular or IHC testing which is required, and in where you have done but not able to categorize further, NOC one and another is NEC, not elsewhere classified. Okay. So next is as I said, essential and diagnostic criteria. Again, I will skip. Okay, one of the example I can quote is glioblastoma, IDH wild type, grade 4. So these are all the essential criteria. Like microvascular proliferation, necrosis, EGFR gene amplification, TERT promoter mutations. Okay, and also have the desirable criteria. Maybe have, may not be having. Is it clear now? The essential criteria or the desirable criteria which is specified for the newer classification in the WHO. Next is quantification of the mitotic count. Again, it is extensively elaborated in the new classification. What is this? It's a quantification of this. So they have specified how you express the mitosis. Okay, how you express the mitosis. They have specified mitotic count expressed as a number of mitosis per defined area in millimeter square or high power field. You need to categorize what is the mitotic count based on the this type, based on this type. So based on this type, depends on the mitosis, you will be categorizing further. You will be categorizing the lesion further. So I will not go in detail about this. You can, it is given in the WHO book. Next is integrated diagnosis. What does integrated diagnosis means? What is integrated diagnosis? Integrated diagnosis means it is a combined histological and molecular diagnosis. Okay. What do you mean by this? You are having the histological diagnosis, astrocytoma, one example, CNS WHO grade, maybe 3, molecular information, whether it is there or not. Okay, you will be collaborating all 3 diagnoses and giving the integrated diagnosis. One example I am giving you. In this condition, patient is having ependymoma, which is looks like grade 3, but on paraffin fixed or formalin fixed paraffin embedding tissue, not able to document particular genetic alteration. So what you're supposed to give? It is location wise supratentorial ependymoma NVOS. Okay, NVOS. So this is one example. So this is called as integrated diagnosis. So next is use of novel technologies like methylome profiling. Again, it is a, I know even very few centers this methylome profiling is available. Even it's a WHO not insist for this, but they will ask you recommend to undergo what is called as methylome profiling. So certain tumor, okay, it is a like one example I am telling you, high grade astrocytoma with the pyloid features. It is exclusively diagnosed based on methylome profiling. Even though WHO says it is a mandatory, it is not. It is a better to do. It is not insisting for this. Okay, but unusual tumors like high grade astrocytoma with the pyloid features, it has to be confirmed with methylome profiling. So they'll be recommending you to ask for methylome profiling. Next. Okay. Usage of this gene and protein nomenclature. Okay. So what they are insisting is they'll be asking you to gene symbols. It should be in italics. It should be written in italics, and there'll be C and P. C and P. It is a protein or it's a sequence alteration. and protein sequence, it should be written in proper manner. So always whenever you are writing the gene symbols, it should be in italics, okay, and it should be with the small c or small p, okay. So it's the sequence alteration or the protein sequence. One you can see the example we have quoted HL3 slash 3A P. It is basically it is indicating sequence alteration, and P it is indicating a protein sequence. Okay. Next is there are some new entities are recognized, new recognized tumor types in the WHO CNS5. What are the new WHO types? Again, majority are under the glioma or glioneuronal or neuronal tumor. List is quite big. There are recently now they have added 22 tumors in the new categories. Majority are glioma or glioneuronal tumor, like starting from diffuse astrocytoma, MYB or MIBL1 altered. I will not read all this. I will not read go and again. In ependymal tumor, which I will come back little later, ependymal tumor based on the fusion gene alteration. Okay, so it is classified into A type, B type, and this particular fusion gene or some amplification documentation, or other embryonal tumor like cribriform neuroepithelial tumor, CNS neuroblastoma with a particular gene alteration, or CNS tumor with some duplication, or within the pineal tumors of cellular origin, there are certain particular tumors are identified, or certain uncertain tumor differentiation. So they are having like a primary intracranial sarcoma, so like that. So they identify the tumor, around 22 tumors, they are added in the new WHO classification. Next is revised nomenclature in the CNS5. Okay, as I already said, I said this grading is very important. Like astrocytoma IDH mutant. Okay, what is the range it is having grade? It is a 2 to 4. Okay, and is there any, what is the, if you are using the glioblastoma, what should be the type? How we are supposed to say? IDH wild type, and it should be grade 4. Okay, you can't say astrocytoma IDH mutant glioblastoma, you can't say that. Okay, and diffuse midline glioma, particular gene, histone gene alteration, H3K27 alteration. Okay, and supratentorial ependymoma with a particular fusion gene protein positivity, ZFTA fusion positivity. Next, the choroid glioma. Okay, so it was initially it was called as a third ventricle. So now they have removed the site. So third ventricle, choroid glioma, or embryonal tumor with multilayered rosettes. Okay, so initially it was associated with some genetic alteration. Astroblastoma with they have added now MN1 alteration. So they added the genetic modifier. So like that, again, certain tumors are particularly added with minor alterations with adding the genetics, or some other alterations within the nomenclature. If you go back to this glioma, so broadly it is classified into gliomas, diffuse gliomas, adult diffuse gliomas, or it may be diffuse gliomas, maybe adult diffuse glioma, or pediatric high grade glioma, or pediatric low grade glioma. And also we are having the circumscribed glioma and ependymoma. Okay, name some circumscribed glioma, pilocytic astrocytoma. Any other? Pleomorphic xanthoastrocytoma. So there are, okay, around 5 to 6 types of circumscribed tumors are there. Okay, remember this ependymoma are classified under the gliomas now. And in the diffuse type, we are having adult type, pediatric type, high grade, and pediatric low grade tumor. What is the basis for this classification? What is the basis for this classification? Again, within the certain gene alteration or genetic mutation. Okay, so now adult type has 3 types. What is called as glioblastoma, IDH wild type, oligodendroglioma, IDH mutant, and what is the deletion you are supposed to document? 1p19q, okay, co-deletion, and astrocytoma IDH mutant, okay. And we are having the low-grade glioma, and it is a pediatric glioma. It is further classified into low-grade glioma and high-grade glioma. In the circumscribed tumor, we are having all tumor types like choroidal glioma, pilocytic astrocytoma, pleomorphic and all these 6 types, okay. I will skip this. I will skip this. Okay. I will skip this. Okay. In 2016, this astrocytoma was diffuse astrocytoma, anaplastic astrocytoma, and glioblastoma. Now it is relabeled to astrocytoma, IDH mutant 2 to 4, and IDH wild type grade 4. Glioblastoma is not a separate heading in pediatric tumor. That is also very important point you should remember. Okay, and already I said there'll be essential criteria. Essential criteria to say glioblastoma wild type. What are the essential criteria? Apart from microvascular proliferation, apart from mitosis, there'll be EGFR gene amplification, third promoter mutation, and chromosome copy number changes. Particular copy number changes. Okay, so this is you can it is a summary of what I am trying to say here is any diffuse glioma, IDH mutant, okay, wild type, go for all this, okay, essential criteria classified into whether it is a glioblastoma, IDH wild type, or CNS grade 4. If it is a mutant, it is ask for ATRX. Also, Nandish said ATRX mutation is also essential. ATRX, whether it is a mutant or ATRX retained. If it is a ATRX retained, it is oligodendroglioma. It is IDH mutant and confirm with the 1p19q co-deletion confirmation. And if it is a ATRX mutation is documented, look for microvascular proliferation and necrosis, then classified into astrocytoma IDH mutant grade 4, higher the grade. Okay. If particularly there'll be, if you're documenting CDK2A deletion, even though they are 2 or 3, so it is automatically, if you document this gene alteration, it is automatically fall under the WHO grade 4 IDH mutant type. Okay, so this is the pediatric low-grade gliomas and pediatric high-grade glioma. What are the pediatric low-grade gliomas? We are having the angiocentric gliomas, pediatric type oligodendroglioma, it is a pediatric type astrocytoma, isomorphic astrocytoma, or the newer entity, PLNTY. Okay, and also high-grade gliomas like diffuse hemispheric glioma, infant hemispheric glioma, pediatric high-grade glioma, and diffuse midline glioma. All this based on the particular gene alteration, gene mutation. Okay. Next, what about the changes within the ependymal tumor? So within the ependymal tumor, again, genetics plays very important role. Okay, what are the changes? Again, based on the location, whether it is a supratentorial or it's a supratentorial, or it is a posterior fossa, or it is a spinal. And genetic alteration is very important. ZFTA or YAP1 fusion positivity, supratentorial type, posterior fossa ependymoma type A and type B, and spinal ependymoma MYCN amplified. Little go in detail about this. What is the gene required to document ependymoma now? ZFTA and YAP. Okay, so 2 gene is required. 2 gene is required, and within the tumor, there is a grading. Now, this mixopapillary ependymoma, whether it is will look like pleomorphic for you or not, by default it will be grade 2 because there is always chance for a recurrence. Okay, recurrence. And papillary clear cell and tannicytic, it was initially, it was a type of variant of this ependymoma. Now it is no longer type. Okay, so it is instead they said it is maybe pattern of any of this type of ependymoma. Okay, and also the this RELA fusion gene, it is replaced with the ZFTA fusion gene in the WHO 5th category. I will skip this. Okay, so within the meningioma, it is a single type. There is nothing like it is a variant. So initially it was called as variants, various types like a clear cell, all this. Okay. Now one thing what they've done the change is, suppose if you are seeing the features of pleomorphism or there is some increased atypical mitosis or pleomorphism, whatever the type, whatever the meaning, it is a type. Okay, it is automatically it is a fall under 2 or 3, whatever the type. So initially it was not so. It is a clear cell or chondroid. It is a by default it will be 3. Okay, like that. Now even meningothelial variant also, if it is having atypical mitosis or it is atypical mitosis or necrosis, if it is more, automatically it will be categorized into grade 3. Okay, grade 3. So that is a change you are seeing. And also they are trying to document some of the gene mutation. Again, it is optional. It is not mandatory. It is not optional. It is optional. I will skip this. Okay, within the it is a embryonal tumor. So they are again particularly giving importance for medulloblastomas, particular gene mutation, WNT activation, SHH activation. Okay, it may be wild type, or it may be mutant type, or it may be non-WNT or SHH activated. All depends on the prognosis. All depends on the prognosis. And also we are having other embryonal tumor like atypical teratoid, embryonal tumor, multilayered rosette, or CNS neuroblastoma, or FOXR2 activated. So like this, CNS embryonal tumor not otherwise classified. So there are varieties of medulloblastoma or embryonal tumors are specified. What I said is gene mutation is required in a SHH, WNT, and how I can say, as Nandi said, do the genetic alteration, look for beta catenin or GAB1 or YAP1 or P53 and INI. Okay, INI. If it is a WNT mutated, it will be showing beta catenin positivity and YAP positivity and INI1 retained. If it is SHH mutant, it will be GAB1 and YAP1 and P53 and INI1 will be retained. And if it is a non-WNT, non-SHH, all this it will be lost and INI will be retained. So that's a way to classify this medulloblastoma. This choroid plexus tumor, not much classification. I will not go into detail. We are having choroid plexus papilloma, atypical choroid plexus papilloma, and choroid plexus carcinoma. Not much change. Within the pineal tumor, again, genetic changes are added, but it is not mandatory. It is not mandatory. It is a one particular tumor is added is desmoplastic myxoid tumor of pineal origin, pineal region, with a particular mutation, SMARB-C1 mutant. Otherwise, not much of change within the pineal tumor. Next is we are having the in the cellular tumor classification. The change what we are seeing is in the past edition, the craniopharyngioma, adamantinus type or papillary types, it was called as subtypes. Now it is classified as a separate variant or distinct tumor types. Distinct tumor types, adamantinus craniopharyngioma or papillary craniopharyngioma. And also one recent tumor which is classified is PITNET. Okay, what is PITNET is pituitary neuroendocrine tumor, which is added in the newer classification. Otherwise, not much change within the SLR tumor classification. To summarize, what are the changes what we are seeing within the WHO 2021 is there are new entities added. How many broad classification I told you? 12. Broad classification is 12. Okay, out of which new entities added are 22. Okay, and revised nomenclature for 14 tumor, and essential and desirable diagnostic criteria is added. What do you mean by this? Must to have, better to have. Okay, so this is simple. Essential criteria and diagnostic criteria is added. Okay, and there are 3 types of adult diffuse gliomas. Okay, and while grading, Roman numerals are removed. It is replaced with Arabic numerals, and we are using the type instead of entity. subtype instead of variant. Okay. And the glioneuronal or neuronal tumors are divided into 6 families. If particular gene is documented, even though tumor is low grade, by default, if a particular identify the particular gene mutation, it will go for the higher the grade. And in the especially in the medulloblastoma, there are particular gene identification is very essential for the prognostication, WNT, SHH, and based on this, it is classified into SHH mutant or WNT mutant or non-WNT, non-SHH medulloblastoma. Okay, pediatric tumors or gliomas are classified into low grade and high grade gliomas, and meningiomas are graded in a single type as a single type. And in the ependymiomas, they are particularly looking for the particular gene mutation, ZFTA fusion gene. And choroid plexus are separated from the gliomas and glioneuronal tumor or neuronal tumor, and they'll be under a separate heading. So this is the overview of the new WHO classification. Okay. Any doubts within this? Okay. We'll go to the next. ಇನ್ನೊಂದು PPT. Madam? Yeah. Now it is a time for you to interact. I will stop at some area. Okay. Straight away without taking much time, so I'll be straight away starting the case. This is the case 1 of 4-year-old child with the difficulty in walking upstairs, downstairs, history of difficulty in wearing pants or slippage of slipper from foot. Okay. Again, looking at the age, what do you feel? CNS. It is what type of tumor you are looking at? If you are expecting any ependymal tumor or glioneuronal glial. Okay, glial or glioneuronal tumor. Can it be meningeal origin? May not be. Okay, based on this. Why I'm insisting is many of the times you will face the diagnostic difficulties. See the CT. Many of the times it will solve your problems. Okay. Okay. What do you feel now? Clarity. Don't say clarity issue. Okay. Yeah, that is there. Okay. What do you want to which category of tumor you would like to classify? Which category of tumor you would like to classify? Gliomas, any gliomas you would like to say? Go with the gliomas. Pediatric. Okay, pediatric gliomas. Okay, low grade or high grade? Why low grade? Why high grade? If you say cellularity is okay. So evenly placed. Okay, evenly placed. Always think it is a low grade. And if it is a cellularity is more with the microvascular proliferation, mitosis is more. So generally give importance for the high grade gliomas. What next? What will you do? What will you do? Huh? 40x I will not give. Okay. Apart from that, what else you will do? Always you don't have the facility of always calling Nandish. Okay. So something else you should do now. So go with So it is a BRAF mutation. So it is just like you are catching one Udan and trying to catch a flight to Delhi. Okay. But is it okay to, how will you reach the Bangalore airport now? You need to go with IHC. Start with the IHC. Okay. What IHC marker you would like to ask for? Huh? IDH. Okay. So yeah, IDH, I will show you. Okay. GFAP is positive. OLIC2. What is the significance of OLIC2? Today morning, Nandish was telling. So OLIC2. Why it is important? It is also essential. Say it is a something sort of you are looking at a glial origin only. Okay. GFAP S100 which came positive, and OLIC2 is positive. OLIC2 is positive. IDH1 mutant or wild type? IDH mutant or wild type now? Nandi should say IDH mutant. Okay, IDH mutant. What about Atrax? Huh? Negative. Okay, retain. Retain. Okay. ಅಲ್ಲ already ಹೇಳಿದ್ದೇನೆ. Okay. So, okay, I will come back to this answer later. Okay, so based on this, what do you feel now? It is a, you feel it is a glioma. Okay, if according to the WHO 2021 classification, where do you want to categorize this tumor? Glioma, NVOS, you will say NVOS. IDH mutation is done. Okay. What else is required? As Nandi said, molecular genetics also is required to exclude. Okay. Molecular genetics is required to exclude. Where you want to classify again now? There will be certain genetic alteration is required to document, right? Okay. Which you have not done. What you will do? It is incomplete. It is almost like incomplete. It is a part of the things you have done. Okay. Where you will stop? With resource limited setup. Where you will stop? In this K67, it was around 30 to 40%. 30 to 40%. Okay. So around 40%. Even though many of the times what we're observing is histology wise looks like a bland, you should look for the hotspot. Okay, you should look for the hotspot, highly mitotic active area, and the K67 was 40%. Okay, so in the resource limited setup, so what I will stop at is high grade glioma, WHO grade 3 or 4. Is it fair enough, Nandish? Three. Grade 3. Okay, we'll so we will stop at WHO high grade glioma grade 3. Okay, grade 3. Okay, what else you would like to ask for? Molecular testing is required. What are the molecular testing you would like to ask for? Yeah, there are many deletion, yeah, mutation you need to document. Otherwise, your answer is incomplete. Okay, so I will stop at here. Okay. Okay, so this is one more case. It is a 63-year-old. 63-year-old. Where is the lesion? Parenchymal lesion, more of parenchymal lesion, which looks like a necrotic area also. Necrotic areas also. It is a 2x, 4x. Okay. High grade. Okay. High grade glioma. You will be going to the high grade glioma. Yes or no? Afternoon 3 o'clock. It is very difficult to concentrate. I know that. Okay. Okay. And also the image, I know that there is some, can you make out any papillae here? There are some papillary structures are there. Papillary structures are there. Okay. And here also something core like, okay, high core. So there are numerous papillary cores also we are seeing. Okay. What else you will do now? So looks like a high grade tumor with the papillary cores. Okay, what are the possibilities you would like to think? Huh? Metastasis. Okay, fair enough. Okay, next. Choroid plexus. Yes, carcinoma. I will agree. Okay. Any tumor of meninges which is having the papillary tumor, papillary architecture? Type of meningioma. Initially used to say it is a papillary meningioma. Yeah, it is there. Yeah. And recently it is a classified one more tumor, papillary glioneuronal tumor. Anyway, it is a, not looks like a papillary glioneuronal tumor. It is some sort of high grade papillary structure, tumor with the papillary structures. Okay. What else you do? What will do? Ask for ISC. Okay. High grade papillary. Okay, even including it is even a squash also it posed a challenge. We said it is a high grade papillary tumor. It posed a challenge everywhere. So possibility we thought was choroid plexus carcinoma and metastasis. Look at the CT. It is not near to the ventricles. Okay, not near to the ventricles. Okay, okay. What we did is again GFAP S100, even including nice papillae are there. Olic 2, nicely it has taken up. And EMA, positive or negative? EMA is positive or negative? I will say it is a negative. It is a false positive. Remember this. So you are supposed to appreciate membranous positivity in EMA. It is not looks like, it is a false positivity. Okay. It is a IDH mutant. It was IDH mutant, IDH positive. Okay. So what is the tumor we are looking at? With these two GFAP, S100, OLIC2 positivity. And we said the PAN-CK, it was negative, EMA negative, TTF1, papillary was there, so it was there. Okay, negative. Okay, where we are lining up now? So we again said high grade glioma. So this also is we discussed with Nandish also, he can remember. Papillary patterns will confuse everywhere. Okay, even high grade gliomas also can have the papillary pattern. So that is a lesson learned from this case. Okay, so don't think some extreme. It is a case of high grade glioma, IDH mutant high grade glioma, astrocytoma, but we are not done the further genetic workup or any other studies. This is the case 3. Case 3. It is a spinal tumor. Spinal tumor. Okay. Now, very cellular, very hemorrhagic, very pleomorphic cells. What you would like to think of? What you would like to think of? What you would like to? How will you proceed? How will you proceed? Ask for IHC. Ask for IHC. Again, GFAP, OLIC2, S100 came easily positive. Okay. It is also SOX10 and P53. I think it is a P53 or some other case. Okay. There was necrosis. Okay. Tumor cells GFAP, S100, OLIC2 positivity, and P53 it was scattered. PAN-CK TLE was negative. K67, 67, it is around 60%. Okay. Again, we said it is a high grade glioma, WHO grade 4. Okay. It is also IDH mutant. It is IDH mutant. This is one more case. 42-year-old. Where is the site? Where is the site? Pituitary or cellular region. Okay. 2x, 4x, 10x, 20x. I will be stopping at 20x. Low grade tumor is looks like low grade. Low grade. We'll go with low grade tumor. What else you do? IHC. Okay. What IHC would like to do? What I have done is NSC and synapto. What is the tumor? Synapto positive, NSC positivity, GFAP negative. It came GFAP negative. It is a pineocytoma, WHO grade 1. Okay. Okay. Everybody is with me? Everybody is with me? Okay. Okay. So now it is a 16-year-old. Looks like a mediastinal mass, presented with a mediastinal mass. It is extramedullary intradural mass. Neoplastic origin, neural origin, they thought it could be ganglioneuroma. Tumor is nice and bulging into the mediastinum. Why everybody silent? Okay. Where we are heading at? Where we are looking at? Okay. Where you want to go to, like? Okay. Histology wise, what you would like to think of? Huh? At least go with the small round cell. Everybody agree with the small round cell tumor. I don't want to hit the exact target. Okay. Okay. Now proceed with what are the possibilities you would like to think of? What will you do? What will you do? What markers you would like to ask for? Any possibilities? Okay. Any markers? Okay. I will think. CD99 positive. NKX is very strong. NKX2 positivity. Okay. Okay, immunosuppressant short CD99 and NKX2 negative for LCA, TDT, FLE1. Okay, where we are looking at? Ewing's for PNET. Okay, so we are looking at Ewing's and extraskeletal Ewing's. Okay, look, NKX2 very strongly positive. So it is we are looking at Ewing sarcoma. Okay, it is a spotter. It is a spotter, not just based on the history. Okay, it is a 43-year-old female, craniotomy excision for meningioma. Okay, it is not my case. It is a contribution from Sathya Sai Institute of Higher Medical Science, Bangalore. Fastest finger. Everybody is so silent. Ganglioneuroma. Come on. Don't think that whatever I am giving is a CNS tumor only. Histiocytic, parasite. Okay. The hint is pilocytic. Come out of pilocytic. Come out of pilocytic. Okay. The hint is there are center cells also. Yeah, here also. Look at this. It is a nucleus is there. Nucleus is there, and it is round. Something engulfed inside. Phagocytosed. What it has phagocytosed? What it has phagocytosed? Sinus histiocytosis. What do you want to call? Roside-Orpman. It is a case of Roside-Orpman. How will you proceed? How will you proceed? How will you proceed? What marker you would like to ask for? CD 68, S100 came nicely positivity. So it was a case of Roside-Orpman presented as meningioma. Okay. Okay. It is a 74-year-old. Okay, suspected of meningioma or metastatic. Biopsy from the sphenoid wing. Sphenoid. Sphenoid. Why everybody is so silent? Even in our UG class also, nobody will be so silent, including UG students. Okay. Now, where we are looking at? Okay, well, come on, it is a common tumor. I think Ramswamy has given some hint. You will be showing to the UGs also. You will be showing to the UGs also. Meningioma. It is a case of meningioma. What markers you would like to ask for? Not necessary, need not have. Okay. EMA and PR, even including PR also can be positive. Okay, PR positivity. So it is a case of meningioma, meningothelial. So common tumor also can occur in some unusual location. Post-diagnostic challenges for you. Okay. This I will skip. Okay. Now this one, 25-year-old male. It is a swelling over the left side of the head. Dural based. Extraaxial mass. Okay. Their DD was hemangioparasitoma, meningioma, or metastatic mass. Metastatic mass. So intraoperatively, they noticed tumor was found beneath the galeal layer. It was adherent and eroding the bone, and a complete excision was done. So this was the excision specimen. Skull bone, and there is some friable mass with more of hemorrhage, necrosis and hemorrhage. Okay, where are we? If image is so good, it is a Nandish, courtesy Nandish. It is image of Dr. Nandish. He knows the case. Image is so good quality. Dural based mass. Dural based mass. What you should think first always is common tumor at common site. What you should think of now? Meningioma. Think of meningioma. Okay. So is it meningioma? What markers you would like to ask for? EMA, PR, or ask for? So aggressive means is it KI67 is aggressive, and it is invading the bone also. But the story continues. Okay. We gave, it could be malignant meningioma. Okay. But it is we sent to Nimans, which came as CD31 and FLE1 diffusely positive, Vimentin positive, CK patchy positive, and HMB45 S100 GPAP negative. MIB is 15 to 18%. What tumor we are looking at? Huh? Hemangioma? Hemangioma? Hemangioblastoma? High MIB. Very aggressive tumor. It is cells are aggressive. Cells are aggressive. Angiosarcoma. Okay, angiosarcoma. Look, good. Okay. Angiosarcoma, whether it will have epithelioid morphology? This morphology? It is look like epithelioid morphology, right? Okay, epithelioid morphology. Okay, let us see. So Vimentin positive, CD31 positive, FLE1 positive, ERG positive, MIB quite high, and pan-CK also positive. What is the tumor? So it is a rare case of epithelioid angiosarcoma. That's why even CK also came positive. So this is the case we got diagnosed with the help of Dr. Nandish, and we published this data also. Thank you. Okay. This okay, I will skip. Okay, case 9. Okay, 61-year-old male. Okay, CT they said looks like a glioblastoma for us, and it was done. A squash was done. It was looked like high-grade malignant neoplasm, 2x, 4x, 2x, 4x. There is some nodularity also invading the brain, spindly cells, MPNST. Okay, we did the Vimentin positive, P53, GFAP. It was positive in the glial area, EMA positive, OLIC2 positive. Vimentin positive, P53, OLIC2, EMA positivity. GFAP glio area, gliomatous area, and also look for the sarcomatous area. Now, think of gliosarcoma. So remember this point, gliosarcoma. Now, where it is classified in high-grade glioma, IDH wild type. Okay, IDH wild type. Okay, so this is a recent case around 1 month back, 54-year-old female. Where is the lesion? Dural based. Looks like a dural based mass. And also there is some sphenoidal region, there is some mass. 2 lesion. We are looking at 2 lesion. Whenever multiple lesion, what you should think? Metastasis. Let us see whether it is a metastasis. But squash showed small cell. Plasma cell. Okay. It is a plasma cell. Plasmacytoma. It is a plasma cell. And electrophoresis M band positive. And biopsy sheets of plasma cell which expressed CD20 negative, CD38 positive, and MUM1 positive, and there is some kappa chain restriction. Where will be heading for? Multiple myeloma. Okay, so what you should confirm? Why it is not plasmacytoma? Ask for always bone marrow examination. So if a bone marrow is involved, it is a type, it is a myeloma. So categorized into myeloma. So bone marrow aspiration also showed plasma cell increase more than 10%. So we concluded it is a multiple myeloma. Remember this crab, whenever it is a brain or any bone is involved, it is a clue that it is involved the crab meeting the crab criteria. B, bone involvement. Okay. It is a 50-year-old female headache, well circumscribed lesion of the posterior cranial fossa, infratentorial. Okay, now if image quality is good, courtesy Nandish. Okay. Loose vascular networks with vacuolated cytoplasm, hemangioblastoma. Okay, it is a, so we confused, yeah, we confused for anaplastic oligodendroglioma that time and hemangioblastoma, or it's a variant of angioma. And finally, we concluded like it is a hemangioblastoma. Last case for today for me is a 58-year-old female, left-sided weakness, right parieto-occipital lesion, big lesion, brain, papillae. Okay, what you should think? Papillae means choroid plexus carcinoma, metastasis. Also, I told you one example. High-grade gliomas. Okay, high-grade glioma. But papillae is over the cells, nice papillae, but cells are very much abundant eosinophilic cytoplasm. Okay, abundant eosinophilic cytoplasm, sheets of cells with vesicular nucleus. And what is this picture? I particularly deliberately added numerous vascular channels. So that is also one of the clue. Think metastasis rather than the primary. Metastasis rather than the primary. How will you proceed? IHC. Okay. So it came TTF1 positive, CK positive. Where is the primary now? Lung. It is a metastatic papillary adenocarcinoma lung manifested as this. Okay. So how many of you know this? Everybody know. How many you like bean now? Including me, I like. But bean in different look. Okay, bean in different look. Why this picture is some common tumor? It will mimic you in different angle, and some it is an unusual tumor mimic you with some common tumor. It will confuse you a lot. So be careful about this. Okay, this is my department. Recently, we conducted the ISC workshop in March. Again, just like here, female dominated department. We are minorities here. Okay. Always welcome to Mangalore. Only place within 2 kilometers, you'll get 3 medical college. And only place in one city of around, there's a few area, around 7 medical colleges. Okay. So this is the Kshema where I'm coming from. We are moving from old Kshema to new Kshema with recently we have updated to 250 admission. So thank you very much.
Thank you, Kishan, for your elaborate WHO classification of CNS, as well as your new terminology. Still quite confusion. You have to read yourself also. Thank you.
Yeah, just to introduce few terminologies about it. Thanks for Kishan for nice cases and also for the WHO update. See, in any CME, there will be a heterogeneous group, first year, second year, third year, faculty, junior. It's very difficult to like cater to each cadre. So it will be usually any of the talks will be in the middle level only. Some will be new terminologies, some things. One is to create awareness, as Dr. Ram mentioned. Many times basic we will be understanding. Right now you have heard some terminologies, few which he highlighted I will be telling. Few if you have any specific doubts at the basic level which is crucial to understand rest of the things you can ask me now. Wild type means whichever is natural from the beginning without any alteration is wild type. You should not think actually speaking, we are also born wild. Wildness is not aggressive, naturally. In the sense, whatever you see by nature without alteration is wild type. Okay, the nature itself is wild. When you alter it, it's an alteration. Permanent alteration with or without actual manifestation is mutation. Okay, permanent alteration. So if something gets altered, that is mutant. And usually mutation, we always, most of the times what we think mutation to be always destructive can be of various types, but we are concerned of pathology. So whatever mutation we're dealing with are all pathological mutations. So that's why it's alarming. The mutations also of multiple types. One is where a loss of protein will be there, or an alteration of protein will be there, or addition of protein. Addition of protein generally happens when it is not properly degraded. Okay, that will not confuse it here in a tumor relationship. In a tumor relationship, we'll consider only those mutations where a protein gets altered in such a way that it becomes malfunctional or toxic functional. Okay, malfunctional means it carries out abnormal function. Toxic function means it causes either proliferation, transcription, or more amount of division like that. That is the thing. So mutation can be at a cytoplasmic mutation protein level, transcription which is intranuclear, and there will be some loss of proteins also. We are like, for example, ATRX is a loss of protein, INI1, okay, H3ME3 methylate. Those are all mutations where there is loss of protein. There are some mutations which are which give rise to expression of the next level of protein, downstream proteins. You should be very careful. Mutation may not cause alteration in that, it may have caused alteration in that protein, but in the pathway, the next level of proteins get overproduced. That is called a downstream effect. So the one best example is P53. A mutation of P53 by itself may be overexpressive, or the previous mutation may make P53 overexpressive. So every time staining of P53 will not reflect mutation all the time. So mutation means an abnormal genetic alteration. Wild type means no genetic alteration, normal. That is the thing. Any other terminologies you feel difficult? Yeah. See, whatever IHC antibodies we are getting, no, they're all for mutants only. Why you want to test normal? By normal, it is assumed by default, anything which is normal is not going to demonstrate anything. Okay. So whatever proteins we are using, antibodies are all against mutant proteins only. If something is staining, it is mutant. But only problem what happens is negative. If something is staining negative, doesn't always mean it is totally normal. Maybe you are not detecting other mutations because we are testing one particular type of mutation which is detectable by an antibody. There may be rarer mutations for which antibodies are not available. For example, simple example I'll give you. IDH mutation we discussed. The commonest mutation is R138, where in that 132 locus allele, arginine is changed to histidine. That is the commonest mutation. But sometimes arginine changes to cysteine, lysine. Don't have antibody available for that. Okay, that is second. Third, there is R172H at the locus 172. There is no antibody available for that. So if a mutation comes positive on IHC, let's take R132H comes positive, then you can tell confidently mutant. If it comes negative by IHC, but you're not detecting the rarer mutations like R132, C, L, those things you're not detecting. So you cannot, just because IHC has come negative, don't call by default as non-mutant, because rarer mutations we are not tested for rarer mutations. Only when you do gene sequencing and you are very sure that there are no alterations, then only you can call it as wild type, because they are looking normal sequence. It is resembling normal sequence. That is the understanding. Okay. So basically what you see, as pathologists, we are comfortable only with IHC. So we are keeping that IHC because you every time you relate it to morphology, is it not? Some fish is also to some extent better. Why? Because still it is under our arena. You can still correlate cells are there, nuclei are there, and that background, everything is there. Once it goes beyond that, like something like PCR based, genetic sequencing based, all those things, then the problem starts. You will not know. That is the reason why we are telling that. Something else he asked? Yeah, what other thing? Some other question was there. I missed it. Anything you can ask.
Thank you, sir.
Wild type, it's like this. By default, normal is wild type. Okay. If you can extremely extensively work out and rule out any kind of mutation, only then you can commit it as wild type. But problem is, it's always like this. Everyone is comfortable with peripheral smear interpretation. No? If it is positive malaria, you are very confident. Patient has fever, you call it as negative, how much will struggle, is it not? In the same way, if any mutation comes positive, you're confident. If some mutations are negative by the available studies, you are still not confident to call it as wild type because you don't know whether you have detected the entire mutation spectrum. So many rare mutations. That's why the problem is in the negativity. To commit it as wild type. Only things you can tell it as these many tests, what you have done, it is negative. But however, sequencing, whatever known mutations by sequencing, you are not detected. Presumably, it indicates wild type. Like that, you can tell. But that always, then danger is always there because, especially in this present era, if you subject it any tissue for NGS, you'll get variety of variants, which will be extremely confusing. That's why I told you out of the box. So it's all a challenge. Negative decision is always a challenge.
Thank you so much, Nandi sir. And thank you so much, Kishan sir, for upgrading our knowledge about the newer entities and molecular updates of current WHO 2021, and reinforcing that we have learned with his excellent collection of cases. And that has made us to glued to those cases, because those were very interesting cases, sir, which we came across. And then I would request Ma'am Sai Chandana ma'am and Jayashree ma'am to give this moment as token of appreciation. I request Dr. Reshma ma'am to give token of gratitude to our moderators for the session.
Thank you all for your active participation, and you had a pre-test by Dr. Kumar Guru. I hope all of you have filled the post-test form as well. And as we are having, the samosa, and I think the beverage will be served with it. The last session for today will be only for the postgraduates. So I request the staff not to participate. So I'll be posting a Google form on your group. Okay, so that will be a quiz. So no discussions. Each of you, answer. Maybe you can split. Don't sit together. No discussions. You can split up. Please move. We have enough chairs. Doctors in the last row, please. You can split in. First. Even PSPG split up. It's for you guys also. All of you to split. No discussions. Attempt on your own. There are a couple of instructions for the quiz. All of you settle down. Yeah. So there are a couple of instructions. So definitely in the quiz, I need your name, your institution, so that I can identify the scoring. And there are 20 questions. Okay, some are all are multiple choice. Only one choice per question, and all questions are compulsory. And some are image-based questions, and some are straight text-based questions. The others are welcome to see the questions, but postgraduates are to participate for this event. All your data packs are on. Great. Okay. Now I'll post the quiz to the group. Yes. Once I post, you have 20 questions. So I think it's MCQs. Roughly by 15 to 20 minutes, you should be able to complete it. So the questions are live on the group, on the CME group. Have all of you received it? Yes. So now the time is 3:40. So at 4:10 I close. Right? Please start. If you're finished, please hit the submit button and you can enjoy your tea and samosa. Professor Vidya will be here to discuss the answers for these questions. All of you are done? Anybody pending? Anybody left for submission or all of you submitted?
things many of our speakers told while their discussions. I was thinking, I have this question in my MCQ and everybody will answer. You know, sitting there, I was thinking there might be tiebreakers. I should have had some extra questions and all that. You know, because most of it was told by our distinguished speakers. Again, at the outset, I also would like to give a disclaimer or confession. I'm not a neuropathologist. No, this is not at all my field. I have no right to conduct a quiz of this which is exclusively on neuropathology. No. Humble request to Dr. Nandish sir, please guide me. I will be wrong. I might be wrong. I will be wrong because this is not at all my field. I have no right. I have no authority to speak on it. We'll right away start with the first question. Questions were mixed up, some tumors, some infective etiologies, isn't it? Shall we start? Are you all ready? Ready to know the answers? Yes. Again, at the outset, a huge thanks to my department, especially Dr. Kumar Guru sir, our HOD sir, and Dr. Afshan madam, because they helped in preparing this MCQ. They have contributed some questions. Thank you, sir. Thank you, Afshan. Yes, the first question comes here. Which of the following muscle biopsy preparations is most useful for analysis? Frozen section. Sir clearly mentioned in his talk, isn't it? This was a question where I felt, I have asked this question and everybody will answer. Sir used something, not just frozen section. He called it something. What is that? Very good. He told he has to snap freeze the sections. It's different from the routine frozen sections, isn't it? Are you all exposed to frozen sections? Is there frozen section in your colleges? Yes? Yes? Very good. Are you doing this? Are you doing the muscle studies? No, isn't it? I think it's exclusively done in centers like NIMHANS, but then one of the indications of frozen section is to study enzyme histochemistry, apart from studying the fat. And so many indications are there. Apart from that, apart from knowing the margins and all that, non-onco indication of frozen sections, one of them is this. And the correct answer is yes. Why? Why frozen section? Why? Because histochemistry, immunohistochemistry, and all this do not require fixation. It will destroy your enzymes, isn't it? So that's the reason why we want paraffin section cannot help you in knowing the rimmed vacuoles or lipid storage in storage disorders or some abnormal structures like nemaline bodies. Electron microscopy is useful, but it's not to be done for as a screen, but yes, for confirmation. Teased fibers is used for nerves. Here, I have a question for Dr. Nandish sir. Sir, is it done now or is it obsolete? You know what this teased fiber is? I am hearing it here only for the first time. It seems something you tease the nerve and you study individual nerve fiber. Is it so, sir? Is it being done, sir? Can you enlighten?
Now it's almost stopped. Very few research centers are doing abroad. Some one or two which I had visited and discussed. Yeah, basically the procedure is like that. Epoxy embedding, epoxy resin embedding. The way we embed for electromagnetic, same thing, but we will not solidify it. And I have not done personally, but I've seen being done. You tease very meticulously with a dissection microscope, individual measure. Mainly, then you have to again see under dissection microscope to see segmental demyelination only. But you have now very good stains for myelin has come. Now the electron microscopy itself is enough. The ultrastructure itself is enough. It's now almost in
Almost
India, nobody is
obsolete.
doing except in few research centers.
Thank you, sir. So it's an obsolete test which is not done. Nevertheless, we should know, isn't it? You should never forget your roots, isn't it? Yes, that is the reason why it has been asked there. Teased fiber test. Yes. Invasion of non-necrotic fibers. How many of you have got that question right? Many? Many? All should have been the answer, isn't it? All should have got it done. Yes, invasion of non-necrotic fibers by inflammatory cells is a feature of. What is the answer? Polymyositis. Very good. You people are very well informed. Why so? Non-necrotic fibers means normal fibers, isn't it? That tells you that there is destruction of normal fibers. What is Hashimoto's thyroiditis? What is Hashimoto's thyroiditis? Autoimmune disease. What do you see there? You see lymphocytes eating up your thyroid cells, thyroid follicular cells, isn't it? Normal thyroid follicular cells are eaten up by your lymphocytes, isn't it? What is the nature of the disease? What is the pathogenesis of thyroid? Hashimoto's. It's an autoimmune disease, isn't it? So autoimmune diseases are known to destroy something normal in your body. By lymphocytes, polymyositis is thought to be an autoimmune disease. Is it, sir? Yes. So you get to see destruction of normal cells by lymphocytes. Which type of lymphocytes? CD8. It's cytotoxic type of delayed hypersensitivity, which is mediated by granzyme perforin mechanisms. Yes. And it seems even the inclusion body myositis also shows non-necrotic fibers being destroyed by CD8 positive cells. Sir mentioned about some skin lesion in dermatomyositis. Who remembers it? Can anybody tell? Huh? Skin lesion in dermatomyositis starts with G. Yes, Crotons, blocks. And McArdle's is a storage disorder, and you get degeneration over there. This was beautiful question. T1 bright fluid filled tumor that occurs within the third ventricle, and it seems it can kill somebody. Look at that. You need not have the tumors always being very aggressive, malignant to be killing a person. Lesion as innocuous as this? The answer is, as somebody told, it's a colloid cyst. A lesion which is as innocuous as a colloid cyst can kill a person. How? Because of the location. Brain tumors, that's how they stand out. Compared to any other tumor, any other site, wherein the organ can withstand something in the brain more than the size of the tumor, more than the nature of the tumor, it is the location of the tumor which is important, isn't it? Colloid cyst, why it kills? Because of the strategic location wherein it can impinge on vital structures. It's seen in adults, a foramen of Munro. That's the reason why it can impinge on vital structures and it can kill them as well. LCH is seen in children, seen in hypothalamic region. Epidermoid cyst is seen at the CP angle. It seems melanocytoma is a meningeal tumor. Among the given options, the best one is colloid cyst. Well, this was the question, which intrigued me. I was taken away by this question in the sense, lesion as innocuous as colloid cyst can kill a person, isn't it? Not so good. But sir, have you seen any cases of colloid cyst in your practice? Is it common? Colloid cyst. Is it? Oh, I didn't know about it anyway. So beware that you can get some such things also. This was a beautiful picture, special stain, which was again forwarded to me by Kumar Guru sir. They have used hematoxylin, floxin, safranin stain to highlight the collagen, it seems. Why this stain specifically? I don't know. I don't know. We have so many stains routinely used to demonstrate the collagen, but they have used hematoxylin, floxin, safranin stain. It's spectacular. All thanks to the stain. It's giving a spectacular view, isn't it? That's why I kept this slide. Look at this cyst. Such a sober looking cyst has a single lining of some ciliated columnar epithelium, some content which is pink. It seems is pus positive, and the wall has some fibrocollagenous connective tissue. Why the name colloid cyst? Probably the content looks pink like colloid. That could be the reason as to why it's being called as colloid cyst. So that was, yes, retrovirus positive person, motor deficits with cognitive decline and visual loss. Neuroimaging details have been given, and the cerebral white matter has been studied. It shows some cells. What are they? What is your option for this? What was your option? That side? A, root swell. Here? B, C and D. Okay. Here? B. B, okay. B. A. Okay. Many are for B, and the answer is, B is correct. It's a case of multifocal leukoencephalopathy. What are you seeing there? Why is it so? So what is this? Progressive multifocal leukoencephalopathy is seen in immunosuppressed people only, not in you and I, though we have the virus. It's called the JC virus. It's harmless in you and I, but it's a AIDS defining illness. It can lead to all those degenerative diseases and relentlessly death ultimately. What are we seeing there? These are supposed to be those degenerated oligodendrocytes with some inclusions, ground glass oligodendrocytes they are called. And you do get to see such bizarre looking astrocytes, it seems, which you may confuse for a tumor. That's the reason why you should know about it. Many mimickers, yeah, one of the mimickers is PML in the background of immunosuppression. In the background of, yes, beware. In immunosuppressed patients, beware of diagnosing tumors. You have many mimickers like this. This was, I think, spotter, isn't it? Again, a mimicker. Radiologists will surely call it a tumor. Which tumor? The two high-grade astrocytoma. Why? Why? It seems in radiology, it produces a ring-enhancing lesion, which we talk of with respect to which tumor? Glioblastoma. Again, a mimicker for tumor, that to a high-grade tumor, but intently we have to concentrate on these structures which lie in a cystic space. What are these? These are the bradyzoids. Toxoplasmosis. Certainly it is not mucor. We all are aware of mucor. We are not seeing any hyphae there. Cerebral malaria. Can it be cerebral malaria? What do you get in cerebral malaria? Can anybody? Anybody, you get some specific granuloma there. Durex granuloma, I think so. Anyway, you get a granuloma, it goes by some name. I call it as Durex. Sir is calling it as Dirk. Find out what it is. Rhinosporidiosis. First of all, I don't know if you can get it in brain. I don't know if this option is correct at all. Anyway, you are aware of rhinosporidiosis as well. How many of you have written toxoplasmosis? Many? Very good. Yes. Cerebral toxoplasmosis. The imaging calls it a mass with ring enhancing effect, which they also see for tumors. So the DD for them is it ranges from primary CNS neoplasms to metastatic disease, whatever. Sir was telling in the morning, radiologists can give DDs, clinical people can give DDs, we can't give DDs, isn't it? Pathologists can't give DDs. Why? Why? We also can give DDs. Yes, biopsy is a must to know the exact diagnosis. Serology will not help because in asymptomatic people like you and I, the serology may be positive. Remember the bradyzoids. You know what? These are all your exam slides. That's the reason why I picked up. Yes. All of you be ready for water. Time to munch some chocolates. Get some chocolate now if you spot this diagnosis. Anybody? Spot the diagnosis. The PGs. Huh? Yes. Very good. Why and how? It's called neurocysticercosis caused by, what is it? Is it an adult worm? Larva of Tinea solium, isn't it? The poke tapeworm. Yes. Again, exam slide. That's the reason why it's been put up. This is again a very easy slide. Neural nodule in a 13-year-old with the options given. What did you make? What did you make? Pilocytic astrocytoma. Why? Based on that, what is the histology? Didn't the histology help you? How did the histology help you? Did it help you at all? People are busy talking. People are busy talking. Did the histology help you in identifying the lesion? Hey, the histology is very classical. Yes, hair-like. See, the moment you see those hair-like structures, you know, the name for the tumor comes from there only. Pilonidal sinus. Pilonidal sinus. We have heard of? Pilosebaceous unit. Pilar tumor. All these point towards hair. And here, because these tumor cells have hair-like projections, they were called as pilocytic astrocytoma. And it is at classical location, age fits into, and the gross also fits. It's a cystic lesion, mind you. The right answer is pilocytic astrocytoma. Again a childhood tumor. Case of tuberous sclerosis. Some syndromes which you should know in relation to CNS tumors. Neurofibromatosis, von Hippel-Lendau. What do you get in von Hippel-Lendau? What is more common in them? Huh? No. Let the PGs. Huh? Very good. Who told that? Very good. Cerebellar hemangioblastomas are very common in VHL, von Hippel-Lendau syndromes. We are talking of tuberous sclerosis, which also shows some predilection for CNS tumors. So, which among these? Very good. On what basis? Age, history, yes. Causing hydrocephalus, yes. What about the histology? You get to see the sweeping astrocytes. It seems, I do not know, and it seems prominent nucleoli is a clue. Am I correct, sir? Please. Yes, says Dr. Nandesh. There we are. So it is Sega. I like that word Sega more than subependymal giant cell astrocyte. Is there a giant cell there? Is there a giant cell here? Looks like, isn't it? So it's Sega. Again. This is a spotter again. What is this? In 18-year-old. What is it? What are you seeing there? Who told the answer? Somebody uttered something. What is it? Medulloblastoma. Medulloblastoma we know as what? Isn't it? Is it small? Medulloblastoma will be all small blue round cell tumors will be blue looking tumors. This is such a pink tumor. Very good. So, ependymoma. The answer is ependymoma. You're correct. You know why I chose this question? Why I chose this question? What is the basis? I want all of you in the hall today to know exactly what is rosette, what is pseudo rosette. No more confusion at all. That was the reason why I selected this. So what is this rosette now? What type of rosette is this? Pseudo rosette. Why is it a pseudo rosette? Around the bread, perivascular rosettes are called pseudo rosettes. And what are true rosettes? True rosettes? What are true rosettes? You will find them around an empty lumen or, yes, isn't it? Now, sir is busy talking. Nandish sir, sorry. Can you clarify to our students and to us also, what are these pseudo rosettes? Why at all it is called a pseudo rosette and why are true rosettes true? What is so truth about them? If you can, sir.
Rosette means a flower-like, which has a nice distinct center and peripheral or petal-like projections. So either you should have a different element in the center or a lumen. Okay, if nothing is there, different element means not vessel. It's a true element. It should be a true element. Whether you should have a true element or a lumen, only then it is a true rosette. All other things, whatever comes in the center, like you take homoerate rosette, only fibrils which are in the center, which is extension of the same cells. Where vessel which is already there, it is so no doubt about it. Only when you have a lumen or a different structures, only then it's a true rosette. So only the flexor interstitial ependymal rosette, they are the one which belongs to true rosette. Now, why you get rosette in commonly in ependyma is why not others? Because in ependyma there is some polarity. If you see, they are the ventricular lining cells. One side is the glial anchoring, other side is the nucleus, the columna. It's a specialized glial cell. So if you just arrange these cells around blood vessels, same anchoring will they be there around the blood vessels. So that's why you get a nuclear zone there. That's why you get. But actually, if you see, when a small medulloblastoma, this all we discuss are all straightforward cases in these sessions. But in practice, only few cases will be straightforward. Majority will be the non-straightforward. Any infiltrating tumor around the blood vessels, which is whether it's glial or non-glial, can show vague rosettes. Best example is medulloblastoma. When Madam was taking, I was thinking same thing. Medulloblastoma, you see infiltrating front, it gets admixed with the glial cells. And because of that, some kind of vague arrangement of the blood vessels, it can mimic ependymoma I grade, especially in small children posterior fossa A group. All these are practical issues, but you should be very, very open enough to accept challenges in every case. This exam actually, after passing out, we'll feel that we have been, it's a great feeling after we get degree, everything. But I feel every exam is a test. I mean, every case is a test, a real test, which can disturb us like anything. Okay. So be very open.
One more thing. Is it a big blunder if they call a pseudo rosette a true rosette, a true rosette a pseudo rosette? It shouldn't matter, isn't it? But I see many places, everybody asking pages, what is a true rosette, what is a pseudo rosette? Papa, every time they get confused. It seems in true rosettes, in that flexor interstitial of retinoblastoma, it seems those rosettes are around a central canal. It seems that they are trying to recapitulate a ventricular system. So they are called true rosettes. But then even if there is a neuropil also, they call it a true rosette. Anyway, can you get true rosette in ependymoma? Is my question. Can you get a true rosette in ependymoma? Huh? Or is it always a pseudo rosette? Yeah. Please say yes or no. That's all. If you say yes, okay. No, still okay. What is it? Yes or no? Yes. Huh? Okay. Are people sitting in this row? Is it an yes or a no? Huh? No. Answer is a yes. You do get true rosette, sir. Can we get true rosettes in ependymal? They are called as ependymal rosettes. Books call them as ependymal rosettes. They are the rosettes around a central lumen, but they are not called as flexor intestinal. I don't know why. Anyway, remember you can get both pseudo and true rosettes in ependymomas. Spot the diagnosis again. Fast. Be fast. Huh? Very good. Who is that? Who answered? Can you tell your name? Mehboob, round of applause for him. Do we have chocolates? Do we have chocolates with us? He will get a chocolate now. Yes. So the classical location of phylum terminale, you should never forget. Again, an exam slide. Spotter. Yes, it's beautiful. Beautiful to see this. This was a case of intractable seizures in a 23 young woman. You find a partially cystic but well circumscribed tumor in the temporal lobe. Any intractable seizures, you find the lesion in the temporal lobe. Okay? Yes. Histologically, they found a glial neoplasm. It showed some bizarre nuclei, large cells, it seems, foamy cytoplasm, spindly cells. But then, though the cells were bizarre, there was no necrosis. It seems there was no mitosis. And there was no microvascular hyperplasia, which they have done to rule out which lesion? Which one? Which one? Mitosis, necrosis, microvascular proliferation. Isn't it? So that is ruled out. Then what is it? Cells are so bizarre. What is it? Very good. It is the options are given. Among the options, pleomorphic xanthoastrocytoma. Have you heard of? Listen here. Have you heard of symplastic leiomyoma? Have you heard of? What is it? It's the degenerative changes in the leiomyoma. You get to see bizarre cells, but then no necrosis, no mitosis. Ancient schwannoma. What do you see? Again, bizarre nuclei, no mitosis. The moment you see bizarre nuclei, always search for mitosis and necrosis. You have to make a positive, active comment on that. The moment you see bizarre cells, okay? I think it's akin to those kind of situations in this pleomorphic xanthoastrocytoma. We can, I think, take a simile from those lesions. The answer is pleomorphic xanthoastrocytoma. How does it get its name? What are xanthocytes? Xanthocytes are those lipidized astrocytes. Do we get to see them in all? No, not. No, not. If they are seen, the life is made easy. Our life is made easy, but that's not to happen. You hardly see them, very rarely see them. You very rarely see them. Even then, it's called as xanthoastrocytoma. And because of the pleomorphic cells which we are saying, it seems you get to see something called as eosinophilic granular bodies in the cells which are PAS positive. Some of these stains, special stains, are of very much use in CNS tumors. Your PAS and the retic stain. Yes, so it's GFAP and S100 positive, it seems. I don't know. This was again nice question. A nice question. I liked it. Loss of function of which gene predicts something? Prognosis in anaplastic. What is your answer? P53. Anything else? Anything else? Why not EGFR? Why not P16? EGFR, P16, P53, or none of the above? What is your option? What is your option? And the right answer is yes, it's none of the above. You know why? You know why? All those are spoken of in astrocytomas, isn't it, sir? Yes, we don't talk of them in oligodendroglioma. But then what do we talk of? What do we talk of? I want you people to tell. Time to collect a chocolate again. Signature of oligodendroglioma. Co-deletion of 1P, 9, 9Q. 9, no, it's not 9. 19, isn't it? That is the molecular signature. Not only that, it also, it seems, tells about the good prognosis of the tumor. It's a good prognostic marker as well. Co-deletion of chromosome 1p19q is the molecular signature, and it decides the survival. They have long survival, good response to chemo and radiotherapy. And these are all P53 and all are talked of in astrocytomas and not oligodendrogliomas. Okay, this was again a big question. If you had patience to read, please read it again. I know the answer. I'm straight away going for the answer. Some dura-based, it seems, and it has some admixed spindle cells, ganglion cells, and admixed in a reticulin-rich stroma. What does it tell? Reticulin-rich stroma. Speaks of what? DNET? Need not be. ATRT? Not the description. Pleomorphic xanthoastrocytoma, we saw it just now. We are left with desmoplastic infantile ganglioglioma. You know, the moment I read that reticulin rich, that should give a clue to you that it is something to do with desmoplasia. That's how I looked at it, and I don't want to read that long history again. I think that's correct. The answer is desmoplastic infantile ganglioma. Sir, as I was reading, please be seated, sir. I read that it's not so very common tumor.
Yeah, just you nicely framed. What I wanted to acknowledge is the description in the case only. Very young child, infantile, and reticulin desmoplasia, ganglion cells, nicely spin. Only thing is it may show small round cells which can mimic higher grade. People may mistake it for an embryonal tumor. That is the only component. And cystic change will be large. And large lesions, it will come quite rare. It is massively cystic. This is one thing which you should have. Yeah, rarely. One thing is we cannot extrapolate our case because referral nature of the hospital. No, so though we say it's related, we are seeing that doesn't reflect in the general population. It is rare like that.
So the textbooks mention that it's a rare tumor. Could be. Anyway, know that something exists on this earth, and it is called desmoplastic infantile ganglioglioma. Yes. Yes, again, intracortical mucin-rich nodules. It seems ganglion cells floating in mucin pools. What is the answer? Which one? DNET, DNET. DNET was a very pet question when I was doing MD. It was frequently asked as a theory question. That's why I chose this. It seems people are, the answer is of course DNET. People are still not sure whether it is a tumor or a developmental disorder, it seems. So you get to see a lot of mucin pools, and this is how the tumor looks. It seems you get to see a lot of cystic spaces filled with mucin, and you get to see those cells floating in. Yeah, mucin-rich tumor in an adult, in a, is it adult or adult? Do you get it in adult? Child. Think of DNET, not PNET, DNET, DNET. Yes, chordoma and chondrosarcoma, we want to differentiate. How do we do? Is S100 helpful? Is cartilaginous differentiation helpful? Vimentin positivity, or is it cytokeratin positivity? Which among these can help you differentiate these two similarly looking tumors? Vimentin is the answer by some. Anybody else? Any other answers? No answers. No other answers. How can it be? How can it be? Take a chance. Take a chance. Doesn't matter even if you're wrong. Our students, RPGs busy talking. Guru, cytokeratin, excellent, very good. It is cytokeratin. The answer is cytokeratin positivity. While taking class, Sir, Nandish sir made a sweeping mention of one more specific marker for these tumors, chordomas. Can anybody tell? Specific. He made a very sweeping mention. Huh? No? Huh? Brachyury. Yes. That is a specific marker for chordoma. Is it used, sir? Yes. We do use it. This is again a very good question. I found it very interesting. What is that which you do not see in an atypical meningioma among this? What is it which you do not see? What is that? Which option? Huh? Yeah, please tell something. Yeah, you want to go home or not? Fast. I want to leave you all soon. That's why only 20 questions I chose. Yes. Yeah. Whatever you have written there, you can tell at least. Hey, Nandi sir is going. Okay. 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 Anyway, our Kumar Guru sir is there. Hey, what is your answer? Sheeting. Oh. Sheeting, I'm afraid, is not correct. Anything else? Huh? Yes, it is the large cell change which is given wrongly there. It seems in these atypical meningiomas, the cells can actually become small, lymphocyte-like. Lymphocyte-like. They lose that Orling pattern and become sheet-like. They may show necrosis, geographic necrosis. They may show prominent nucleoli. So the wrong answer given there was large cell change. What is it? Otherwise, it is small cell change. See that? Prominent nucleoli, yes, you can see in atypical meningioma. Sheeting, yes, you lose that. You will lose that wall-like pattern. Instead, you may get sheets and sheets of cells. Geographic necrosis, yes, you get, but you don't get large cells. You get small cells. What is this? Yes. You want to read? You have read? You should tell us. It seems in an squash, they saw some cells which had reniform nuclei with prominent nucleoli and some cytoplasmic inclusions which were pink. Which of the following is incorrect? Not the correct, incorrect. Majority die within a year. Is it correct? Is it correct? Huh? Yes, they do die. Frequently express EMA? Yes. Difficult to differentiate from medulloblastoma? Yes. So the wrong one is the odd man out is associated with mutations in P10. No, it's not. What is it we are talking of? What is this we are talking of? Can you give me the diagnosis? Yeah. Huh? No, it's not medulloblastoma. Very aggressive tumor. Another tumor, which is a sinister. Wherein you get to see this. And the correct answer is no. Yes, associated with mutations in P10 is wrong. It's not associated. This P10 and all we don't talk here. What is the diagnosis? Diagnosis is, yes, it's atypical teratoid rhabdoid tumor is what we are talking of. And how does it look? This is how it looks. Look at these cells, quite large. They have eccentric nucleus, abundant cytoplasm. It's what they're called as rhabdoid cells. Only thing is they're not showing that pink inclusions in the cytoplasm. That is I think that's the histopathology, but then more pink looking tumor. So remember ATRT, what is the genetic abnormality? INI1 is lost. SMARC A4 gene is mutated and they don't synthesize INI1. INI1 negative tumor is ATRT. Again, very easy one, isn't it? What's your diagnosis? Hey, PGs, look at the cells. They're self-explanatory. They're talking to you. Yes, it is lymphoma. Why it is lymphoma? Why is it not glioblastoma? Cells are looking quite large, but the right image is more explanatory, wherein you have discrete cells in a non-fibrillary background. And the correct answer is CNS lymphoma, which is mostly seen in immunocompromised. And you get to see this cohesive collection of round cells, absence of fibrillary background. That's the reason why, in cytology, you don't concentrate only on the cells. Look at the background. Look at the background as well. Yeah. So the background is non-fibrillary, again, helps you in picking up some diagnosis like here. B or T cell? It is B or T cell lymphoma. It's a B cell lymphoma. Yes. What is this? CT scan shows 2 lesions in the cerebellum. He's a 56-year-old man. What's your diagnosis? What's your diagnosis? Yes. Why metastasis? Very good. Multiple lesions, think of always metastasis. Very good. Some information. Which is the most common neoplasm of CNS? The answer is metastasis. Which is the most common tumor of your bone? Bone? Again, metastasis. More than the primary, it is the metastatic tumors which are more common even in bone. Similarly, in CNS, it is the metastatic tumors which are more common. The primary CNS neoplasms in an adult, it seems, are astrocytomas in children. And the second common is meningioma. In children, the solid tumors are medulloblastomas. Cystic tumors, most common cystic tumor in children. Pilocytic. That's all. Okay. So remember this. Then reticulin stain is useful in all of the following except. What did you write? The correct answer is C. It seems in this you cannot differentiate. That stain will not help you much. But it does help in all other, especially in pituitary, normal pituitary versus pituitary. See here. I have that example for you. See here. This is normal pituitary. Around each acini, you have the retic highlighted. In hyperplasia, that is still retained, whereas in tumor, that is lost. Look at the retic haphazard, isn't it? That is a sign of tumor. That's how retic stain helps you. This again, sir spoke in his talk. What is the answer? MN1 gene altered in A. In classification, sir mentioned about it. Astroblastoma. Sir told about it. It's a new classification. Astro, remember, at least from now on, you will remember M1 gene is mutated in which tumor? Astroblastoma. What grade is this tumor? High grade. No grade is given according to WHO, is what sir told. Is it, sir? Am I correct, sir? He told, sir. This question was sent by you only. Yes. So it seems it's not graded. Astroblastomas. Last question, membrane-bound collections of, what is the answer for this? B, eosinophilic granular bodies. But then it doesn't end there. You should know what are those polyglucosan bodies. Where do you find them? What are Rosenthal fibers and what are Negri? Where do you find Negri bodies? Yes, sir will agree with us. I think that's the end of it. Thank you. Who am I? Who am I? Ask the personality over there. Who is he? Who is he? Huh? Hey, take some guesses. Who is he? For everything options, I thought I will not give. Take some guesses. Is he Pasteur? Louis Pasteur? No. Is he Fleming? No. Who is he Newton? Why will I take Newton here? Who is he? Who is he? Yet some disease goes by his name. Disease of dementia. Ma'am could answer. Yes, he's Alzheimer. Good round of applause for Alzheimer. Alzheimer, not me. Thank you very much for your patient listening. Thank you for the participation. Thank you.
Wow, ma'am, that was a brainstorming session. Thank you so much, Vidya ma'am. I would request Dr. Kumar Guru sir to give the memento as token of appreciation to Vidya madam. Ma'am, please.